give the appearance that we're organized here as the Recovery Council. So first of all, I want to say welcome everybody and thank you very much for spending your time with us. And we value what we are going to learn today. And again, as a council, we have collected other data from other pieces of information, but today we're going to gather information, valuable information from the public as to how we will dispense the opiate settlement dollars that we have. So the first thing I'd like to be able to do is to introduce the people that are sitting at the table with us. This is the Recovery Council, and I think Eric is missing. Eric Smith is actually away at an FBI training school, but the rest,
Dr. T.
Oh,
Eric and Dr. T.
What did I say?
Eric Smith.
Eric Smith. It's an S. Eric Small. Sorry. All right. So I am going to ask people to introduce themselves to you and who they're affiliated with, so you know who they are. You want to start at this end?
Sure. Oh, it's on. Good morning, everyone. My name is Liz Blackwell Moore. My pronouns are she, her, and I am the Director of Public Health for Cumberland County Public Health Department.
Good morning, everyone. My name is Miles Willett. I'm from Augusta County. I'm a clinical supervisor at an outpatient treatment facility and someone that was personally affected by the opioid crisis.
Good morning, and thank you very much for coming. I'm really anxious to hear what you have to say. My name is Paul Vinsel. I'm an addiction physician. I work at Tri-County Mental Health Services in all of their offices, and I precept at the Family Medicine Residency at Central Maine Medical Center.
Good morning. I am Representative Lydia Crafts from Newcastle. I have the honor of serving House District 46, and I am also a clinical social worker in my other job.
Good morning. Thanks for being here. I'm Gordon Smith. I'm the state's director of opioid response in Governor Mills' office.
Good morning. I'm Pat Kimball. I'm the current chair for the Recovery Council.
Good morning. My name is Joe Everett, and I'm the president and CEO of the Opportunity Alliance in South Portland.
Good morning, everybody. My name is Courtney Gary Allen. I use pronouns she, they. I am an at-large city councilor here in Augusta, as well as the organizing director of the Maine Recovery Advocacy Project and a person with lived and living experience. On Monday, I will celebrate 8 years.
I'm Chastity Toole. I use she, her pronouns. I'm the Northern Maine Director of Harm Reduction Services at Maine Access Points and a person with lived experience.
Good morning. My name is Benjamin Mann. I'm the Deputy Commissioner of Finance of the Department of Health and Human Services.
Good morning. Betsy Fitzgerald, representing the counties and regional interests.
Good morning. Great to see a lot of familiar faces here this morning. My name is Bruce Nodden. I'm with the Maine Reentry Network, and I'm here hopefully to represent kind of the wishes of folks who are reentering the community from incarceration in prison, jail, and other institutions.
Good morning. My name is Todd Brackett. I'm the sheriff in Lincoln County. I'm one of 2 law enforcement officials on the council.
Thank you. Thank you all. So I just want to share with you a few things of housekeeping things to do before we actually get started. So one is, again, we asking that for the purpose of today, if you could put your phones on silent. And then if you have to take a message, could you please just leave the room to take that message? Your comments today will be limited to 3 minutes, and we will time those minutes, and we will politely flash our nicely bright sign that says your 3 minutes are up. We will not stop you mid-sentence, but the thing is, I will stop you mid-paragraph. We're going to try to keep as close to 3 minutes. I know that you have a lot to say, and we honor your comments, but we want to make sure that in this time frame, everybody gets their voices heard. We will stop taking names at 1 o'clock. So at 1 o'clock, the names, we will no longer take names for testimony, but if you've signed up before 1 o'clock and it is 1 o'clock, we will still stay to listen to what you have to say. There is a sign up back that actually, if you don't get the opportunity to testify today, you didn't get here by 1, or that you don't want to stand here in person, we do have other ways for you to do that. We have so up front is our website. There's also our email address where you can submit your written testimony, as well as we encourage you to complete our survey. We're taking information in regards to a survey, and that survey closes today, I believe, at 5 o'clock. So if you haven't filled out that survey, I hope that you will have the opportunity to do that. And all of that information will be collated and given to the council. We ask that you be respectful. We all have different views. And we choose different words sometimes, and we have different ways that we think that the funding should go. Please be respectful of all of that. We appreciate that. The people up here are not taking a break. So they may have to take a short break to get some water or use the facilities or whatever that may be. Please note that they're not trying to be rude to you or anything else. We just are human, and we just need to do that around. If I leave to take a short break, member of the council will take over and in that position. The council will have an opportunity after you give public comment. If they choose to make a comment or ask a clarifying question, they would like to have the opportunity to do that. And I think that's where we are. What we're going to do is call the names in order that you signed up. And we'll ask the person who is next on that list to just come take a seat here. So we'll say the person who's on and the person on deck. But if you're on deck, if you could take one of the reserved seats up front, that way we can keep things moving in somewhat of an orderly fashion. All right. All right. So Courtney's going to be our timer. And I want to make sure that we go to a list. And please excuse me, I'm trying to read your handwriting as well as I will make every attempt to say your name phonetically correct. And if I'm wrong, please, incorrect, please state so when you come up. When you come up, please state your name and who you're affiliated with. So the first person is Susan Savell, and on deck will be Ann Connors. Mm-hmm. I don't think that microphone is on. Is there they're going to work on it? Okay. Is there a button?
It did. I think it's on now.
It's working now.
Maybe I'll stand over here. Oh, well, good morning, everyone. My name is Susan Savell. I am here to share some information about an evidence-based school model for supporting students and teachers known as BAR, which stands for Building Assets, Reducing Risks. That would meet the priorities of this Recovery Council, as well as any of the priorities around substance abuse prevention. BAR is a school improvement model focused on strengthening relationships, reducing high-risk student behavior, and improving academic achievement. It is listed on SAMHSA's National Registry of Evidence-Based Programs and Practices. BAR is not just a prevention program. It's actually a system that creates lasting connections between students, their families, teachers, administrators, and the wider community. It is based on the science of risk reduction, as well as research on positive youth development, and provides a comprehensive approach to both prevention and intervention within a school. For 9 years, I served as the co-director of 2 national investing in innovation grants from the U.S. Department of Education. developing, validating, and scaling the BAR model. These grants were held by Spurwink Services with the understanding that BAR is an effective resource for substance abuse prevention and behavioral health interventions. The purpose of these grants was to test, through the most rigorous research available to us by the American Institutes for Research, whether or not the BAR model would improve academic achievement by reducing the many poor outcomes for ninth grade students, particularly substance use, juvenile delinquency, school failure, and dropout. The results from this research were so statistically significant that in 2014, Spurwink received the Scale-Up Grant to implement this model in 250 additional schools throughout the country. BAR is a system that requires training and support for 3 years for the school, but then becomes totally self-sufficient after everyone in the system has been trained and supported. A few Maine schools were able to implement its strategies for the full 3 years with the research funding, but 27 others only had enough funding for 1 year without the benefits of the ongoing coaching and support provided by BAR for years 2 and 3. BAR is actually a hugely popular model with teachers and administrators, which is just such a wonderful thing because, you know, most schools, their first reaction to an innovation is, oh no, we're already doing too much. We're overwhelmed. We can't take on anything new. But within the last year, so many of the schools that had already been involved in doing the BAR model began to lobby the Maine Department of Education for additional funding so that they could continue to do years 2 and 3. And new schools joined the call for funding for the full 3 years as well. This summer, when the Maine Department of Education responded to this demand and made an announcement that some federal funding would be available to schools that want to implement BAR for 1 year, they received a response from 87 schools throughout the state, 15% of all Maine schools. This response was so dramatic and surprising in many ways that the department is now seeking funds for years 2 and 3 for these schools that have started now with the first year. And the department also wants to make this evidence-based model available to all schools in Maine, eventually grades K through 12. While the research results are amazing, and I am including links in my testimony to many of the reports that you might want to read, what I really want you to know from my heart is that BAR is a comprehensive system that creates a culture of belonging for all students. From kindergarten through 12th grade, teachers work together through the BAR system of data sharing to make sure that no student falls through the cracks, that every student is supported, and that students experiencing very significant stress in school or at home get the focused attention that they need. This comprehensive system of connection is what builds a safety net and is a profound antidote to addiction. So 3 minutes, is that right? So I'm happy to answer any questions you may have. Yes.
I've said this already, but is BAR only located in Maine, or is this throughout the nation?
No, BAR actually kind of started in Maine because the first development grant with the U.S. Department's Investing in Innovation worked with 3 schools in Maine and 1 school in Southern California. So BAR actually has been developed and then validated and then partially scaled in Maine over the last, 14 years.
This sounds amazing. Thank you for your work.
Oh, you're so welcome. It's been my pleasure to work with this program for, since its beginning really in 2010 when Bucksport and Sanford and Noble got the first grants to do this model. And I'm hoping that you will be able to hear from individual school leaders about how this model has impacted them in their school.
Thank you, Susan. I'm familiar with BAR. I know the commissioner is very enthusiastic about it. Can you tell me a little bit about how much money it it would cost to fund years 2 and 3 for the set 87 schools that are now in year 1?
Yes, BAR is a pretty effective model. It's a 3-year training process. It's about $80,000 a year per school for the training. So over 3 years, it's about $240,000. So right now, the department has used some of its federal funding to fund the first year of BAR for, I think it's, 71 schools throughout the state right now. And for year 2, they will need an additional 853,650. And for the third year, they'll meet for all of these schools, they'll need 5 million. But that doesn't count any of the new schools that are going to want to start doing BAR for the first time. So I would say it's probably a little over 5 million that would be needed in the next 2 years. And hopefully there would be more available for schools that want to start this. The unique thing about this program is that teachers and administrators really love it. And so it's a peer, a process of peer sharing about the value of the model, and more schools hear about it, they want to do it too. So.
Could you quickly tell me what does it do? Like, what are you doing in schools with young people?
It's a comprehensive system of what we call 8 interlocking strategies. So the main thing that it does is create teacher teams from the various disciplines that meet every week and have a process of a structured data gathering system that tracks the well-being of every student. And so you get different perspectives from different teachers, so that if something is going on in English or in math or social studies or on the playground or in the lunchroom, the teachers talk about that student and can put their heads together about how to support them. And they gather in, it's a data gathering system, not only from grades and test scores and homework, but also from the observations about the emotional and social well-being of each student. And so it's a process where every student is supported and looked at. And teachers, I think Jim Boothby, the superintendent at Bucksport, said it's teaming on steroids. That at Noble High School, they had been doing teaming for years, but then this particular system, because it's structured in such a way that the teachers meet every week, and they also have a risk review meeting at the end of the week for students that are really high stressed, and that system enables the teachers to really stay in touch with what's really going on with their students.
Thank you for your testimony. Just quickly, can you clarify for me how many schools and what age group? You mentioned 9th graders.
It started out as a 9th grade program because that's the year that students have the most difficulty. If they drop out in 9th grade, the trajectory is very poor for the rest of their high school years. And so it started out as a 9th grade program, but then when schools, starting out in 2010, and some of the schools in Maine, they discovered that they wanted to carry it on into the sophomore year because it was so effective for the freshman year. And then the middle school wanted to do it, and eventually elementary schools wanted to do it. So Westbrook is a school district that now has district-wide implementation of the model from K through 12. The first year that we focused on really was 9th grade because that's so critical. But now many schools in Maine are doing elementary, middle, and high school. I think the other thing is that there's a curriculum component to it, in the sense it's called iTime, where the teachers and the students once a week in each of the what would I call it, the disciplines, actually have time together to get to know each other. And it's a very, very thoughtful social emotional learning process. So, and that's also now been taken down into elementary school.
Thank you. And you said there were 80, did I hear 87, 81?
Yeah, there were
How many
87
schools?
87 schools that wanted to do it. And
How
I
many
think
how many are actually enrolled?
71
71
right now. And the others just weren't ready to do it this year because it takes some organizing within the school to be able to pull it off. But they want to do it next year. So they all want to do it, but it sometimes takes time to get going, to get all the systems in place. So
Thank you.
you're welcome.
All right, thank you.
Thank you.
Thank you very much for
You're so welcome. Thank you.
thank you for your time and the work that you do. Ann Connors, and then on deck is Robert Rogers.
Good morning. I'm Ann Connors from Maine General Medical Center. I'm the director of the Community Health Department. In case you've missed my name tag, my vest, and my shirt that all is branded Maine General. I wanted to thank you for this opportunity to speak for myself, but also for the public at large, and for providing multiple modalities in terms of written testimony, this opportunity, and the survey that's electronic. I also wanted to thank you for your time. I know all of you have busy lives and other things, and I know this is a volunteer role, so I appreciate that as well. The bad news is that we're in the midst of the public health crisis that we're in. The good news is, as the previous person spoke, there's lots of resources out there. We don't need to reinvent the wheel. So I hope that makes all of our work easier. I would say, broadly speaking, we would endorse the 5 principles in the Johns Hopkins outline for how to spend this money. Number 1, spend money to save lives. Number 2, use evidence to guide spending. There's a lot of it out there. Number 3, invest in youth prevention. Number 4, focus on racial equity. And number 5, develop a fair and transparent process that should be led by public health leaders with active engagement of people with lived experience, as well as other key groups. So how do we apply this to Maine? Number 1, direct funding towards organizations that provide direct services to people rather than funding law enforcement or existing DHHS programs. I'm not saying in any way that DHHS existing programs and law enforcement aren't critical pieces and stakeholders, but there are other funding streams that are already dedicated to those efforts that can be accessed. Number 2, ensure geographic spread throughout the state using data and mapping existing community resources. Who is currently providing evidence-based programming in what areas? So the state should be adequately covered. It shouldn't be focused in one geographic area or another. Select some priority interventions. I would argue for prevention, broadly speaking, youth prevention and harm reduction, including syringe service programs and syringes and mobile harm reduction services. There are many resources around youth prevention to draw upon. Drug-free communities have been operated by community coalitions in the state for many years now. There's resources and Surgeon General's reports. There's a lot to draw upon there. Invest in campaigns that decrease stigma, whether that be personal stigma, organizational stigma, or structural stigma, such as within the healthcare system, for example. And number 5, please develop an RFP process and release these funds soon. The Community Health Department set up COVID clinics, mass clinics at the Civic Center in 2 weeks. And we did that because it was a public health emergency, and we worked around the clock to make that happen. This is a similar emergency, and I would urge you to act quickly and to get this money out to the community organizations that need it. And I really hope you don't ask me any questions because I wasn't prepared for that. So I would just like to hand in my testimony and sit down. So, but if you have any questions, I'll try to answer.
Thank you. Thank you. We'll make sure that we get multiple copies of that. Thank you very much for your testimony, your public comment. Next up is Robert Rogers, and on deck is Joanne Woodward and Barbara Skinner. Are you testifying together? Or are you testifying separately? Georgia and Barbara. Okay, it's just your names were on the same place. I just want to know. Okay, thank you. Excuse me. Thank you very much. And if you hear that little bell, that is the timer. Thank you. That's not somebody's phone going off. That's the timer. Thank you very much. Thank you, Robert.
Members of the Maine Recovery Council, thank you for the opportunity to address the vital issue of opioid settlement funds allocation. I am Robert Rogers, the Director of Substance Use Prevention and Grant Services at Kennebec Behavioral Health. I oversee the Prevent Prescription Drug Opioid Overdose Related Deaths Grant for Somerset County. I represent the Somerset County Substance Use Task Force, comprising 33 plus organizations and over 100 individuals. Our priority is to serve Somerset County equitably and transparently, a process that has not occurred to date in our region with already released opioid settlement funds. To achieve this, we propose geographically based councils, inclusive of the recovery community and those working with them. We urge an application process aligning with the community in the, Maine Recovery Council's goals of preventing opioid addiction, preventing and reversing overdoses, and assisting citizens in recovery. Proposals should adhere strictly to evidence-based practices. Strategies offered prior to the onset of a disorder that are intended to prevent or reduce the risk for its development, improves quality of life, reduces crime, decreases suicides, and lowers healthcare costs for acute and chronic conditions. We must use the science of prevention, not what people believe to be common sense approaches to preventing opioid use disorder. Addressing social determinants of health and the root causes of addiction is imperative. Access to reliable and affordable transportation, housing, childcare, food, and access to mental health treatment is crucial. We advocate for ongoing access to free naloxone. Concerns arise regarding over-the-counter naloxone becoming cost prohibitive. Recovery support must include a variety of interventions, many of which are consistent with prevention, and located at recovery community centers, a service not yet made available in Somerset County. Funding for the center is essential. Additional considerations include support for mobile treatment, co-located substance use treatment and daycare services, and a substance use specialist within Child and Family Services. We also emphasize the importance of recovery coaches, proposing compensation through Maine Care or opioid settlement funds. Compensation parity for telehealth services is necessary, particularly in rural areas with limited internet access. Treating people in the way that best meets their needs should not be cost prohibitive. Somerset County requires a locally accessible residential treatment facility to optimize recovery outcomes. People recover best when they are able to be treated in, receive support from, and transition back into their own communities. In conclusion, we urge transparency in spending and emphasize evidence-based, scientifically supported interventions. Funding should serve the greater community in multiple ways. Thank you.
Thank you. Questions from the council? Thank you very much for your input. It's valuable. Thank you. So next is Georgia Underwood and Barbara Skinner. And on deck is Dr. Ron Stankler.
Hi, I'm Georgia Underwood, Barbara Skinner, and we are the Recovery Wellness Initiative in Piscataquis County. We are a 501c3 and we are brand new. So I'm here to talk to you today a little bit about Piscataquis County, and I want to give you a visual. Piscataquis County is the size of Connecticut. We are the poorest county in the state of Maine, and we also have our median household income is $34,000. If you can imagine that. We have around 17,000 residents, and in that we have about 7,800 households. So from what you hear from that, we in Piscataquis County, our recovery services are scarce and few. You would need to travel, depending on your current location, to Bangor or further south of Bangor for treatment, detox, and recovery services. And recovery resources. The travel time and service time could equal a half day of work and or a half day of making arrangements to cover costs of childcare, transportation, and other unmet needs. and I'm a little nervous here. So this is what we do have. We have medical assisted treatment provided by family physicians through our Northern Light Mayo Regional Hospital and C.A. Dean Hospital. One located in Dover Foxcroft, one located in Milo, and one located in Greenville. We do have telehealth services for behavioral health. We have limited internet services. We do have links through Penquist, and that's similar to a taxi service for those that need rides. But the unfortunate thing, the system of links is complicated to be navigated, but someday we'll improve our rural transportation issue one thing at a time. We have one taxi service. However, we do not have Uber, Lyft, vehicles, bus services, walkable paths between towns or bike lanes. So transportation is an issue. There are several AA meetings throughout the county and one NA meeting. These meetings are offered daily, usually at night, and they are scattered through the whole county. That's one a day, 7 days a week. There has been several businesses interested in starting services in our area, such as treatment of Suboxone or counseling in our area. Unfortunately, they have not been able to break ground, and meanwhile, others have left. There may be some groups that I'm not aware of. Okay, so a little bit about us. Recovery Wellness Initiative is a small nonprofit, and it's been working on bringing community awareness and education about addiction to the county plus surrounding towns for the last 2 years. We meet weekly at Central Halls Commons in Dover Foxcroft from Wednesday 10 a.m. to 11:30 a.m. We bring peer-to-peer support. We are recovery allies. We are folks in recovery. We are also affected others. We do this by creating space for presentations, trainings, events, recovery circles, and through social media platforms. We currently offer our services as a cafe, a recovery cafe, and we would like to expand to a recovery community center.
As there is no recovery community center at all in Piscataquis County.
And we'll conclude with that.
So I'm going to take some questions. Thank you. Stay right there. You're in breathe. You're doing okay.
You did good.
Well, I think it's already on.
Okay. Georgia, you did great. Okay. Don't be too nervous. Piscataqua County is very rural. Do you think that a mobile unit that provided MAT, counseling, peer support that would travel throughout the county, different areas on different days, do you think that would be beneficial?
I think it could be somewhat of it, because of the known transportation and all, yes. And that's something that we have talked about as far as a recovery center as well, is having that as a mobile right now. We need to have a space that we can actually be in on a regular basis, that people know we're there. Right now, we're only able to do this 1 day a week for a couple of hours. And the space that we have is across the street from a police station. Not the best place. Folks that are in addiction or recovery, a lot of times they don't have, if they have transportation, it may not be a registered vehicle. They may have warrants. They don't want to be parked across the street from a police station. We want a place that we can be more secluded yet access for folks.
Thank you.
Thank you for your testimony. One app you have that you didn't mention is that you live in a beautiful county. All of us would live there if we could work there and have a job. I'm with the state, so I'm aware that we support that cafe model with the same money that we would have put into a bricks and mortar center. But you mentioned that you don't have a bricks and mortar recovery center, and the governor's committed to having one in every county. I guess my question is, knowing very well the distances between Greenville and Sangerville and Milo and Dover Foxcroft, should we be thinking about a bricks and mortar center in one of those communities versus continuing to support more of a mobile cafe where you can go to different places? I'm interested in your thoughts on that.
Yes, we actually put it in for one of the CDS grants, but we didn't have the nonprofit status at the time. And that was for a building in Sangerville, because we feel that's kind of more central. Because when we say Piscataquis County, Dexter, Cambridge, they're closer to us than they are going somewhere else. And they don't have anything in that area either. So we're looking at a space in Sangerville, and the CDS grant that we put in for was about $500,000. It would have covered the cost of the building, and getting it set up the way that we needed it set up, along with having computers so that we can help with, I'm right now a workforce development specialist for Eastern Maine Development. So to help folks with finding that employment, getting those employability skills, those kind of things, as well as art and recovery. That's important. People can express themselves. So yes, we do need a brick and mortar.
I think I should explain to the CDS is the congressionally delegated spending that we used to affectionately call earmarks. And so those are done through the 4 members of the federal delegation.
Yeah.
I just wanted to say something. I'm in long-term recovery, and I am a long-term resident of Piscataquis County. So in my journey, I went to rehab at Acadia and Bangor. I had a mental health condition as well as depressive disorder. And so I was a single mother with 2 children. And that was really hard to try to do that and work and so forth. So luckily, I'm one of those that I was able to stay there for 7 days. I came back out 9 months later, I was back in. And after the second trip, I came back to Dover, Foxcroft, and came to the realization that, geez, I can't do this alone. What am I going to do? So I was one of the very luckiest people that I know that found recovery through AA fellowship. And I made it to those meetings, and I worked really hard at my sobriety, and I still work hard at it today. And we're looking at 15 years. I was able to go back to school. My kids graduated, and my life has completely changed. And I truly consider myself lucky, because I look around those rooms and I see people come and go all the time. And I wonder where they're going, how they're getting help. And it's just, we can say, yes, we have AA and NA and all that, but it doesn't fit everyone. And so we take that into a lot of consideration at our recovery and our recovery cafe when we talk to people. So when you say mobile, I'm just thinking from personal experience, I don't think it would work. I think that one solid location where somebody could go to a meeting or to receive services or to talk would people would be able to get there.
Thank you.
Yeah. Courtney?
Hi, Georgia. It's nice to see you. And I'm sorry I didn't catch your name, but it's also
Barbara.
nice to see you, Barbara. You did a phenomenal job. My question for you, and I'm getting to a larger question around funding for small recovery community center cafes in Maine. Are you a volunteer or are you staff?
I am staff.
I am volunteer.
Awesome. I'm glad that you're staffed. There's a lot, and I'm glad that you have support from volunteers. You do not have to answer this question, but how much is your annual operating budget?
Currently?
Yeah.
50.
Okay, thank you.
So as somebody in long-term recovery, I do have mental health human service degree background as an addiction specialist, and also have a background in workforce development and community development.
And I have my CADC, 18 years of mental health case management, and now workforce development specialist.
Yep. Thank you for your service, and what a phenomenal history you have. And just for clarity, $50,000 is paying your salary and all coverage of operating expenses.
Yes.
Well, thank you for doing that for pretty much nothing.
Thank you very much. And as someone who is I'm sorry, I know I'm just a summer resident of Piscataquis County. I do know the importance of something more permanent. I know that you have a lot of things that are mobile, including DHS that comes once a month. So thank you very much for your time. And if there's no more questions, thank you.
Thank you.
Dr. Sprengler. And then Jerry Mason is on deck.
Good morning.
Good morning.
Honorable members of the Maine Recovery Council, thank you for your service. I want to take some of my seconds to thank you again for your service. My name is Dr. Ron Springle, a resident of Scarborough and Executive Director of the Maine Association of Recovery Residences, a 501c3 Maine nonprofit organization established in 2016. Our organization's mission is to certify that our operators meet the compliance standards set by our parent organization, the National Alliance for Recovery Residences. Since MAR began, we have grown to represent 73 certified recovery residences with 802 beds in 12 counties. From the start, we have seen the many unmet needs in the continuum of care for substance use disorder. These include transportation, lack of primary treatment beds, and beds for medically managed withdrawal, both acute and subacute, sometimes also subacute, called social model. These so-called detox beds are most critical, as they are the gateway to recovery. Still, one cannot increase one set of beds for treating withdrawal symptoms without a commensurate increase in actual primary treatment and long-term recovery supports, such as housing. Specific to recovery housing, MAR suggests the council consider funding projects and programs that would do the following. 1, temporary or respite housing. MAR operators are constantly facing the dilemma of what to do with a person who has suffered a recurrence or can't pass a urine drug screen for entry. 2, fund MAR's Bed Scholarship Fund that allows a person with no funds to enter sober living for the first 30 days of their recovery journey. 3, fund research to determine recovery housing best practices in Maine to guide operator strategies to best improve the recovery capital index of the residents. 4, ADA accessible residences. Provide funds to convert an owned residence to become ADA compatible. 5, support a recovery resident safety fund to support installation of fire and life safety equipment in certified recovery houses. 6, support the MAR Safety and Wellness Program that has proven to save lives. 7, provide seed money to aid new operators to establish recovery residences in the 4 underserved counties. 8, fund peer recovery coaches to work with all recovery residences. In addition to the above, MAR generally supports 9, funding medical education programs to help reduce stigma among providers and first responders. 10, fund programs to support grandparents raising their children's children. And that's courtesy of our MAR board member, Carolyn Delaney. Thank you again for your commitment to recovery in Maine. I have a few seconds left, I guess, for questions if there are any.
Thank you very much.
You like that? Yeah, thanks.
He's done this before.
You taught me how to do testimony, so.
Thank you, Dr. Springle. Thank you for your work. It's important, and you've done it since I started on day one. It's going to be a tough question for you. We're not going to be able to fund not 8 of these things.
Right.
I'm not sure, maybe you said it and I missed it, whether these are listed in the priority for your organization or not, but if we could assist in 1 or 2 of these areas, what are the 2 most critical?
Thank you, Gordon, for asking. They're sort of in order, although a poll of the board was not taken, only a request for their ideas, some of which are incorporated. Respite housing is really critical. We're losing people, we're losing lives because of the lack of that. As noted in the fine print, Florida has recently opened 5 respite houses throughout their state, 5 for the state of Florida. Now, could we do with 1 or 2 in Maine? Yeah, we probably could. Access to all residents.
Thank you, Pat. Is this on? I think so. Okay. Thank you, Ron. I appreciated that you submitted this early, and I did read it this morning, and I appreciated that it fit on 2 pages. It made me very happy. So thank you. I do have a few questions for you. The first question, and if you don't have the answers off the top of your head, feel free to follow up with them. The first question is on the number 2 bed scholarship fund. Could you provide us with a little bit of data about where this is going right now, who it's serving? Is it geographically distributed? Who is it serving? Do you have any demographics, etc.?
Well, we actually do have that data. Thanks for asking. MAR actually operates 2, call them scholarship funds or bed subsidy funds. One is through funding from the OBH, which actually funds state beds for up to 60 days a person throughout the year. So that's 90 state beds are funded, and that's spread out among our operators. That's a lot of beds. You would think that would meet the demand for people that can't afford to the initial first month's rent or whatever it might be to move in. It hasn't been. The Bed Scholarship Fund, which is money that MAR raises, not from the state. That's money that we raise for the film festival and other efforts. We raise net about $30,000 for the year. We're finding that if we parse that out, 5 or 6 scholarships a month, we open on November 1st and we close. We've already got 7 applications. We'll probably close by the November 3rd or 4th. That's the demand. In addition to the other beds that are being supported, I have to tell you, frankly, it surprised us. But until we started operating both of these programs just since July 1st, we had no idea the demand was so excessive.
Okay. And could you, if you have that data available, could you follow up with like where it's going, demographics, age, gender, etc.?
We actually have all that data.
I love data. Thank
Okay.
you, Ron.
You bet.
And then a follow-up question for number 7, seed money for new operators to establish recovery residences in underserved communities. I'm curious about special population houses. I know, like, I'm thinking about LGBTQIA+ community housing, as well as BIPOC or Indigenous housing. Can you give me a landscape of what we have for special population housing in Maine? And I did not say all of the special populations that I've
there's a number. So we know that the Wabanaki Public Health supports 2 recovery residences, and their priority populations are Indigenous. There is one right now, house in South Portland, it's a women's house that serves LGBTQIA+. We're calling it Q+, just so I can say it properly. There are several residences now that are accepting women with children. A new one just opened that's accepting women who are involved in reunification with their children. The children specifically won't be living there, but they could be, and that's just opening like right now.
Wonderful. Thank you so much, Ron. Yeah, those are the 2 that I would be most particularly interested, with the caveat of special populations or otherwise not served in Maine. Thank you.
Hi, Dr. Springle. Thank you very much. Can you explain to me how a temporary or respite housing works and who would be the type of person that would use that?
Thank you, Dr. Vincent. Dr. Vincent. That's a really good question. It's not a single population that would use that. It could be a person who's experiencing homelessness that wants to enter recovery housing, but they can't pass a urine drug screen because maybe the metabolites are in the system for so long that that it may take them weeks to be able to clear a urine drug screen. Not appropriate yet for social model. They may need some medically managed withdrawal. It can be holding for people that are trying to get into a detox bed. It could be for people that have experienced a recurrence in a recovery house, and maybe it's their second or third bite from the apple, we might call it. And so their continued residence there is really detrimental to the rest of the home being a social model experience, but they may not have a viable place to go while they figure it out. Like, okay, I'm continuing to use, I need to get back into primary treatment, or I need to get into a recovery house that is more structured, or one funded by Maine Care, like a level 4 house that actually provides treatment. And we have 3 or 4 of those, but those beds aren't available at any moment. I mean, that's part of the problem we all know about. So respite house is like temporary. Again, short term, 3, 4, 5, maybe 10 days. So a person can get support, get some case management, have housing and food and a plan for what they do next. And we know that people leave recovery housing and they perish because they have nowhere else to go. They may be in their car. We find them deceased in their car or in an alley, or you know the rest.
And so the goal for those people would be to, in that time within the respite housing, would be to develop a plan for more permanent housing or something afterwards.
Well, it could be transitional housing, a more permanent transitional housing. I know that's almost an oxymoron, but I look at transitional housing as a longer term. This is really not that. This is short term, almost emergency housing. You can think of it like that, but specific to these populations that are interested in recovery, not just looking for a place to crash, who are interested in figuring, who need like a timeout. Okay, my best efforts got me kicked out of this sober house. All right, what do I do now?
Yeah, I think of some of my patients who have had to leave sober living for a period of time because they did have a return to use or slip, and then ended up being in their car for a few days before they could get back in.
Okay. Yeah, we've had deaths reported in that case. Yeah.
Ron, thank you very much. You know that I admire the work that MAR does, and we're very thankful for your presence in the state. My question is probably 2 questions in one. One is the OBH funding that you're receiving for the HSSP program adequate for the demand? And do you foresee OBH continuing to fund this program moving forward?
Thank you, Bruce, for both those questions. I don't have a magic ball about OBH funding, but I am told that it is a reliable source. So we do think at the current level that it should continue after we have a 1-year contract with the Housing Subsidy Services Program, the one you're talking about, HSSP, funded by OBH. Is the amount of funding adequate for that? The funding probably is adequate, but we don't have enough flexibility in how we can spend some of that money. So that becomes a problem. And it is also limited to houses that accept MOUD, without getting into a big debate about that, medication for abuse disorder. If you run a so-called absence-based residence, you're not eligible for those funds. I completely understand it. We're doing more work around ADA training for our operators actually this month and next month.
And I don't want to put anybody on the spot, and I certainly don't want to put you on the spot. But the demand is great from folks who are releasing from prison and jail. And has there been any discussion with the Department of Corrections or other funding sources to support the HSSP program or programs like it. I mean, for folks that don't know, recovery residences are our de facto halfway houses. We really don't have a halfway house program in the state, and your folks and the folks that run recovery residences have taken up, that burden. And I'm wondering if there are other funding sources that you explored.
Well, really good question, Bruce. Thank you. So the State Department of Corrections and the county jails have been good partners. They do get funds from time to time. They will use them till they're exhausted, which happens a lot. When they're exhausted, they turn to us. We've also formed a group of recovery residents support, the funders. There's about 6 funders to help people get into recovery housing. I think a lot of them. Pathways of Hope, the United Recovery Fund associated with Maine Works. We all work together now, which is really a benefit to help best utilize the resources. If you can't help here, you get help here or over there. Do you have money for this or that? There's a lot of that going on. Never happened before. So that's a plus. So when DOC and county grants run out, we have to look for other funders. So, as a matter of fact, as we speak today, one of our philanthropy bankers is looking at helping to fund some of this. So we don't just turn to one source. We've also have applied for grants with Gorman and others, but haven't been successful. We keep trying.
Just a quick question. Thank you for your. Just a quick question. I was just curious if MAR operates any recovery residences. You're just sort of the umbrella group that oversees the certification and the compliance of them. Right. Thank you, Ben. So MAR itself, as an organization, does not operate any recovery residences. Now, briefly, it was formed in 2016 with 6 operators who did operate, and they were the original board of directors. Now the board has grown to 12. It's kind of half and half. So there are still some operators on the board, but we don't directly do that kind of work, right?
No.
Morning, Ron. Out of the 73 recovery houses that you represent, do you know how many or percentage, or if there are any that are self-sustaining or self-sufficient?
Thank you, Miles, for that. So yes, there's quite a number that are self-sustaining. Most of them are. MAR does not provide direct support for their operations. We'd help people get in who couldn't pay otherwise. So the support goes to the applicants or the new residents. So houses come and go. They open and close, and if they have good business practices, they stay open. I know Mr. Scott Parties here is operating 14 houses with like 100 and some beds. You could ask him, but he would say he's self-sustaining. We do have problems we have 4 counties without a recovery residence that any of it we know of, let alone certified by MAR. So that would be Piscataquis, Oxford, Waldo, and Lincoln. Powell, I just call them the Powell counties. That's how I remember them. They have 0. And maybe we'll get something in Oxford soon. But what do we do in the other areas? You can't find recovery supports near where you live.
Thank you.
Thank you, Miles.
Thank you. Thank you very much.
Thanks very much, Pat.
Thank you. All right. So Jerry Mason is up next, and Whitney Parrish Perry is on deck. Hello, Mr. Mason. Thank you.
Hi, thank you. Thank you to everybody for coming. I kind of screwed up when I came in. I signed my name and I didn't realize I was going to speak. So I'm like, okay.
Well, you can, if you'd like to.
That's fine. I'm a member of the Penobscot tribe. I live in Reedfield. And I heard about this on the radio, and I'm like, I'd like to come to represent my tribe. Sorry. My people are my ancestors, and they suffer from opioids. I don't personally have a problem with it, but I'm getting ready to retire, and I'm an off-reservation Indian. So I'm not really familiar with a lot of the people on the tribe, but I know they suffer, and the women suffer. 'Cause But I built a camp in Alder Stream up in Franklin County, and there's not a lot of people there. And I didn't know, I'll be 65 in December. And I didn't know if there was some way that I could help my tribe do something. So I'm not a member of the council. And I don't think the chief may kick me in the butt if he knew I was here. But I didn't know if anybody from the tribe was going to come and represent the people. But I know that during COVID, there was a lot of things that were found out about tribal people. A lot of them don't have drinking water and access to food. And I know the problem is all over the state. I have a cousin that's an attorney, and he works with the tribal people in Caribou, Craig Sanborn. And so he's doing a work for them. He's worked for our tribe on Indian Island. And my Aunt Rose worked for 25 years of her life on the island. She ran a battered women's program, working with the Catholic Church. So I know it takes energy and people step up. People willing to step up. I'm sorry. Did you knock me out?
No, you're fine.
Hello. Yeah. It takes people with energy willing to step up and sacrifice. And when my Aunt Rose passed, maybe I'm the guy, I don't know. Excuse me for getting emotional. I'm just a big sissy.
No, you're not, sir. You're a man with a large heart. And I thank you for that. And I thank you for standing up and representing the people of your tribe and caring enough that this illness is hurting a lot of people that you love. I'll ask if any of the council has questions, but there's people that are here today that can talk to you. And if you get their names and some contact information, maybe you can help by making that property that you have into some sober residents, whatever. I know that the gentleman who just spoke, Dr. Ron Sagler, has information about starting that kind of program, as well as, and I'm going to put him on the spot, I know Scott Parody is sitting in the audience, going to comment today, who's successfully opened. Are we up to 15 now? 15 houses. So there's people here that you can talk to and make some decisions. But sir, thank you very much for your heart and for how much you care about your people. And thank you for being that voice today. And I'll turn that to any of the council members if they have any questions. Thank you very much.
Thank you.
It's Whitney Parrish Perry, and Sarah Gaffney is on deck. Thank you.
Chair Kimball and distinguished members of the Maine Recovery Council. My name is Whitney Parrish Perry, and I represent Maine Access Points. Thank you for your service and this opportunity. As a current provider of the state of Maine and personally as a former public servant who's executed funding, I believe it's important to highlight a little bit about who we are. Maine Access Points is the state's geographically farthest reaching harm reduction service organization, distributing naloxone throughout the state as a tier 1 distributor of the Maine Naloxone Distribution Initiative. For some background, MAP is the sole mail order naloxone T1 distributor, and it is the only T1 that purchases both nasal and intramuscular naloxone. We know that people who use drugs have always been and will always be the people who take care of one another and their community. And it is a priority of MAP to ensure people who use drugs have access to safety when and where they need it. Together with our distributor net community, MAP has distributed nearly half of the naloxone, nearly half, provided by the MNDI and the Office of the Attorney General, reflecting the impact of peer-driven service provision. Maine Access Points is a Maine CDC certified syringe service program provider in Calais, Holton, Rumford, Machias, and Sanford. And we provide an array of services beyond safer use supplies, which are often focused on including disposal containers, sexual health and wellness supplies, wound care and hygiene supplies, at-home drug checking, and other necessities for safety and wellness. We provide overdose prevention and response education and training, culturally specific overdose education in 7 languages, drug user health services that include rapid HIV and hepatitis C testing, referrals and linkage to care to the Gilman Clinic, Nason in Sanford, and so many other things, as well as peer support services in our partnership with the state of Maine. We will soon be performing rapid drug checking in rural communities with FTIR machines and with confirmatory testing with our partner at Colby College. As you can see, we do a lot of work with few resources. We partner with health departments and provide technical assistance all over the state, as well as disposal for municipalities who are exploring ways to mitigate syringe litter. And so I'm not going to read everything, but despite the critical and life-saving support offered by MAP and its partners, harm reduction programs in Maine have seen diminishes in funding on a yearly basis. So bolstering and increasing funding is critical to the health of some of Maine's most marginalized and vulnerable residents. While the Maine CDC has worked very hard to obtain funds that SSPs can use, many of our funds are restricted due to being federally sourced. An important thing to know about harm reduction funding is that we have significant state and federal restrictions on it. This, coupled with the ongoing loss of life, in spite of money being funneled into prevention and treatment, makes it clearer than ever that we must reckon with the reality that drug use exists and will continue to exist. We ask you to support innovative, tested solutions to the growing despair in our communities. Practical strategies to reduce harm are proven to save lives, enhance quality of life, and build community and connection. MAP recommends specific recommendations from Section 8 or H, and to preface, we want to make it clear that harm reduction does reduce risk and harm. I'll finish my sentence. And it increases connection, which is so often discussed in these conversations, to non-stigmatized healthcare, to basic needs support, to the broader community, and to one another. We are not just a few of our parts. We are the sum of all of that make up a holistic, effective approach to building health. So I have a very long testimony with very specific information and data that may be of interest, and I will make sure to get that to all of the council members. Thank you for your time. I'm happy to answer any questions.
Thank you. Questions?
Thank you very much, Whitney. Harm reduction is so important in saving lives and improving the health of people that use substances. And it's needed throughout the state. Does Maine, if funding went to Maine Access Point, would that get throughout the entire state?
Yes and no. That's a very long conversation about administrative rules of the Maine Department of Health and Human Services through the Maine CDC. What I will say is that where we provide services in areas where there's sometimes virtually no healthcare, we are able to meet folks, a lot more folks. We are in Oxford County, Washington County, York County, Aroostook County, but I am happy to offer more information regarding those rules. If we were during the time of the emergency order during the COVID-19 pandemic, yes, we could reach everyone in the state. We do not have that luxury right now.
Thank you.
Thank you.
You're welcome.
Thank you. This microphone is giving me a little bit of trouble. Hi, Whitney. It's nice to see you. I wanted to spend a little more time, give you a little more time to talk to us about could you talk to me about what is restricted and specifics about what funding harm reduction programs in Maine need right now? I'm particularly interested in smoking supplies. And I'm worried about folks who smoke substances having access to smoking supplies.
Absolutely. Thank you for that question. So as we said, there are state and federal restrictions. Federal a little more stringent. We cannot purchase injecting supplies with federal funds. That is something that we're hoping is moving. And with regard to smoking supplies, that is something we cannot purchase with state funds. But what we are seeing in many of our locations is that people are transitioning to injection alternatives. They are making safer choices for themselves when they have the tools they need. We do provide smoking supplies. We purchase them with non-state and non-federal funds. And so that's a huge thing that's happening. There is an RFP out through a national organization, NACCHO, city and county health officials to investigate the efficacy of smoking supplies and funding it for the federal CDC to evaluate. We are hoping that the Maine CDC was at that informational session, actually, because they have been really excellent partners in learning more about why smoking supplies are so critical to folks. We have the highest rate of HCV, hepatitis C in the country, and hepatitis B. And we know that these diseases do not just transmit through injection drug use, they do through many other avenues. And so it's important to have those alternatives to injection drug use. And as well, it's important to have safe supplies for folks who are smoking and making those maybe safer choices for themselves, or also learning how to taper their drug use. Maybe they want to lower it. That can be sometimes easier for folks who are smoking drugs or using them in other ways. And so we need to really look outside the scope of syringes. There are many other, health conditions that are can be resolved by transitioning from injection drug use. And we really think it's antithetical to our collective goals not to fund those items when we know there's a lot of deeply rooted historical and racialized fear around smoking. And that is the root of why some of these choices, and there's not necessarily a conscious choice rooted in that history, but that is the history, and that's how we got here.
Okay, great. Because I am going to remind the council, you need to know you have not gone through one sheet and you have 6
And I can talk forever.
in an hour. So I just want to remind you all of that. So maybe again, if we need added information, we can get that, but we want to be able to make sure that everybody has that. And it's been absolutely informative, but just a reminder to people. Courtney, do you still want to ask that question?
I feel like I can't ask that question now, but I will defer.
Sorry,
Thanks.
Courtney.
I will follow up with more information for anyone who wants it.
It would be great to have that. Thank you.
Of course.
Any other questions? I didn't mean to cut questions off. I just want to remind that some of the questions will be really long answers. And if we can get the data sent to us or ask people to come to a council meeting and get more clarification, we also have that opportunity.
How many of these FTIR machines do you currently have?
We do not. So they were just purchased by Maine Health. And so we're really excited to get them. We will have 2 machines. And that is through the support of the state as well. And we would love to have more access to those machines as well as what it requires to operate them, staffing, those types of things. But we are really, really excited to get that program started. We do not currently have them in place right now. We're hoping to have them. I don't know that I can say, they're going to be in fairly rural places because we operate in rural Maine.
And rough estimate of the cost of the machine and to run them if you.
I didn't purchase them, but I can get that information for you. Absolutely.
Dr.
Thackrar can tell you exactly how much they cost.
Thank you very much.
Thank you.
Thank you. Thank you very much. Sarah Gaffney, and then on deck is Amy Clark.
Good morning. My name is Sarah Gaffney, and I'm here to speak on behalf of the Brain Injury Association of America's Maine chapter and the Maine Acquired Brain Injury Advisory Council, representing Mainers living with brain injury, as well as their family members and caregivers and the providers serving them. Thankfully, the widespread distribution of naloxone has increased the number of individuals surviving overdose in Maine. However, survival does not paint the full picture, and we are deeply concerned about the impacts of overdose on survivors. Last year, over 10,000 individuals in Maine experienced an overdose reversal. Every single one of those individuals is at risk for a brain injury. During an overdose, the brain can be deprived of oxygen, either wholly or in part, often resulting in hypoxic or anoxic injury. The frontal lobes of the brain are uniquely vulnerable to the effects of oxygen deprivation, which can directly affect an individual's executive functioning skills. That includes their memory, planning, the ability to focus and multitask, among other skills. Brain injury can have a major impact on the success of substance use disorder treatment, as these types of cognitive impairments from brain injury are frequently misidentified as non-compliance or resistance to conventional treatment. As a result, overdose survivors may not get the treatment they need due to the unrecognized symptoms of their brain injury. Though it is identified as a priority in the Maine Opioid Response 2023 to 2025 Strategic Action Plan, there is very little awareness about this silent epidemic of hypoxic and anoxic brain injury with Maine's ongoing overdose crisis. In addition, though LD 539, an act to provide substance use disorder counseling for Maine Care members with an acquired brain injury, was passed unanimously by the Joint Standing Committee on Health and Human Services, it remains unfunded. This is a huge gap in Maine's care for overdose survivors. And as more and more lives are saved, many more individuals will need care and support for co-occurring substance use disorder and brain injury. Our recommendations and next steps include increased awareness, increased screening, provider education and training, expanding access to brain injury services and supports, and building capacity within current systems. We'd be happy to submit additional information in writing.
We would like that. Thank you. Questions? I haven't scared y'all. Okay, thank you.
Hi, thank you very much, Sarah. I recently attended the National Brain Injury Conference in Portland.
Yeah.
And I was kind of disappointed that there really wasn't anything about brain injury after overdose and with substance use disorder.
Should have come last year. So last year we actually had several pieces of that conference dedicated specifically. We had a whole track dedicated to substance use disorder and brain injury and the overlap.
Okay, thank you.
Yeah. And thank you for attending.
Oh, that's great.
Thank you. Other questions? Thank you very much.
Thank you.
Thank you. Amy Clark, and then on deck is Seth Fournier. Hey, Amy.
Good morning. Thank you so much for allowing me the opportunity to speak today. My name is Amy Clark, and I am an affected other recovery ally and a longtime board member of the Bangor Area Recovery Network. BARN, as it is more commonly known, was the very first recovery community center in the state. And while a few years ago, there were just a couple of us, thanks to the Mills administration, Maine's Recovery Hub now boasts 19 centers spanning all over. Well, this is great progress and has allowed access to many more people. More help is still needed. As we just heard not that long ago, Piscataquis County is still really lacking the help that it needs. And most of these centers are working on shoestring budgets, wondering how they will keep their doors open. And so far, there's not really a plan for sustainability or increased funding for these centers. Recovery community centers have a profound and positive impact on addressing the substance use crisis in our communities. Recent research has shown that recovery community centers improve the quality of life 10 times faster for individuals that access them. These centers provide a safe and supportive environment for individuals in recovery and their families, offering a wide range of services such as peer support, counseling, educational resources, and social activities that help individuals maintain their sobriety. By fostering a sense of belonging and connection, they reduce the feeling of isolation and stigma often associated with addiction, making it easier for people to seek help and stay on the path to recovery. Moreover, recovery community centers serve as valuable hubs for information dissemination and advocacy, raising awareness about the dangers of substance use. They play a vital role in the broader efforts to combat the substance use crisis by creating a network of support that empowers individuals to reclaim their lives and help rebuild their communities. For more than 15 years, the BARN has stood on the front lines of the substance use crisis in Bangor, and we've grown to become an integral part of our area. We are not only open 365 days a year, hosting more than 125 different recovery-focused meetings a month. We offer recovery coaching, resource navigation, outreach, and advocacy, and partner with other programs such as Penobscot County Prosecutorial Diversion Program, the local options and overdose response teams, and many others. Although BARN has one of the bigger budgets as far as recovery community centers go, and we are grateful to currently be able to employ 6 full-time positions, only 3 of which are paid for by the state. It is still not nearly enough to meet the ever-growing and challenging needs of the Bangor area. In order to do the work that we do, we still require upwards of 1,000 volunteer hours a month, which the state equates to a value of somewhere around $250,000 per year. I tell you this not just because I love to brag about our volunteer program, because I do and I will, but to highlight that we still do not have nearly the resources we need to be able to do the job that the state expects and needs us to do. Space is at the premium, and our staff and volunteers spend every day stretched as thin as they can possibly go without breaking. You have and will hear from many people with many ideas of how the funds should be spent, and surely the needs are great. But I implore you to please use some of these funds at your disposal to appropriately fund all of the recovery centers across the state and create a sustainable plan that will ensure they can not only remain open, but can also adequately serve their communities for as long as needed. Thank you. Happy to answer any questions.
Thank you, Amy. No
You're all
questions,
making it
then?
easy on me. Thank you.
I've scared them all, Amy. Thank you very much for the work that the barn does. Thank you. All right, Seth Fournier, and then on deck is Tommy Hayes. Okay, are you Tommy? Well, you can tell. Oh, is that Seth? There he is. All right, thank you.
I got a little caught off guard, but thank you for having us today. And I kind of came to this a little bit. I'm learning as I go here. Wasn't quite sure what I was doing, but anyways, I'm Seth Fournier. I work at the Larry Labonte Recovery Center. I'm also part of the advisory board for Mari and part of a group that is getting ready to open up or working in the process to try and open up a sober house up in Mexico, which Ron was talking about with Mari, I believe. So in Oxford County. Anyways, since I've been in the recovery center, I've been in recovery myself for 15 months, and it's been eye-opening. I'm relatively new to this, but what I wanted to bring here today was I've got the opportunity through the recovery center, and I get a chance to go out with Glenn Gordon and work a lot with the options program stuff. So I kind of say I get the chance to get in the gutters and do some work. So I wanted to bring like what I've seen out there to the board today, so that help inform some decisions, hopefully. But anyways, what I'm seeing out there is what we're really lacking is working with the recovery center is great. Obviously, as recovery centers, we always need more funding, but we need the resources available to continue to help people, which most of the people we help or work with are working off Maine Care, or they're homeless, low income, and it's quite a challenge. Getting somebody into detox or whatever can be quite a challenge. There's not enough beds out there. Getting somebody into rehab is quite challenging. I've been talking with an individual lately that wants to get some help, and it's looking at 4 to 6 weeks out. So I personally, I mean, I think one of the huge things that this money could go towards is opening up for the people that are less fortunate avenues to be able to get them into the treatment they need. We see it daily with people that they just don't have anything, and so getting them into the treatment they need is relatively tricky. Being in Oxford County in Western Maine, I mean, nothing is close to us for resources to start with, but also transportation is huge in there. I know I've talked a little bit with Corey Mason that's going to be talking later on, but he's kind of coming out with a transportation thing that sounded very interesting, but I don't know all the answers to it. But I know that if people can't get to meetings, if they can't get to recovery centers, if they can't get to treatment, it's awful hard to recover. So I think it's just huge on that aspect that we start looking at this. A lot of these people that I work with that are suffering or whatever, I realize how fortunate I was at the time when I was in my addiction. I didn't think I was that fortunate, but at this point, I realized I was quite fortunate. I had people there to help me. I work with a lot of people that don't have that. And with these funds coming in and being available, we need to do more to help these people. We're seeing more of a homeless problem in the area, which I mean, comes right from, or a lot of it stems with mental illness and addiction. And there's just not the resources in place for it. And it's without the money, it's definitely not there. So that would be my suggestion, is that we kind of put more into place that help people that don't have these resources. There's a lot of people I've listened today that are a lot smarter than myself to implement how it happens. But I just want to bring my stories of working with these people and make sure to speak out for everybody. That, I mean, being in the rural community has a lot of challenges, in transportation and lack of beds and availability with Maine Care or not having anything is a huge problem. But thank you guys for your time.
Thank you for yours. Questions?
Seth, I just want to thank you. The Larry Labonte Center does tremendous work along with you and Glenn Gordon. So many of my patients utilize their services, and I really appreciate it. That sober housing in Mexico would be sorely needed, as you know.
Thank you.
Thank you very much.
Thank you.
Tommy Hayes and Rachel, and I can't pronounce his name, Solo Tardev is on deck. Thank you.
Thanks, Tommy.
Hello, everybody. Thank you for hearing what I have to say today and doing everything that you do on the board. My name is Tommy Hayes. I live in Dixfield. I work at the Larry Labonte Recovery Center as well. I'm our staff supervisor, our Narcan coordinator, and I handle most of our online presence as well. I also work with Seth here, and we do a YouTube recovery show called Recovering with Friends. We do like a half an hour, just a conversation podcast type of deal. We don't edit anything out. We allow the conversations to happen as they were. Unless somebody were to mention somebody's name who's in an anonymous type meeting, then we would bleep out their name for confidentiality reasons. Working at the center, I've really, quite nervous. I've quite noticed that the people that we do work with need three main things within like our presence. And they've all been said by most of the people that have spoke before me, so I'll kind of just give my piece. But detoxes by far. When somebody walks through our doors at the recovery center, sometimes they're not sure of the continuation of the process of recovery or going into something like a sober living house, where like a gentleman before me had said, like you need to pass drug screenings and things along those lines. So a lot of times that they will need, we refer them to a detox instead. Go through that process. That way you can go into these types of recovery housings. A lot of times when we open our doors at 10, these recovery houses, these detoxes are already full. We've started to now like come in before we open, meet with people at 7 as soon as detoxes start to open, because most of the time by 7:45 the beds are full. So beyond that, once we do find a detox for somebody to go to, or if they've already gone through that process and is going to some sort of rehab or sober living, is transportation. For us in Rumford, getting anywhere, even if it's just going somewhere for yourself or out of town, grocery shopping down to Auburn or something, anywhere from us is 45 minutes to an hour. And then for us to transport somebody, and that takes quite a bit out of our staffing. That's something that we've started to do now as a recovery center, is we've reached out to local grassroots organizations. Some are in our area, River Valley Recover Strong, as well as there's a few other like Facebook groups, Recover Together with Randy Beard, and many others have helped us out with compensation for the funding for gas to get that person from A to B and get them there. And to go along with transportation, my thought of this was either possibly expanding the already program that we have in place through Maine Care and Motive Care to get people to these programs, opening it for the recovery community, but maybe instead starting its own recovery-based, Maine-based transportation service that allows more than just a detox or some sort of appointment for Maine Care, like something whereas recovery meetings, setting up so that somebody could go to these meetings at night when most of the time medical appointments is all that's covered. Lastly, I just want to touch on is just recovery centers. Through our center, we work a lot with our local schools. We do SUD prevention days at our schools, and we do one-on-one recovery coaching with students, so that they either refer to us through the school as a disciplinary action, because instead of getting suspended, they meet with us as a recovery coach for a while, and We don't give the schools any evaluation. We just meet with the students, give them a place to speak and see if they're at that point now. They're at that middle school age of trying things, or they already passed that point and now are in active addiction. They can meet with us, see how things go. We can refer them to resources outside of us. Just lastly is we also do meet with students as more of just not as the recovery coach position, just as a, I know we're not peers with students, but more of that open-ended, we're not a teacher. You can talk with us more than just that piece there. Thank you.
Thank you. Questions?
Tell me, in your personal experience, how long average when you make that phone call, hours, days, weeks, months, what's the wait time to get into a detox when you call for someone?
Sometimes that's kind of depending on what day of the week. Sometimes we'll call on a Monday through Wednesday and they say, sorry, we actually don't have anything available the rest of this week. Try back on Saturday. Sometimes we'll have one of our staff members come up into town. Most of us don't live in the general town of Rumford. So when we do come up, it is a little bit of a trek for us. I myself live in Dixfield, and that's just a 10-minute ride away. It's just a connecting town, but that is a little bit of a distance. So when we do come up, even on a Saturday, when they tell us to call, sometimes when we do get that person, we finally track them down. If there's somebody who is unhoused, we don't have a phone for them, no way to get in contact them. When we meet that person, by then, sometimes the beds are already full. I know of a situation, we worked with Seth here where he got somebody, he said, I need to find them. He called the detox. You need to get somebody within 10 minutes. He found him within 7 minutes. He's like, good thing you called because we were about to give that bed to somebody else. So those are the things that, we need to, when beds are available, we need to jump on it. So expanding those beds is very much needed.
Thank you.
Thank you.
Thank you, Tommy.
Thank you very much. Thank you
Thank
for
you for your
coming
time.
today. Rachel, and on deck is Maria Grindle.
Thanks for the opportunity to be here. I'm Dr. Rachel Solotaroff. Sorry about my handwriting. I'm the Executive Clinical Director of Substance Use Disorder Services at Penobscot Community Healthcare. I live in Portland, but I'm here representing PCHC, which, if you don't know, is a federally qualified health center. Headquartered in Bangor. We have 19 clinical service sites throughout Penobscot, Waldo, and Somerset counties. PCHC urges the council to allocate a portion of opioid settlement funds to community health centers. CHCs have been and remain a key part of the frontline response to this epidemic. The services that we provide in health centers, prevention, identification, treatment, and long-term support are particularly well suited to addressing opioid use disorder and substance use disorders while also providing comprehensive care. Over the past 10 years, PCHC has devoted significant resources, often with limited funding support, to becoming really a regional leader in the prevention and treatment of opioid use disorder in primary care. From things like addressing the overprescribing of controlled substances to implementing the first low-threshold bridge clinic in the state, and also advancing street medicine in the Bangor region for unhoused people with co-occurring disorders. However, despite this work, overdoses in our community have held steady, while at the same time our resources to address SUD have declined. This is exacerbated by the pandemic, which destabilized healthcare, further exacerbating underlying financial challenges. And to date, funding streams have just not led to a sustainable model for prevention, harm reduction, low threshold treatment, and supports for long-term recovery. So to these ends, we propose the Recovery Council allocate funding to the following initiatives, which we think would be strategic, high leverage opportunities. First is doubling down on SBIRT, which, if you don't know, is the evidence-based practice of screening, brief intervention, referral, and treatment in the healthcare setting. What some folks don't know is that of all the screening that we do in primary care, SBIRT is the single most effective screening and prevention practice that we have, specifically for alcohol use disorder. Yet its systemic implementation in primary care has been hampered by a lack of implementation resources, things like time for training, workforce development, embedding workflows in daily practice. So really a full court press on SBIRT across primary care, particularly in health center settings, would really be a leap forward for prevention and treatment, specifically for alcohol use disorder. Second initiative is expanding access to comprehensive low threshold SUD care. A colleague of mine up at PCHC really has developed a brilliant model of low threshold SUD care. By low threshold, I mean same-day access. We can talk more about that. And includes treatment for all substance use disorders, but with additional capacity to treat co-occurring mental health conditions, to address reproductive health and STIs, wound care, and provide screening. The last thing I do want to spend a quick minute talking about is addressing foundational drivers of recovery, including supportive housing and supportive employment. This is where I've spent the last 20 years working in another state, but supportive housing can be inclusive of low barrier or recovery housing, transitional or permanent. And while the Recovery Council may not have the resources to increase the affordable housing supply, it is perfectly positioned to fund services that make supportive housing possible, including case management, rent support, housing navigation, even operating costs. And then 10 seconds to say a couple of words about supported employment, which in my experience is really the unsung secret sauce of recovery. This fundamental idea that anybody who wants to work can be combined with comprehensive treatment and supportive housing if needed, and can really serve as a catalytic and highly affordable component to SUD care, and it's sparsely funded across this country. It can serve as a highly synergistic element to other initiatives that in the Recovery Council's portfolio. So thanks for your time, for your dedication to this issue. And I think I submitted written testimony last night, so I don't have copies for y'all.
Thank you. We have some questions.
Thank you for your testimony. At the beginning, you said support for community health centers, and were you referring to, I just want clarification, were you referring to CCBHC's community?
So not at this, that would actually.
But you don't have a contract for a CCBHC?
We're not a CCBHC. We're a federally qualified health center. And I would, not to speak out of turn, I would say a CCBHC is a variant of that, which is sort of an evolving newer model in the state.
Okay. For acronyms, certified
community behavioral
health
yeah.
clinics.
Yes,
okay.
But a terrific model.
Okay, thank you.
No other questions. Thank you very much for your time. Thank you. Maria Grindle, and on deck is a Greg Zingzer.
Little bit shorter. This is my son. So my name is Maria Grindle and I live in Bremen. I don't represent an organization. This had some guys, my son, Jonathan. Sorry, he struggled for 20 years with addiction. He tried outpatient therapy, methadone clinics, and lastly, inpatient services at the Plymouth House in New Hampshire. His admission at Plymouth House was a result of an overdose and his father Narcaning him twice. He spent 7 weeks at Plymouth House as inpatient. He attended group therapy, one-on-one counseling, along with other treatments for addiction. It was a rough road for him and his family. This was done without any medical assistance. After 7 weeks, he came back to Portland and spent 2 months in a sober house that had random drug testing. He then moved to another sober house that did not. This was the beginning of the end. My son passed away on July 4th of this year. I feel that if random drug testing had been in place, I would not be here telling you his story. And speaking with his friends, he made in the sober community about having random drug testing in place. They thought it was a good idea. They told me they are held accountable, but not held accountable. They're held accountable when it comes to mandatory biweekly house meetings, curfews, signing in and out when they leave, and chores need to be done. One of his friends told me she was in a sober house for 3 months and not once was a random drug test administered. To close, I hope you will consider my request for mandatory drug testing in all sober houses, no matter the level of care, and hopes it will save the life of someone's loved one. Thank you.
Maria.
Sorry.
Thank you for having the courage today to share. I thank you. And your son looks like a very beautiful person. I'm truly sorry for you.
That was after 7 weeks at Plymouth House. He put on 40 pounds.
You know, you bet those are good 40 pounds.
Yeah,
and
they're
you
good
know,
40 pounds.
And you can tell that that spark in his eyes.
Yep. It was good to have him back. We had him for 5 months. God gave us that gift of, having my son back as my son instead of my son, the addict, which I hadn't seen in 20 years. So it was a beautiful thing.
Thank you.
Thank you.
And I'm going to ask the council if they have any questions. Thank you for coming here today and sharing those concerns. Thank you. Thank you very much. Greg? And then Senator Center.
Greeting.
I didn't come to speak, I came to.
Oh, okay. All right. Thank you.
Signing in for.
I can do that, Senator, and thank you for coming and caring. So on deck will be a Lauren, I believe that's Hunt or Hint. All right. Thank you. Thank you, Greg.
No problem. Greetings, everybody. My name is Greg Zinzer. I'm the county manager for York County, and I am here in that particular capacity. I do and have submitted to you a copy of my testimony, but I just want to say, being here as a governmental agency, York County government is a governmental agency that believes in barrier-free treatment options. Right now, we operate in the county the largest MAT program. We currently have 70 folks on our jail-based MAT program. We do not have any cap on that particular program. And we also offer a 24-bed residential treatment option right across the street called the Maine Recovery Center. Next week, we're having a meeting with our MAT folks to in an attempt to get people out of jail that are successfully on our MAT program and into residential treatment option. I wanted to point that out. As we are, again, a governmental agency coming here, presenting ourselves to you. And we also occupy a very unique position here because we're very heavily involved in the criminal justice system. And so from our view, as we get right down to it, we see and would really suggest that this council really invest in detox and recovery, residential recovery beds. And when we're talking about the residential recovery beds, we're talking everything from the very beginning in a program that we have developed is beginning with observation. And then from there, they can go into short-term, midterm, long-term recovery. It's various types of licensing regulations that we're looking to follow there. And so from there, they would go to outpatient and then have access to residential care after that. So again, from our perspective, big issue facing this particular, the state of Maine is the severe shortage in residential treatment recovery facilities throughout. We all hear all the time about the lack of health treatment options in every county. What I often see, and I'm just going to put the plug in for us, a lot of items are focused to a lot of what I'll call the more rural counties. We often feel forgotten down in York County. We have a huge problem down our way. And so, we're hoping that we can see some reinvestment down our way as well. Second, we think that you are well positioned to work with other entities such as ourselves and other governmental agencies who have funding that are currently available to them from the opioid settlements as well as rescue plan funds. And we believe that you working with those folks to help maximize and leverage those investments to really look at really significant regional solutions. Everything I've heard here is wonderful, and I think everything is needed. But from our view and what we deal with on a regular basis, the residential treatment and recovery beds, the beds are most important, as well as detox. As I said, right now, the access in York County in particular is extremely limited. We, the county, are actually the largest provider of all of those services at this point in time. And, we don't believe it should be in the jail. And so that's why we are focusing all of our resources, and you have in your packet some of the proposals that we're currently working on right now, a 58-bed recovery center,
I'm going to put a plug out here. We have our public hearing for that particular center, November 27th, 6:30 p.m. And that will be at the county courthouse in Alfred. Would appreciate a letter of support from this council. Happy to talk more. That information is in your packet. So again, residential detox and treatment beds and leveraging your existing funds with other entities that are willing to spend their money on this very important program.
Thank you. Thank you very much. Questions, Courtney?
Thank you for coming today. I've been super interested in what York County is doing with your ARPA funds, and I'm assuming maybe some of your opiate settlement funds as well with the treatment center. You touched a little bit on it, but could you tell us more about what you all are trying to build? Also, my specific question is the cost of it for both projects, the training center and the treatment center, is $45 million estimate. Could you break that out for me? How much is the training center and how much is the treatment center? Or are they just like so intertwined that you can't?
We believe, yes, I can break them out. Training center is 20 million, treatment center is 26 million. And so we are looking at those as heavily intertwined. If you look through also the allowed uses of the opioid funds, you will see that the training and education for our public safety personnel is tantamount to really assisting, that frankly, at this point, that is the front line of the opioid epidemic. It is our public safety personnel that are the ones that are getting hit with this every day. And again, notwithstanding emergency departments and everything going on here, we have a duty and an obligation to work with our public safety professionals to train them, equip them, and give them the knowledge they need to respond to the opioid epidemic. Also intertwined with this is a huge public health component. We were one county in York County when the COVID pandemic came around. We opened up the largest vaccination center in the county as well. So we have a very well tied to the public health field. We have partnerships with the community college to bring in some nursing level care, students, interns into this particular program, and some of the community mental health programming that they're embarking on to bring them in and work with us on this.
I apologize. Can
yeah.
you tell me specifically about the treatment center that you're trying to build?
Yeah. So, again, we're very excited about it. It's going to get built. We are actively in the phase. We're hoping for a late spring 2024 groundbreaking. It's a 58 bed recovery center. There will be 8 detox beds, 16 short-term beds, 16 midterm beds, and there will be 10 long-term beds. And then there will be 8 observation beds. Those observation beds are generic in nature. Those are for drop-offs. Those are for anybody that needs to get dropped off outside of normal operating hours. They're brought into observation and they're assessed by the clinicians as soon as possible thereafter for placement into the appropriate level of care. And so those are for not only law enforcement, those are for the community at large. The funding for this long-term over the time period is going to be a combination of Maine Care and already raised county funds. Because of the funds that we currently raise right now, we spend about $1.5 million per year in our county on substance use disorder treatment. That's a combination through the county jail as well as the other funds that we raise for our 24-bed recovery center, which is outside of the facility. So it's again a 58-bed center. It's going to also have an intensive outpatient substance use outpatient clinic as well, where we're going to serve the folks that are leaving the jail, but also is going to greatly expand the continuum for those that are leaving the jail, because the jails typically tend to be somewhat transitory in nature. We're going to capture those individuals and be able to hopefully get those into longer term treatment and recovery. So in short, that's what we're looking at. That particular project is 26 million. And when we look at the total combined projects, it's about 45. We have 38.5 million.
Super quick follow-up. I'm sorry, Pat. That sounds amazing. Thank you for leading this work in York County and in Maine. Is there any harm reduction that's going to be included in the any harm reduction services or principles
Well, we like to think that we already engage in harm reduction. We have a very aggressive program over at our county jail where every individual who leaves, they leave with a harm reduction bag. The whole, what exactly is harm reduction? It encompasses a lot of different things. Some of the items that we do have to consider, however, being a governmental agency and, we occupy a very large area in a somewhat small town. One of the things that we're facing in particular as it pertains to all of this is the stigma associated with recovery. And I don't need to explain what we mean by that. And so, yes, we have discussed providing additional supplies, but like we heard from other individuals prior, we are largely limited in what we can really do with those funds. But I do believe that we see the need for it and are happy to have that conversation. And we equip our residents as they leave the jail facility as best as we can.
Thank you.
Just a quick question, Greg. Can you talked a little bit about the medication assisted treatment program at the jail, and you said around 80 individuals. Two quick questions. I should know this probably, but what's your average population in the jail? And then how does York County primarily fund the MAP program?
So we have on an average daily population at the county facility is a little over 200. And right today we have 70 individuals on that MAT program. Thank you, Sheriff, for bringing that up. The MAT program at the jail costs about $400,000 a year in direct expenses. That does not include the ancillary expenses that we incur in our other medical contract for other nursing level of care. That is primarily the counseling side and the cost of the medication. That costs about $400,000 a year. We receive $120,000 a year from the state of Maine towards that program. And just to probably echo some of the other things you've heard here as well, that is a very painful program to monitor. We get called into question frequently on our own money as part of that program, whether that money is sustainable, whether we're going to continue to fund it, down to how are we accounting for it. And so we get the $120,000 from the state towards that program. We raise through taxation the remainder. And so if I'm putting a direct expense, it's $400,000. The ancillary expenses are probably an extra $150,000 when we factor into other nursing type of care and medication management on top of that. And so we pay for that through county taxation. We're happy to do so because we are in our county a very firm believer in medication assisted treatment as well as treatment and recovery. We feel it should happen outside of the jail, and that's what we're trying to accomplish.
Thank you.
Thank you.
Other questions? Thank you very much. Lauren, and then Leanne Dodge is on deck.
Okay. Good morning, everybody. My name is Lauren Hunt. I live in Lincoln County, and I'm the program coordinator for Maine General's Harm Reduction Program. A little bit different than everyone else today so far. With no affiliation, I was asked to read a testimony submitted online from Christopher Cody, who will introduce himself in the following. Quote, "My name is Christopher Cody. I am 43 years old and currently an absent father to 2 daughters because I am serving a 4-year prison sentence for street-level drug sales to support a 20-year-long battle that was prompted shortly after I graduated from high school as an honors student with a bright future ahead of me until I became addicted to the OxyContin I was prescribed, resulting from an injury while on active duty in the military. Soon thereafter came the destructive avalanche, since I have failed numerous attempts of recovery, been in and out of prison, and lost my life completely trying to find a way to escape what I had become. Throughout all my encounters with substance use treatment, counseling, support groups, rehabs, detoxes, periods of abstinence, the absolute biggest influence and impact has come from others just like myself. those who have found a way to take control back and have taken steps to grow in the recovery community to help others just like ourselves. I feel that investments should be made in creating jobs for those who have lived experience and have become professionally educated to provide services like those of an options liaison, but the professional role could be trained with intentional peer support and act as a peer recovery coach while still holding the clinical knowledge to more effectively connect with individuals on a more personal level while still delivering evidence-based treatment. Regardless of it, this model is incorporated or not, peer support and peer recovery services and connections need to expand and integrate more forcibly into professional, legal, recovery, residential, and institutional settings. A few years before Purdue Pharmacy settled the class action, I received a $380 check in the mail asking for me to agree to no further action for being a plaintiff in the lawsuit. Now, an individual in long-term recovery working towards strengthening Maine's recovery community through education, training, and structuralizing a peer recovery organization, I feel that the peer approach should be supported because of its effectiveness and great need. Thank you.
Well, thank you very much for that. Thank you. Leanne? And then looks like a Carrie Lupin. I think it's Lupien.
Hi, thanks for having me. I'm going to talk fast, I hope. My name's Leanne Dodge, and I'm a prevention specialist. I've been in the field for over 25 years, and I also was a DEEP instructor. That's the driver education evaluation program that people have to take to get their license back if they get an OUI, and I only taught the under 21 program. And most of my work was done at the college and university level here in Maine and also New Hampshire. And I always thought, what if I could get to kids sooner than when they get to that age? So fortunately, I have a great job now in South Portland as the program director of SOPO Unite, All Ages, All In. It's one of the drug-free community coalitions. And I'm a lucky dog to have my office in the high school, even though I work for the whole city. And I just wanted to share a few quick things and give you some feedback from our students of what they think about this funding. And so one thing we just know more and more about is the young brain, and that it's best for learning from 13 to 20 without much effort. So I have great students. Some of our new Mainers know 6 languages. Some students play 4 instruments, 9 sports. I mean, they just can do anything. So that's the great news. And if they can learn great things when they're young, that can stick. Unfortunately, 90% of addiction starts before the age of 18. So prevention is so critical, and it really takes multiple strategies and multiple settings. So we get to work with the whole community of South Portland, from law enforcement, parents, coaches, teachers, everybody. And that needs to be funded because we have this small, I've been there 7 years. The kids are there for like 10 minutes in my brain. They're out and they grow a foot from 9th grade to, I'm like, who are these 5th graders? Oh, they're 9th graders. We don't have much time to do prevention, so we got to do it. I wanted to share quickly, one of the big things we've done is that we no longer suspend students for substance use violations out of school suspension. We use restorative practice, which holds students accountable and also treats this as a clinical issue. So students, they do go home the first day, the second day, they're back in school and they get formally assessed by one of our social workers. We have an in-school restorative practice coordinator where the student spends a day or 2 doing the restorative process, which is not fun. In fact, our students said in the beginning, they go, I think we'd rather be suspended. What? Okay. We also don't kick kids off of athletic teams. They get to still go to practice and meetings. They don't get to play in games for 10 days, but they're still on the team. Some schools in Maine, you can get in trouble once. The second time you're kicked off of sports all 4 years, all sports, never to play again. So I just would say, as a DEEP instructor, so many of my students would say that they were kicked out of school or they were kicked off a team. And now here they are with an OUI. And what if we had gotten to them sooner? So here's a quick little things from the students, very fast. This is what they think you should fund. Fund youth prevention groups in all schools. promote clubs and organizations and hobbies, and pay club advisors. Some school advisors don't get paid to do that work. More transportation, and work on providing affordable housing to homeless youth and healthcare, and providing more treatment for youth. There's an 18-month wait right now for adolescent treatment. Thank you so much. Don't ask me anything.
I won't ask you any questions, but I will tell you my very favorite job was working full-time for a school system as a substance abuse counselor. And those students are amazing. Thank you for your work.
Yeah.
We do have a question though.
Not a question, just do we have that list? Can we have that list? Thank you.
Thank you very much. Thank you.
Hi, good
Carrie.
morning. I want to say thank you to the council and
One
members.
second,
Oh,
I'm
sorry.
just going to say Katie Huntington from Mount View is up on deck. Thank you.
I just want to say thank you to members of the council and the audience for convening around such an important topic. This is really great. Thank you. My name is Carrie Lupian, and I am here today representing an incarcerated citizen at the Mountain View Correctional Center, and this is their testimony. Quote, "Hello, I was recently advised by a recovery advocate at the Mountain View Correctional Center of a public forum happening looking to hear input regarding opinion as to what is seen as top priorities for the opiate settlement funds in Maine. While I do feel that there are many areas concerning substance use, treatment and resources for those in recovery are in desperate need of growth, such as more programs, housing, training, and reentry services. I believe one of the most beneficial things that could be looked into is the development of a one-stop shop for the networking of all of those services. If there is one already in place, then the broadening of the web of awareness and contacts in that network should be discussed. Although I have witnessed great progress and expansion of resources made available over the last 10 years, I have also witnessed a recurring theme, that being the lack of communication and ability to connect the right information at the right time to the right person. To my knowledge, this is not something that is available. Having had many conversations with various caseworkers, case managers, and other folks in support positions over the years, I have found a vast number of them to individually have knowledge of many different pieces to the larger puzzle. More recently, I have noticed this to be especially so throughout the correctional system. I am one of the people in that system, one who is also coming upon release, and have found myself to be dealing with the same problem that I have been seeing for years. Poor communication as to what is available, where it may be available, and how to get access to those specific services available that would be most beneficial. I realize that there is no easy answer to many of the struggles that a large number of people face, but I truly believe that having a combined, cohesive networking space to be a hub for as many pieces of the puzzle as possible would not only be an incredible aid in the process of assisting those with substance use problems get back on their feet, but would also help to lower the number of many who slip through the cracks of the system. By having such a platform, it could also potentially save those who give up the journey before they even begin because of not enough information exchange and the lack of transparency of all that is out there. I would like to thank you all for being in attendance. Your time is appreciated. S. Little.
That is very well said. Thank you. Question? Yes.
Can I ask you a question? Could you ask this person if he could reach out to, I would like to make contact with this person personally so I can answer a bunch of his questions. And I'd like to learn a little bit more from him. Thank you.
Thank you. So is there a Katie Huntington here? And then on deck is Scott Gagnon.
Hi, good morning. I'm Katie Huntington, a nurse in Lincoln County. And as the previous gal stated, I'm here to represent a person within our correctional facility. I'll read for him. My name is Gavin. I'm 22 years old and I'm currently incarcerated at Mountain View Correctional Facility. At 18, I was sentenced to 8 years. I've been in for the past 4 years, and during my time, I have struggled with addiction as I have watched those around me struggle with the same. It would be nice to see this money used towards programs and services like reentry services, education, more broadened services in DOC, and job training offered to those struggling with addiction while incarcerated or just being released. There isn't much offered now, and I've seen many men struggle of this. Adding services that will help men cope with their problems without using drugs should be our goal. If it's not, then how are we really helping? Just because of the mistakes we've made, it shouldn't prevent us from bettering ourselves and growing into honest, hardworking men. Our first thought shouldn't be, I can't wait to get high. Or our first thought should be, rather, I'm thankful for this second chance that I was given. And then a gentleman who had recourse to a number of the people within the facility wrote this: as the peer recovery facilitator here at Mountain View Correctional Facility, whether in a group or individualized setting, I maintain the ability to connect with many of the residents who are actively involved in recovery. Over the past week, I held an open discussion with them about the Maine Recovery Council Forum and informed them of the opportunity to provide their own input as to what they should feel should be prioritized for the uses of the opioid settlement funds. Several ideas were presented as to what they each thought needed the most attention and would be most beneficial to the greater recovery community. Following the open discussion, to form a consensus, I asked that everyone in attendance rank their top 3 choices, prioritizing them 1 to 3. And these results are: 1, investing in peer-led positions inside the Department of Corrections, both resident and staff. Resource liaisons, if you will, to be assistive in the navigation of the system, recovery options, and peer support, both inside and outside the facilities. There needs to be a communication bridge from the contact person inside the facility to the outside facility. Both need to be abundant and knowledgeable of all needed resources across all of Maine. This means all state facilities. 2, there needs to be some sort of system to circumvent the revolving cycle of the system in terms of aftercare following release from DOC, i.e. basic needs being met, more than $50 and a bus ticket release, connection to services. And 3, investments should be made in the expansion of peer-led recovery services, i.e. opening several small peer-led community centers in rural areas that offer peer-led recovery groups, SUD counseling, access to and knowledge of resources, harm reduction, and/or access to MAT. Thank you, the peer-led men's group, residents of Mountain View Corrections Facility, and prepared by Christopher Cody, the group's facilitator. I'd like to thank you folks for your support of the population and hoping to limit the recruitment to, as Gabor Mate calls them, those in the realm of hungry ghosts suffering from SUD.
Yeah. Thank you for bringing those messages to us. We have a question? It's really nice to be able to have that voice at the table. Thank you for bringing the messages here. All right, Scott. And then Catherine Harvey is on deck. Thank you. Hey, Scott.
Hi, my name is Scott Gardner. I'm the Director of Ad Care Educational Institute of Maine, also the New England Prevention Technology Transfer Center. We do a lot of training and technical assistance across the continuum of services. I'm also a certified prevention specialist. And so my comments are really in 2 buckets. First, in the realm of prevention, I'm glad I got to follow Leanne because she was really provided a great example of one of my recommendations is the more investment in the coalition model. So Polio United and a lot of the other coalitions across Maine are really the best positioned entities to assess and address the particular root causes and contributing factors in communities when it comes to prevention. So I think more investment in that model is good. I'm going to be a little bold to suggest something to not invest in when it comes to prevention, which is PSAs. I think whatever money you could consider investing in a PSA campaign, you get much better return investing in the coalition model in prevention science. The research on PSAs is that they're limited at best in terms of effectiveness. In the realm of workforce development, along with the co-occurring collaborative Serving Maine and the Muskie School, AdCare is part of the Maine Behavioral Health Workforce Development Collaborative. And one of the issues that's constantly on our radar is the issue of workforce shortage across the continuum of behavioral health services. And that was a problem before the pandemic, and it's something that's only been exacerbated because of the pandemic. And so in that realm, there's 3 things I would throw to the council to consider. One is funding an initiative to grow interest in the behavioral health field in high school. I will say that EdCare and CCSME did develop a pilot program for that, which we were starting to implement in schools before the pandemic, but the pandemic kind of threw off our momentum with that. But so we do have a model to build off of. But I think building that interest early on is very, very important. And again, across the continuum, prevention, treatment, recovery, and harm reduction. Coordinated mentorship programs and internship programs, again, across the continuum. So it's one thing to get interest in the field, but we want to make sure when they get in the field that they have someone with them along the way to help them grow their career and stay in the career. So that's an important part for retention. And then finally, I would suggest with a lot of interest in prevention, we know that in prevention, folks come from a lot of different backgrounds, from education, from psychology, from public policy like myself. So I think developing a prevention science model or module that we could drop into other training programs, like for LADCs, for recovery folks, for healthcare settings. Because we know that prevention doesn't just have to happen in coalitions, doesn't just have to happen by prevention specialists. If we can infuse prevention science throughout all the different sectors and professions that are in the business of doing prevention, we could really increase our effectiveness as a state. So those are my ideas. I will wrap up by just putting a plug in a way that we could potentially help the council. Because I mentioned that we are the New England Prevention Technology Transfer Center. So we're funded by SAMHSA to provide training and technical assistance to any entity in New England that is in the business of substance use prevention. And our goal is to make sure prevention science gets into implementation. So between the ideas that I just laid out for you, but other ideas that are coming before you, if we can be a resource to help in that cause, please look us up. You know where to find me. That's all I got.
Thank you, Scott. Questions for Scott? Thank you very much for the work that you do. And thank you for talking about workforce development, important issue. I think Catherine is up, and then Peter Mullen is on deck.
Good morning, Chair Kimball and the members of the Maine Recovery Council. And thank you for allowing me to be able to speak to you about how both the Boys and Girls Clubs and the YMCAs across the state can help in prevention. I would also like to thank Representative Crafts for visiting our facility a short time ago and for learning a little bit about our wraparound wellness program. My name is Catherine Harvey, and I'm the Director of Philanthropy and Government Relations of the Alphon Youth and Community Center in Waterville. I'm here representing the interests of the Maine Alliance of YMCAs and the Maine Alliance of Boys and Girls Club. In 1999, the Alphon Youth and Community Center became the nation's only combined YMCA and Boys and Girls Club, and we remain the only one. I believe that we are uniquely positioned to speak about the benefits of both organizations. And we believe that having both of those organizations with the Alphon Youth and Community Center really makes us a strong program. The impact of the opioid epidemic has had on youth is broad and it's alarming. According to the Center for Disease Control, studies have demonstrated that prescription opioid misuse among youth is strongly linked with subsequent initiation and use of heroin and increased risk for injecting prescription opioids and developing an opioid disorder. Additionally, the CDC shared in the same study that 1 in 7 high school students reported misusing prescription opioids at least once in their lifetime. We know prevention programming can make a difference in the lives of youth. According to the Community Anti-Drug Coalitions of America, substance misuse exacts an enormous financial toll on the United States. Annually, the U.S. spends $740 billion on costs related to crime, lost productivity, and healthcare. However, for every $1 invested in effective substance use prevention programs will result in a savings of between $2 and $20. As the Maine Recovery Council directs the disbursements of these funds to ensure the strongest positive impact on communities, the Master Distributor Settlement Agreement encourages states to support efforts to discourage or prevent misuse of opiates through evidence-based or evidence-informed programs that include partnering with nonprofits as systems to support prevention, funding evidence-informed prevention programs for students, families, and others, leveraging youth-focused programs that have demonstrated effectiveness in preventing drug misuse, and supporting evidence-informed programs to address mental health needs of young people who may be at risk of misusing opiates and other drugs. States should support children, youth, and families by making long-term investments in effective programs and strategies for community change. We serve over 20,000 youth collectively with over 37 sites. We are the nation's largest youth serving organizations and providers of after-school programming, summer meals, and firsthand experience helping youth build resiliency, social emotional skills, and supportive relationships, all of which contribute to positive mental health. And we've been doing this for over 100 years. So we ask you to kindly consider that prevention programs for youth is a good way to invest some of your funds so that hopefully they will not have to go through all of the treatments and all the things we've heard today.
Thank you very much.
Any questions?
Questions? Youth is certainly important. Thank you very much for your time today. Thank you. Peter Mullen. And I think we have your testimony up here. And then Holly Richards is on deck.
Good morning. I'm Peter Mullen from Owl's Head, and I'm on the board of the Mid-Coast Recovery Coalition, a nonprofit helping Maine citizens recover from addiction. We run two nonprofit recovery houses, one in Camden for women and one in Rockland for men, and both houses have children. We've been doing this successfully for over 5 years. Thank you for the opportunity to speak today. We run the only MAR certified charitable recovery houses between Bath, Bangor, and Augusta. And the demand for our beds is overwhelming. Typically, substance-dependent individuals are released sober from incarceration, and then they crash on their buddy's couch or sleep in their cars. Too many relapse and eventually die from overdose or suicide. Because we can only help some, we carefully choose those most motivated to stay sober. People have always used substances and always will. Each one of us has to come to our own terms with alcohol and drugs. And many of us realize we're on the wrong path and we change. Some of our brothers and sisters didn't get there yet, but when they get tired of feeling sick, decide to get sober and want to get back in the game with us, we can help. Now, the men and women that we help don't have money, wealthy family, or insurance. The only thing we ask for is a firm commitment to stay sober, and we'll provide a safe, sober, supervised place to live while they get healthy and get their life together. We do this because every person deserves a chance at recovery. 2, 3, maybe even more chances, because we know it's better to get up off the floor and keep trying than to give up. We're here because we believe love and compassion are a whole lot better than scorn and derision, or even worse, apathy and indifference. But love won't pay our bills and keep our houses open. We depend on grants to keep our houses open. We want to expand our bed capacity by opening additional houses. And we intend to apply for 2.8 million spread over 5 years in Maine Recovery Council funding to open 2 additional houses in Knox County, reconfigure, equip, and provide for some future operating expenses. Please help us, our Mid-Coast community, and especially our addicted brothers and sisters. The gentleman behind me is our Director of Operations, Ian Kirkman, who hit not 1, but 2 deer on the way here this morning. So we didn't get to go on the sign-up sheet with me, but I'd like Ian to say hello and be the one to answer your questions. Thank you.
Thank you. Hi. So, you have questions? I have one question. I do have. So am I understanding that those who reside there do not pay room and board or some fee to stay there?
We do have a $600 a month rent charge. However, we have never actually kicked anyone out for not being able to pay that rent. We have asked over the last 5 years 2 people to leave because they were not paying their rent and had,
And had the
capacity to, but that is not that's not a qualifier for us. We've never turned somebody down because they don't have the money. We write off thousands and thousands and thousands of dollars. One of the other things that we do that we focused on is a lot of times people are coming, they've incurred thousands of dollars in fines and fees, child support, or they need to save up money to get an apartment or get a house or whatever they need to do so they can move on from us and be successful. And so if they sit down with us and they say, I've got these barriers and I've got these plans, we work out an arrangement for the rent so that they can achieve those goals. Because it doesn't make sense to charge for us to collect the rent. And then when it's time for them to leave, they're in the same position, just, sober, and they can't find an apartment and they still have thousands of dollars in fines.
No, go ahead.
Thank you. How many beds do you have currently in operation?
We have 12 beds at our men's home in Rockland, and we have 9 beds at our women's home in Camden. Both of our houses are set up, and we do accommodate parents with children. There's guidelines around that. But as far as I'm aware, we are the only men's house in the state that lets fathers have their kids. We have 2 little girls there right now that I flew out with one of our residents to get from Washington State because they were being taken from the mother. And it's been very successful.
And how many additional beds would the 2 new houses create?
That would depend on the houses that we could find. We would prefer to have a minimum of 10 beds per house. You can get to a point where there's too many beds in a house, but somewhere between 10 and 20 beds.
Great,
per
thank you.
house.
Representative Kraft, I almost got to my question. It sounds like you haven't identified the 2 additional houses.
We have not currently. Housing in the state and especially Knox County has been very, very, very difficult. And there's not a lot available in our area, especially.
I'm going to caveat my question with, I'm very supportive of recovery residences, but my question is, I used to run recovery residences, right? And there's recovery residences in my community, and I guess my question is, are recovery residences standing in the place of detox centers and recovery and treatment centers? I guess is my question.
I would say
In the
that
absence of those things, it seems like we're like sending you all the folks who actually should be in treatment because we don't have treatment. which doesn't seem fair. I don't know what my question is.
I would agree with that statement. I would say that I've been doing this for 4 years now, and it's been a learning process. You know, there's NAR standards, but there's not a lot of like, there's not like a set guideline, and depending on the area you're in, depends on what you do. One of the things that we've learned is we need to be bringing in the right people into our houses. When we bring in the wrong people, it doesn't work. We did have a fatal overdose back in 2020. It was awful. It was terrible. But we've learned bringing in the right people and saying no when it's not the right person, and that does become hard. So we do. I have phone calls all week, every week, from the prisons, from the jails, from the the park unit at Penn Bay or other hospitals, where I have social workers begging me to take people that aren't the right people because they're not ready, and the people are just looking for a place to live, but they haven't been through treatment, they haven't been through detox, they haven't, and we've learned that those people, they don't do well.
Well, I think when you say right and wrong people for recovery residences, what I think you might actually be saying is right level of care.
That is
Right,
exactly what I'm
right,
saying.
where they're
I
actually
think that was-
supposed to be, because I had the same experience in recovery residences, right? And I just think what you're saying is that they're in the wrong level of care.
I would agree. I tend to be. I'm a live in the woods Mainer, so my language is what it is. It's very blunt, and but that is exactly what I mean. It's not that there's a wrong person, but we might not be the right setting for them at that time, and we might be in 6 months.
Right. Okay. Thank you. I think you got to my point. Thank you.
I just want to clarify and thank you. And that cleared a lot up for me. There is specific criteria. The American Society of Addiction Medicine has the ASAM criteria, which specifies the level of care. The problem is we don't have all those levels of care available.
And that's what we've discovered.
Right.
I've put 50,000 miles on my car since December, driving people to detoxes, driving people to rehabs, driving people out of state to treatment, because we couldn't help them in our facility, but they needed help. And there's just, the resources just aren't there.
Right. We're supposed to use the ASAM criteria to determine level of care for our patients or clients, but it's almost meaningless because those levels of care don't exist.
Exactly.
And when you send somebody to the wrong level of care, it's certainly not a formula for successful treatment.
That's correct.
And there was a gentleman that was sitting here, I believe, earlier, that was talking about he works at a recovery center and getting people to detox. A lot of times I have people that are calling and they just don't know where else to call. They call and the resources are so small that the instructions that I give people and that we end up helping them with is, you need to call this detox every morning at 7 a.m. They're going to tell you no the first 3 to 10 days that you call, but you have to call every single morning. And on the day that they say you can be there, you need to call me, tell me what time you have to be there. And I've driven to Augusta County, pick somebody up to bring them to Bangor to get them there, or reached out to people that I know and say, hey, can you get this person to this detox bed? So that, you're 100% correct. There is some direction on levels of care. The levels of care don't exist.
Thank you. Thank you very much. Thank you for the work that you do. Thank you. Holly Richards, and then on deck is Terrence Miller.
Can you hear me?
I can.
Hi. Good morning, Chair Kimball and the Maine Recovery Council. I'm Holly Richards, Director of Philanthropy for the YMCA Alliance of Northern New England and residing in Androscoggin County. The Alliance represents the 15 YMCAs in Maine, who together serve more than 95,000 Mainers each year through our programs and services. Our mission is to support and strengthen YMCAs and facilitate collaboration among the YMCAs and community partners to increase our impact and advocate for positive change. We are uniquely positioned to leverage the collective reach of Maine YMCAs to maximize positive impact across the state. Thank you for the opportunity to give input on how Maine's opioid settlement fund should be spent. I'm here to share how our alliance and the Maine Ys could utilize the funding to support critical prevention programs in our communities, I want to underscore our invaluable role in addressing the opioid crisis and how this funding can make a profound impact on our communities. The YMCAs have been a steadfast pillar in our communities for more than 150 years, fostering health, wellness, and community engagement. A few ways that we feel the funding could help is the expansion of prevention programs. So our YMCAs play a vital role in our communities, offering a wide range of programs and services that aim to prevent various issues and promote healthy living, positive youth development, and social impact. These prevention programs contribute to building stronger, healthy communities. A few examples are our youth development programs, after-school activities, mental health support, bullying prevention, nutrition education, fitness programs, substance abuse prevention, all that aim to create healthier, safer communities. Another idea is scholarships for our before and after school programming. So collectively, the YMCAs are the largest provider of early education before and after school programming. In 2022, we served over 3,800 youth in our early prevention programs, 7,400 in our before and after school programs, and over 8,000 children in our summer, day, and overnight camps. Our programs provide safe environments for children to learn life skills such as swimming, water safety, receive free meals, make lasting friendships with peers, build positive relationships, all which aid to reduce the likelihood of engagement in risky behaviors as they get older. An example how we utilize this structure is during the pandemic, we distributed $3 million in community development block grant funds to the YMCAs to provide before and after care scholarships to low, moderate income families across the state. And then we also think we could use the funding to increase community education and awareness, funding to support marketing, to make our programs more readily available and known, and especially to serve the underserved communities. YMCAs serve as a hub for community engagement. They bring people together, fostering a sense of belonging and purpose. So I urge you to support the YMCA's mission to combat the opioid crisis by providing the necessary funding. Together, we can make a difference, save lives, and build a brighter future. Thanks for your time, for all you're doing to combat the opioid crisis in Maine. I've submitted a longer testimony as well as our Maine YMCA's latest impact report.
Thank you. Questions? No? Well, thank you very much for the work that you do for our kids. Thank you. Terrence Miller. We have your testimony up
Great.
here.
Thank you. Good morning, members of the Maine Recovery Council. My name is Terrence Miller, and I'm the Advocacy Director at Preble Street. Every 10 days, a client at one of Preble Street's programs experiences an overdose. Every 10 days, Preble Street staff respond to those overdoses, reversing as many as possible and saving lives, compassionately utilizing their professional expertise on the front lines of this public health crisis. This year alone, Preble Street staff have responded to 36 overdoses, a record number for our agency. 31 of those 36 overdoses occurred in one of our 3 shelters: Elena's Way Wellness Shelter, Joe Chrysler Teen Shelter, or Florence House Women's Shelter. Often someone who overdoses refuses to go with the EMS to the hospital, and Preble Street staff are responsible for providing aftercare and advocating for other treatment and harm reduction strategies, since they are the trusted individuals. The opioid settlement funds must be used to address this public health crisis for low barrier shelters that are daily responding to the opioid crisis. Low barrier shelters are often a primary entry point for unsheltered community members who who have little to no access to social, behavioral, and medical service providers. The few low-barrier shelters in Maine are currently at capacity, severely limiting access. In addition, low-barrier shelters are further hampered by inadequate state revenue streams, causing deficits and creating imminent possibilities of shelter closures. Low-barrier shelters aim to ensure that individuals who may be actively using drugs, among others, can access a safe and consistent shelter environment. A year ago, Preble Street opened Elena's Way Wellness Shelter, which provides shelter to individuals who struggle with complicated mental health and substance use disorders and struggle in high-barrier shelter environments. Elena's Way provides 40 beds and 24-hour, 7-day-week support staff. More significant staffing requirements are needed because of the intensity of this work, which includes regular overdose prevention and the thoughtful, intensive aftercare that is required. Elena's Way is keeping people alive so that they can have the opportunity for recover. When Preble Street opened Elena's Way, it was with the understanding and expectation that the state would provide ongoing operating funds. Despite ongoing discussions with various state agencies, this has not happened. Currently, we have an $850,000 deficit for operating Elena's Way. This is unsustainable. Ongoing funding for low-barrier shelters on the front lines of this opioid crisis is critical so that Preble Street and others can continue saving lives. Elena's Way's 40 beds serve some of the most vulnerable individuals in southern Maine, keeping very ill people fed and warm and giving them their own bed to rest. When needed, we respond to and reverse overdoses, keeping people alive and giving them hope for recovery. Yesterday, I and others in this room spent the day helping unsheltered individuals as encampments were swept along Marginal Way. Without funding to keep Elena's Way open, the staff's life-saving harm reduction work cannot continue. Let us not make 40 more people struggle to live and survive outside without support. If Elena's Way closed its doors, the impact on the community would be devastating. With this critical funding, Maine can do better. Preble Street respectfully requests $850,000 from the opioids recovery funds to keep Elena's Way open, keeping people on the path to recovery and providing hope. Thank you.
Thank you, Terry. Thank you for what you do at Preble Street. I talked with Greg Payne about this yesterday. Just have two questions. When the state helped you open Elena's Way, and there was an expectation too that you would begin that for patients that were eligible for Maine care reimbursement, that there would be at least some portion that could be billed and reimbursed by Medicaid. Right. So my question is, have you started that? Are you able to do that? My second question was, it's my understanding that the emergency shelter funds, Greg was in our housing office, was pretty instrumental in getting a lot of that available the first year. Do we expect that any of that would be available in the second year? My third question is, when would you have to have this $850,000 to prevent any disruption to the 40 people that are there?
So in regards to the first question, yes, we have started to begun that. It's small at first, but we are starting that process of Medicare recovery. Second question is, we have a meeting today at 3:00 with Maine Housing regarding their long-term strategy because of the incredible migration of people from other parts of the state to Maine, to the city of Portland and southern Maine for shelter services. And so what is the response and how is that sustainable in the long run? So we are exploring that as well. And as regard to the $850,000, we are in need of that money within next year, early next year, in order to pay for that deficit.
That's very succinct answers to my three questions. They're very, very helpful.
I try.
Thank you very much. I've been trying to follow in the paper about the homeless encampments and how they're being taken down. And there was proposals in front of the city council in Portland to maybe increase the amount of shelter beds by 150. But I couldn't tell from the paper whether those were low barrier shelter beds, and I kind of assumed they were not.
Good assumption.
And even those were shut down. They said no.
Right. Well, so Preble Street put out a white paper with 7 viable solutions to the encampment crisis. None of those solutions have been followed up. The city was suggesting to put 150 more beds in a high barrier shelter that only had capacity for 208, where the staffing, they were lacking 20 full-time staff members in that shelter at the 208 number. So, and they weren't, the city never, during those conversations at the city council meeting, which I attended all of them, never were willing to discuss barriers and access to change the process from, as many of us know, this November, 179 Maine Welcome Immigration Shelter will be opening. And that will free up beds in the homeless service center that the city runs, but they're not willing to change the admission standards so that it's based upon need of the unsheltered individual instead of a first come, first serve, with some real high barriers there.
What you're saying is the city council was going to put in beds, spend the money on beds, but no additional staffing.
Support. Well, they were already down 20
Right.
for the 208. There was never, and that never went through. Then they went to 50 beds, and then the 50 beds also failed for the very reasons that I'm describing here.
Thank you.
You're welcome.
I have 2 questions. One I know the answer to, but for the purposes of everybody listening, could you help me understand the difference between no or low barrier shelter versus high barrier shelter?
Sure. As I stated in my testimony, low barrier it houses you, and it's a housing first sort of model. It's shelter for those that are needing, even if you're using. That's the low barrier model. And there also is other, it's not a voluntary first come, first serve. You don't have to get up at 4 a.m. Lights are not on in the shelter all night. There's a number of different qualifications for low barrier versus a higher barrier shelter.
Thank you. My follow-up question is, does Preble Street or anyone else in Portland or otherwise, all communities are struggling with unhousedness, do any peer-based community outreach in the encampments? And I emphasize peer as important in that. Yeah.
Right. Absolutely. We have a street outreach collaborative unit that I joined yesterday, and my Taylor Cray also on the advocacy team to support their work. They're out in those encampments daily, trying to identify housing and beds for those individuals, recovery programs, etc. So that's pretty extensive. There is also a warming shelter was just awarded from the state to Portland, and that was on the to a group at First Church, but with the Portland Peer Homeless group.
Thank you. That's something that I would be really interested in learning more about. My community, like many communities across Maine, are struggling with unhousedness and just wanting to get peers out into the community across Maine. Thank you.
Absolutely.
Other questions?
Thank you for your time.
Oh, thank you.
Really
Please. Thank you
appreciate
for
it.
the work that you do. It's
Thank you.
certainly, we're very grateful that you're there, and I'm sure that people unhoused are more than grateful that you're there.
Thank you.
Thank you. Thank you. So next up is, and I think I forgot to put on deck here, Katie White is up speaking, and then on deck is Scott Parody.
Thank you, everybody. My name is Dr. Katie Spencer White. I am the president and CEO at Mid-Maine Homeless Shelter and Services in Waterville. We are a year-round 55-bed low-barrier shelter. We serve people without regard to sobriety, mental health treatment, or criminal convictions. I am the 1-2 punch, as my colleague from Preble Street has just said, and I want to provide some additional context. There are 6 low barrier shelters in the state that are funded through state dollars. Those 6 have a total of 499 beds. 3 of these shelters serve the greater Portland area. We are the only year-round low barrier shelter serving Central Maine. There are 2 in Bangor. Penobscot Community Healthcare, I serve on their board, operates Hope House, which is about a 63 low barrier shelter, and the Bangor area shelter. We are all in desperate financial crisis. PCHC is in the midst of a multi-year loss this year. Their operating loss is about $800,000. We have a $500,000 operating loss. And Milestone Recovery, serving Portland, has an approximate $300,000 operating loss. The task of serving people who are in crisis is expensive. It's about $95 a day based on national studies and our own internal analysis. But for that $95 a day, we provide 24-hour services. We provide case management, which a lot of folks can't get through other avenues. And importantly, we're housing first. So we strive to get people out of shelters and into permanent housing, and then provide the after lease up housing first services that help them stay stable. We also reverse overdoses every day. I'm pleased, well, in 2022, we were unfortunate in that we had 2 losses. In order to prevent losses, and we do a lot of in-reach for folks in the community, in Waterville, we have about 100 folks who are outside right now. We do in-reach. We welcome them in to use showers, but we had to install very sophisticated reverse motion sensors so that our staff could be alerted when a bathroom was occupied, but nobody was moving. We also have an innovative risk stratification program, and I'm pleased to say that we have dramatically reduced our rate of overdoses, and we've had no deaths so far in 2023. The work of the low barrier shelter community is part of a continuum of services. We are both healthcare providers, because housing is a social determinant of health, and we are also housing providers. There's an inference that I've read into a lot of the proposed programs that the folks who are needing services are housed. I think we have to understand that that is not always the case. And importantly, there's an equity issue that I want to raise with you all. We know that people of color are disproportionately affected by homelessness. And you will see in my testimony, I referenced 2 studies that indicate, recent studies, national studies that indicate that the rate of overdose death for veterans is 10 times higher for unhoused veterans than all other veterans. And that importantly, the people most at risk from dying of overdose that are unhoused are white women. So we need to address the low barrier shelter crisis, and we need to make sure that people continue to have access to these services in order to make sure that they have hope for recovery. Otherwise, we'll leave them outside to die. Thank you, and I'm happy to take any questions.
Thank you. Well,
Hi, Katie. Thank you very much. I'm going to go back to some of the discussions we had with the gentleman from the Mid-Coast Recovery Coalition, talking about the levels of care. Do you feel that there are clients that you have in the low barrier shelter that would be better served and would be willing to go to a higher level of care if it was available?
Yes.
Thank you.
Thanks.
Thanks, Katie. I'm very interested in more information about the financial losses that you mentioned, and I don't know if you've included that in your testimony.
No, I've
But
kept
if
it
you
brief.
have that information generally for your organization or the other organizations that you mentioned, that's really about the existing infrastructure. And if that's not working financially, it'd be great for the council to hear more information
Yeah,
about.
and I think the high level, we can break that down and give you more specific data, but I think the high level piece of information that's critical for the council to understand is that state funding has not increased for shelters since 2017. Of course, since then, we've had about broadly almost 27% inflation rate over that number of years. And none of us can operate in 2023 or 2024 with a 2017 budget. So if you look at that $95 a day, we're getting about 22% of our funding from state sources. Many of us, particularly outside of Bangor and Portland, do not receive any municipal funding. So the math just doesn't work in terms of trying to operate a business. And importantly, we've made the transition at Mid-Maine Homeless Shelter and Services over the last 4 years from high barrier to low barrier. So I can tell you that the cost to hire and retain qualified staff, it's a very special individual who can engage with somebody who's got comorbid, major mental illness and substance use, reverse that overdose, get them to EMS, and have them back within a couple hours and make sure that they're safe for the next 23 hours. It takes a special individual. It's stress. Very often, I think our staff are forgotten frontline service workers in this crisis. So it comes at a premium. My wage bill has gone up almost 50%. Just so that I can retain the staff who can do that work. And then when they leave, I can't rehire them. So it's really critical that we do look at the finances, but a lot of it is just the basic cost of operating in order to recruit and retain the staff necessary to do the work and to maintain the buildings in a way that's safe so that we can do the work. The system that we have adopted, the Brave system, comes out of Canada. And that came with a $6,000 install, and we have to commit to $2,000 software updates annually. But that's the cost of doing business in a safe and effective manner.
Thank you for sharing that information. And also thank you for highlighting the workforce challenges and how that's contributing to the cost as well.
Any other questions? Thank you very much.
Thank
Thank
you.
you again for the work that you do. Scott, and then Tyler is up on deck after Scott.
This is always nerve-wracking for me, but thank you for allowing me to speak here today. My name is Scott Party. I'm a resident of Bangor and the president and founder of Fresh Start Incorporated. I'm also a board member of MAR, the Maine Association of Recovery Residences. A little history: Fresh Start's first house was purchased in October of 2018 by me as a way for the men I met weekly who were incarcerated. I did service work in Penobscot County Jail from 2014 up until COVID. I noticed that the same men going in and out of the jail were homeless and wanted recovery. I took funds from my retirement account and used this as a down payment for the first house on Ohio Street in Bangor. I knew absolutely nothing about recovery residences, but felt that this might be a way out for these men to have safe and affordable housing. I didn't know what I didn't know. I quickly became aware of MAR, the Maine Association of Recovery Residences, and through a series of connections and people who cared about Fresh Start, Fresh Start grew where it is today. 15, we have 15 buildings, 14 houses, and 116 beds. Fresh Start is fully self-supporting. Fresh Start is the largest of its kind in the state, and I believe the second largest recovery residences in New England. With all that, we are only providing a drop in the bucket of what is necessary for safe and affordable housing for those seeking recovery. My experience in this field has shown me that housing is the base of the pyramid. Without safe and affordable housing, recovery is almost impossible. We have recently started a social detox in Bangor, and now we need to branch out into smaller communities. This can only be accomplished with additional houses being purchased in smaller communities that in smaller communities. The services that are available in Bangor, Portland, and other larger cities are practically non-existent in smaller communities. Therefore, we will need to provide our own services. Fresh Start currently owns 11 properties in Bangor, one in Brewer. Fresh Start leases 2 other homes, one from the Bangor Area Homeless Shelter and one from the Bangor, from the barn in Brewer. Because Bangor is a service hub offering plenty of employment, services, and recovery meetings, we can afford the debt load of mortgages. In smaller communities where Fresh Start is needed desperately, Fresh Start will be able to supply such services as transportation, recovery meetings, and help with appointments, etc., providing we have no debt load. Providing Fresh Start with the funds needed for capital expenditures will allow us to carry on our mission and continue to be self-supporting. We know we need Fresh Start recovery homes in Dover Foxcroft, Waterville, Ellsworth, Calais, Holton, Augusta, and the Belfast Rockland area. With funds for homes, Fresh Start will be able to do in these towns and cities with the same that has been done in the Bangor area. What better way to support recovery from the opioid crisis than making an investment in Fresh Start, a proven facility? Be the change you want to see. Thank you.
Thank you, Scott. Thank you for your work. It's been amazing. Have you, I have 2 questions. One has to do with whether Fresh Start Inc. has been organized as a for-profit or a non-profit organization. And while you answer that, I'll think of the second one.
Okay. Yes, we were originally founded as a for-profit organization, and the reason is because I personally feel that we were able to grow quickly by being a for-profit rather than having a board and being a nonprofit. But in June, I applied to change the corporation to a nonprofit. It's been approved by the state of Maine. So as far as the state of Maine is concerned, we're a nonprofit. Everything has been submitted to the Internal Revenue Service and to be a 501c3. And that should take effect within the next few months.
I do think that makes it easier to get grants. My second question was, I have a working knowledge of this, but I bet there's a lot of people on the council and the audience that do not know the difference between a social detox and a traditional or maybe medical detox could you do that in a few sentences?
I can do it as best I can here, but what I know of it, a medical detox is where medical intervention is needed, whether it be alcohol. People die from alcohol and people die from benzos, etc. And in a social detox, I've spoken recently with Suzanne Farley of Wellsprings, because she runs Wellsprings has a medical detox in Hamden. And they receive a lot of people and a lot of requests where only a social detox is required. But this helps alleviate that. Our social detox is peer run. It's to get people stable from opioids, for instance. We have partnered with Savita Health. They're in our same building now. We purchased a building in Bangor on Center Street. And the first half of the first floor is Savita Health, and they provide MAT and they provide comfort to people in our social detox. I hope I did that right.
Yeah, I think so. I mean, as you know, the Wellsprings detox was begun as a social detox.
Yep.
It was not successful financially, so then it was converted. So, I mean, there's a lot to this, but I wanted people to understand the difference. Then thank you.
Amen. Sure. Anyone else? Oh, Scott, thank you. You know how I sing your praises. So thank you. Tyler is up, and then James is on deck.
My name is Tyler Shanahan. I reside at a Bangor MAR certified Fresh Start house. I'm not going to bore you with my story. I'm going to shorten it up a bit, but my addiction had landed me in Kensington, Philadelphia. And when I returned home to Maine after getting out of my sixth rehab, I knew a geographic change wouldn't fix my problems, but at least I would be home where the remainder of my support network was. At first, I stayed with some friends who I thought of as my second family, but that was short-lived because even though I was sober and in recovery, they said they couldn't trust an addict to be in their home. I was homeless again. Thankfully, I ended up in my hometown of Bangor, and that gave me some comfort. I wasn't familiar with the recovery community in Bangor at all, but I met somebody who helped connect me to Fresh Start. Typically, I have a difficult time with change, but Fresh Start has made it easy for me to adjust to a new and better way of living. Since being welcomed into Fresh Start, I've become familiar with several sober resources within my community. My support network has multiplied considerably. I've found meaning in life through a necessary relationship with my higher power, and I'm learning how to live honestly. Thanks to Fresh Start, I know a new freedom and happiness. I do not regret my past, and I embrace it. And I am working two jobs that I absolutely love, one doing recovery capital assessments for Fresh Start and another working with the homeless youth of Bangor at the Shaw House. I see how my experience, strength, and hope can benefit others. But most importantly, Fresh Start has made me a part of something greater than myself. And this is my new dream coming true. So thank you.
Thank you. I can't tell you how much that last line it just warms my heart that this is a life worth living. So thank you. Up next is James, and then on deck is Elizabeth Smoney.
Good afternoon. Unlike Scott and Tyler, I'm not really nervous. I enjoy speaking. I've been to a couple of these events like this, and I really enjoy getting a chance to talk about Fresh Start and getting to just kind of touch base with and network with some of the other folks that are here. Thank you, Tyler, for sharing your story. That was pretty brave of you. And I just want to take one quick second to thank the people who brought testimony from residents at some of the facilities that they came from today. Those are that's incredible and very much appreciated. So my name is James Rickroad. I'm a 20-year resident of Bangor and an alcoholic and an addict in long-term recovery. Been the general manager of Fresh Start Sober Living since we first opened in October of 2018. Fresh Start provides safe, affordable housing for people in recovery from drugs and alcohol. We currently have 14 homes totaling 116 beds, and we're full with a waiting list. All Fresh Start homes are certified by Maine Association of Recovery Residences. Fresh Start staff works hard daily to maintain compliance with MARS safety and ethics standards. In the past 5 years, we have helped several hundred people. We've began in the last 2 years, I think, to do some good data collection. But my estimate would be we've had well over 500 people come through our doors of our various residences. We've helped those people have safe, affordable housing and remain abstinent from drugs and alcohol use. My involvement with Fresh Start has allowed me to be free from active addiction for over 6 years. Fresh Start has afforded me the opportunity to become. Thank you. Fresh Start has afforded me an opportunity to become a productive member of our community and given me the chance to help many addicts and alcoholics achieve and maintain sobriety. Fresh Start could use funding to increase our bed capacity, add programming to our newly established social detox facility, and to add support staff for our current members. All these improvements would give us the ability to provide a better service to our community and help us continue doing the great work that we've started. I also wanted to add that we're pretty excited about maybe having the opportunity to branch out into some of the more rural areas and smaller communities. They've been hearing that for the last 2 or 3 years, and we've gotten a lot of push. And like Scott expressed, it can be a lot more higher operating costs operating outside of kind of central hubs. So we're pretty excited about that. We really hope to spread out a little bit. And I can't tell you how much Fresh Start has done for our community in the 3 minutes that you've given me. But I hope that you've all listened very closely to the members and staff that have testified today. And I appreciate your time today. And thank you for allowing me to weigh in on this important topic. And I'm always happy to answer questions.
Thank you, James. Question?
Hi, thank you for sharing. Could you tell me how much your monthly rent is for folks? How much do they pay to be there?
Am I still on? Yeah, our members pay $710 a month. They can pay weekly at 165 per week, or they could pay 710 per month.
I noticed that you call them members where other people called them residents, or is there a reason for that?
So I think initially we called our residents members because it helped them maybe feel more a part of something and not just like a tenant or something. And until LD 597 passed, there was some issues with discharging. So do you discharge a member or do you evict a tenant? You know, so I think some of this has just kind of started to get fleshed out and hashed out, some of the barriers that we faced. And again, I think we call them members because we have Fresh Start members who are not residents. We have alumni members. We have honorary members. We have an incredible number of people that support our community, support what we do from our community and different organizations that we consider members. So, you know, what we've built a big organization full of members.
Okay.
Any other questions? Well, James, thank you very much.
Hi, James. The houses that you have, do you have a tier system? Like, does someone come in and get their own bedroom, or do they share a room, or is there 4 people to a room or 3? How does that work a little bit?
Okay, so we do have a phase system. People come in at phase 1. And it's somewhat restrictive. In phase 2, it opens up a little bit, and then phase 3. But as far as how we house people, most of our beds are in single rooms. Most of them. We have if I had to guess, I would say 6 to 8 2-bed rooms, but most of them come into single rooms. So with having as many buildings as we have, we're really able to assess our clients or assess our members as they come in, or applicants when they come in, and put them in a space, in a house where we think they're going to get the level of care that they need. So like we've heard, and like we've heard said, that we kind of are halfway houses. We kind of are taking on some of the roles of some of the detoxes and treatment centers because it's just not available. So we kind of assess our clients or our members, and as they progress, we can maybe move them to a house that's a little more stable, has maybe a little more long-term clients. Okay, maybe you got a house with 8 or 9 members and most of them work during the day. So, you know, somebody doesn't need to have, you know, a bunch of support right there, or maybe 3 or 4 different people that they can reach out to daily. We would put in a house like that. We would put somebody who just came maybe off the streets or just came from a detox, doesn't have much recovery capital. We have a great system for assessing recovery capital. And, you know, so a lot of that stuff comes from our initial assessment when people come in, and then as follow-up assessments, recovery capital assessments. And just, you know, there are different people have different needs, different personalities. I'm really flexible with the multiple facilities to be able to move them around. But most people come in in a single room. Some people come into a double room, and generally within 30 days at the most, if they've been successful with us, followed our rules, met our requirements, they would move into a single room.
Thank you.
Thank you.
Thanks
very much. Elizabeth Simone, and then on deck is Brent Benedetto. Hey, Elizabeth.
Hello, Pat. Good afternoon, members of the Maine Recovery Council. Thank you so much for the work that you're doing and the time that you're spending listening to the community today. I actually came just to listen, and I got an email when I arrived from a Mr. Todd Crawford, who is the statewide coordinator for Maine's treatment courts. He was hoping to provide testimony today and was unable to be here. I did not receive any testimony from Mr. Crawford, so I used my imagination and thought about.
Oh no, this could be dangerous, Elizabeth.
It could be really dangerous, right?
You know.
I know. I think I might know some of the things that he may have said to you, and I'll be brief. Maine benefits from a system of treatment recovery courts. The first court was established in 1996, and then the current configuration really began in the 2000-2001. Right now we have 15 courts in Maine. We have 3 family recovery courts, 1 co-occurring disorders court, 2 veterans courts, and 7 adult treatment recovery courts. There is current planning for court development and implementation in Aroostook County for an adult court and in Portland for another family recovery court. Treatment recovery courts started in the 1980s. And as some of you probably know, they are the most deeply researched criminal, legal, clinical interventions that we've seen in our history. There are national best practice standards for these courts, and there are specializations among the courts, as I mentioned, for family recovery, veterans, mental health, co-occurring, and of course, substance use disorder. They are a configuration of a multidisciplinary team led by a judge, prosecutor, defender, probation officer, peer professional, treatment provider, and case managers. The efforts that we make in Maine are predicated largely on what the outcomes can be, and we gather data very carefully to be able to evaluate these courts. The last independent evaluation of these courts statewide was December of 2000, and that indicated that we had greatly reduced rates of recidivism as compared to any other criminal justice interventions, and we had greatly reduced rates of recidivism compared to other national drug courts. So Maine has a star cast. These things work. We also showed a slightly, it's still statistically significant, but a decrease in mortality rates in these courts. People who participate, even if they do not commence from these courts, are shown by Maine data to have decreased rates of recidivism and decreased rates of overdose just from being in the program for a period of time. When I walked in today, I saw someone that completed one of the treatment recovery courts, and I was very happy to see him. And he said, "Oh, you're testifying." And I said, "No, I'm just listening. I want to hear what Maine needs." And he said, "No, I want you to get up there and testify because we need more of these courts." These courts are kind of small. We have 241 people participating today in these courts across Maine. We usually have about 500 that go through in a year. We probably could serve more people. But what I wanted to do, and this is my risk in reading Todd Crawford's email and mine, is talk about what might be important. And it's not actually an ask for treatment court. What it is we need access to transportation so people can get to and from care and to court. We need paid peer professionals. We already have some, but we need more. We need recovery residences, and we need safe and affordable housing. We need training and education for professionals so that they can uphold those important national standards. We need independent evaluation every few years so that we can hold ourselves accountable and know that we're not doing harm. And then finally, and probably most critical on this list, is access to residential detox and treatment beds. I will end with this. 3 people that I know in Maine all have something in common. One is an astrophysicist, one is an elected official, one is a licensed treatment provider. Those 3 people are all graduates of these treatment courts. Thank you.
Thank you, Elizabeth. I'll take questions. Please tell that he can still submit testimony. He just has to do it online and we will all see you back.
Thank you.
Hello, Elizabeth. It's nice to see you. You might be talking about me when you're talking about an elected official who is a graduate of the treatment court. So send my thanks to Judge Walker and to the entire family court in Kennebec County for all that you've done for me and for my husband too. My husband's a graduate too. So not only did I get my life back, but I also met a phenomenal husband. So that is not my question. My question is, has there been any about youth treatment courts as it used to be one in Maine? Can we have that? Has that conversation happened, or is there any willingness to have that conversation?
I have not been party to any of those conversations. I was around when there were 6 juvenile treatment courts in Maine that were defunded. So I think it's a great conversation to have. I think one of the concerns I have, and you and I have talked about it, is treatment courts are just one way to get into and sustain recovery. And I worry about getting more people into the criminal legal system. So if there was a way to nuance it very carefully so that we didn't increase the exposure to further incarceration or penalties for young adults, that would be great. Thank you. Yes, sir.
With the youth courts that you were talking about, Courtney and Elizabeth, are those similar to the Restorative Justice Project, or is that a different? Do they do the same things? Do you?
I am not an expert in this. There are different ways to apply models or to build models. So you could have a court where a young adult had a charge pending, and in exchange for saying, I'm holding myself responsible for that, treatment is given, case management, and then perhaps that charge is dissolved. That's a little bit different than restorative justice, but we often see overlays of RJ onto those types of juvenile interventions.
Thank you.
Thank you.
Any other questions?
Thank
It was nice to see you.
Nice to see you.
And thank you for all the work that you do. Thanks, Elizabeth. All right, we have Brent up and then a Michael, and I cannot pronounce your name. Is that Shanop? Shanop is on deck. Hi, Brent.
Hi, thank you, Chair Kimball and distinguished members of the council. My name is Brent Benedetto. I'm a journeyer at the B. Simpler Recovery Homes located in the Greater Portland area. I wanted to speak to you guys about, we've heard it here earlier, some transportation issues for people in recovery. I will give my personal experiences with some of those issues. I was trying to get my girlfriend at the time, who would later become the mother of my child. I didn't know of her whereabouts, and she contacted me and she informed me she was in a trap house and she wanted to get out of there. I did not have my license at the time, but I knew that I had to act, and I had to act quickly because the window of opportunity decreases by the second in situations like that. I was able to get to her. She was not in a condition to drive, so I took it upon myself to drive her car. She came with me. She came out of the house, but in the process, as I was driving back, I was pulled over and I was arrested for driving with a suspended license. That's one instance. The other one was shortly thereafter. I was taking her to a treatment facility located about 5 hours away, and I had made it up there safely somehow. And on the way back, I was again pulled over and I was arrested and jailed for driving with a suspended license. Sure, it would be easy to say, don't drive with a suspended license and, these things won't happen. I can obviously agree with that. But furthermore, aside from, the clinical accessibility issues we're having with getting people to treatment in rural areas, also getting journeyers like myself more access to other meetings, other self-help meetings, commitments, where you would go and share your personal experience. Also just to expand personal relationships, you hear that the opposite of addiction is connection, and establishing meaningful connections in this process are imperative, and providing reliable, safe transportation will help expand not only your sober network, but those meaningful connections, the relationships. I'm from New York. My daughter's 5 hours away from me, and I have issues getting to and from. Airfare is expensive, train tickets are expensive, and finding somebody that will drive 5 hours on their own will and at their willingness to do so is difficult. And the Be Driven program, which you will hear more about, will provide transportation, safe, reliable transportation for people in recovery by people in recovery. So just wanted to give my experience. I'm good.
Thank you. Questions? No, thank you for bringing the issue of transportation in a very rural state with very poor transportation. It's an important issue. Thank you. Michael, and then Corey Mason, I think.
Good afternoon, Council. My name is Michael Schnaps, and I'm a person in recovery. I'm also the intake specialist for Be Simpler Active Recovery Homes and the house manager for Tranquility House in Portland. I'm also the wellness driver for Be Driven. I'm here to solve the following challenge. Earlier this week, I was working with Cumberland County House of Corrections and Cumberland County Drug Court. I had a journeyer who I was working with to enter our recovery home, who we had offered at the time safe and reliable transportation to our house, bed-to-bed service. Such journeyer denied. I had multiple conversations with said journeyer's probation officer, and she advised me he was released at 6 p.m. He did not arrive to my home until almost 10 p.m. And now typically I would not accept someone at that time. But under the conditions and of him just being released, I wanted to make sure he had a safe, warm house to come to. Upon being there, 30 minutes later, this journeyer had been found overdosed on the porch by other members of the home. This could have been prevented. Among that, I provide our journeyers safe and reliable transportation for a number of different reasons, some being rides to work, meetings, visits with their children. Another one being picking Brent up from treatment in New York and bringing him to our recovery home, making sure that he made it there safe and secure, as well as many other wellness trips throughout the greater Portland and more. Thank you.
Thank you. Can you stay for questions for a sec?
Sure.
So this is what you handed out.
Yes, and Corey has more information on that. I can speak solely on what I do for that on a daily basis. And that usually involves driving, any one of our journeyers in one of our 4 homes to many different appointments, whether it's general assistance, the recovery center, meetings, grocery shopping. The list goes on and on.
Maybe I'm supposed to ask the next person that comes up, but if you don't know the answer, they can answer. Is this just for folks that are in your recovery residences, or
No,
it's like
this is-
a whole thing?
This is for the whole state of Maine.
Okay, thanks.
Great, thank you. And Corey is up. And then after Corey is a Stephen Knockwood is on deck.
First and foremost, thank you guys for being vulnerable and being you. And all as well, thank you all here. My name is Corey. I'm some guy. I'm very fortunate to be the founder of Be Driven, an active recovery lifestyle partner. We Be Simpler. As you heard, I'm the Chief Equanimity Officer for Be Simpler. We have 4 homes in Maine and 1 in New Hampshire. We touch York and also Cumberland County. Be Driven exists to assist non-emergency transportation services to the journeyer statewide to locations that are not covered underneath health insurance, and more importantly, not being provided by the DOT or other existing rideshare services. My goal is to work with you and to work with everyone statewide to go ahead and to bridge the gaps from recovery to resources. My goal is to go ahead and work with you and everyone else so now I get like 4.5 minutes. Can we reset the clock?
Yeah.
Yes, nice, good. All right. I heard them say yes. All right. My goal is to ultimately bring journeyers to where recovery lives. My goal is to go ahead and help journeyers have zero shame or jabbing occurring when he or she gets into a vehicle. Judgment, abandonment, blame, and shame, if you don't know what jabs are. My goal is to go ahead and more importantly, provide free transportation for the journeyer to access these resources where recovery-friendly partners live. We're talking about resource centers. We're talking about incarceration. We're talking about other recovery residences. We've heard here by over 8 people, as I've been keeping semi count of who's indicated that transportation is a big challenge. A few of you members have also recognized and also supported this initiative as well. My goal is to hopefully employ over 96 team members statewide by doing so. As a fellow Rotarian, I believe in service above, self before service before self. I work with other Rotarians who are willing to go ahead and volunteer. Right now it's happening for Maine Works. I'm just going to drop names. I shouldn't do that, but that's neither here. That's one of the biggest expenses that they have in getting journeyers to work. There's a big initiative statewide right now called the Recovery Friendly Workplace. Really fortunate to help launch the second annual Build and Recovery Ready Communities Conference with Chief McKenzie and introduce RFW options. How are journeyers going to get to work? How are journeyers going to go ahead and get to their employment options if they don't have a car? If they're Brent, who's willing to go ahead and do what it takes to get to work, I've done that. At the end of the day, we want to help the journeyer reduce the stigma. Can they get to work? Can they get to recovery? Can they get the IOP? Can they get the PHP? What can they get to all the different things? We've been challenged ultimately of making sure we have safe door-to-door services. Right now, there's Uber rides, there's bus tickets. Journeyers coming out of incarceration cannot get to DHHS without a license. They can't get their EBT cards without driving. Fresh Start, we're all ponying this stuff up. Not to use slang, but we're all paying for that. As a recovery residents, we have ultimately an unseen budget to go ahead and help a journey get to his or her next location to help him or her stay off the street. At the end of the day, I'm asking you to go ahead and why are we going to be different? I just want to pontificate on this. Our goal is to have every driver be CPR certified, to go through the mental health first aid training, to go ahead and actually perform the naloxone training. We're going to require the journeyer who's going to be driving that vehicle to provide a full, safe transportation. Because at the end of the day, we're probably going to be picking someone up who has used. At the end of the day, we're going to bring him or her to a location where we know it's a safe location. Furthermore, the vehicles are going to be a little bit different than your typical ride shares because we are going to require interlocks in all of our cars. We are going to have safety cameras in all of our vehicles. Males will only drive males and females will only drive females. In the event it's a co-ed drive, I make a reservation. That's going to happen. The other difference that we're working on is actually developing an app. We've heard a lot about resources. We're building that into the Be Simpler community. And underneath that, ultimately, will be the ability to do reservations for trips to resources. So where recovery lives. My goal is to be statewide. And we're only going to get there with a little bit of your help. We're looking to ask you for help to help the journeyers go to recovery-friendly workplaces, recovery-friendly partners. We're not looking for your assistance to buy the vehicles, pay for the insurances, or the professional development of the journeyer. And that's what they are. The journeyer who's going to be driving those vehicles will be PDs. So we're asking you to help fund a journeyer who's going to be picked up at a home, at incarceration, at a recovery center to get to his or her certified location. We're not asking for help to go ahead and pay for someone to go to Johnny's house to go get a bump and then return back. We're asking you to, or actually go to the movies, which heck, that'd be nice these days sometimes. But the reality is, no, we're asking you to help bridge the gap to where recovery lives. We'll take care of the rest. We'll have adequate reporting. We'll have adequate, feedback for you. I'll pause myself because I think there's no clock, which is okay.
Thank you.
And by the way, we use the term journeyer, not resident or guest or member, because quite frankly, we're all journeyers. And, there's a really great magazine that's out there too called Journey Magazine, but that happened, but that's neither here nor there. But we're all journeyers. And so we're looking to go ahead and provide safe and wellness trips for the journeyers.
Thank you.
Thank you. By the way, you got a small snippet of like a 145-page business plan last night in your email.
That actually is my question. This is phenomenal.
Okay.
Great.
Thank you.
Is it a nonprofit or a for-profit?
So we're a social enterprise, nonprofit called Be Gentle up here, for-profit Be Simpler, for-profit Be Driven.
Okay.
Quite frankly, this way we kind of like we've heard other people, just for what's right.
Well,
Yes, Miles?
Is this currently in the works? Are you doing this now?
I'm actually in debt with a few bankers right now, and I have a beautiful Chrysler Pacifica S that's got leather interior, and I can't get my significant other to take that instead of our Audi. We have multiple vehicles ready to go and looking for it. And as you heard, Michael's a driver today. I will be driving Brent, just to be transparent, to New York when he meets a specific step in his active recovery lifestyle. We pick up dogs. We pick up things that, ultimately is going to help someone stay off the street and, all, relapse. So it's in production. Yes.
Thank you.
And how long have you been doing this?
Technically, I want to argue that we've been doing it since the day that Be Simpler has existed, but Be Driven's concept and modeling, and quite frankly, like cash flow analysis paralysis I have, has been under works for over a year.
Yeah. Thank you.
Yeah. Thank you.
Any other questions?
I really want Bruce to ask me a question because he's got a nice voice.
I will ask you questions at the next statewide meeting.
Deal.
Thank you.
Thank you very much.
Thank you all. Safe travels.
Thank you. I believe Stephen Knockwood is up, and then I think it says, trying to read writing, Marshall Mercier is on deck. Stephen?
First, I'd like to acknowledge Pat Kimball and the rest of this amazing group of individuals that comprise this council. My name is Steve Knockwood. I'm first and foremost a Indigenous First Nation individual. I am a resident of Kennebec County and here of Augusta. I'd like to begin, and a lot of what I have to say is surrounding very, very difficult subject matter, and I want to make sure that we create a space that is non-judgmental, and for all to be able to speak. The first thing I'd like to point out is through LD 1722 in the Memorandum of Understanding, it was eminently clear that we wished that we could comprise a council and that this money could go to the communities in which were in fact intentionally targeted by Big Pharma. A little bit more into this, those communities were Native American communities. They were the fishing communities of our coastal area. They are our smaller rural communities that lacked sufficient health care and services, which left them extremely vulnerable to the poisons that Big Pharma decided to deal. So in that, I'd like to point out the fact that, we have already set forth guardrails in both those articles on where to spend this money. Another point I'd like to make is during the process of LD 1722 and the Memorandum of Understanding, it was made very clear that the state of Maine took the stance that our Indigenous communities had received their piece of the pie of the settlement. A little bit of clarity around that it equates to $3 million to be divided between 4 communities for the next 15 years. That's a few drops of water in a desert. And furthermore, during the course of this court case, the state of Maine, municipalities all used data collection, which included that community along with other marginalized communities. So the first thing I hope people can understand is that the system of recovery in the state of Maine in the United States is a colonial system that we need to invest in community and culture-based systems of care. I'd also point out the harm that has been caused by prevention methodology of the past, which was embedded with shame, isolation, and stigma, And we need prevention models to implement and cultivate harm reduction principles within these systems. Thank you.
Thank you, Steve. Wait, other questions? None? Thank you very much. Thank you. Marshall Mercier is up. Mercer?
Yep.
And Tess Parks is on deck.
Hello, friends. Thank you for having me here. My name is Marshall Mercer, formerly incarcerated, unhoused, and in my own recovery program, designed for me, by me, and now the executive director of Hope Brokers Incorporated, a 501(c) that was created to focus on the marginalized communities of Augusta, Maine. Since I have walked this path of recovery, I've excelled beyond and in many ways I never thought I could, while becoming a leader in this community when I was once an enemy. I was able to do so because I was welcomed to a space to grow in my recovery and given the tools to succeed by my peers. When I was in active use in the past, there weren't many programs available to help people like me or my peers. Since this whole big pharma scandal and they hit the recovery community, I truly feel like this all has become a money grab. I have personally sat before councils like this where we were promised representation from the marginalized community that would have been appointed to make these very decisions. None of that has happened. I'd like to see this money invested in such things like new programs created focused to building recovery communities that's more welcoming in the BIPOC communities and the LGBTQI communities. Or more spaces welcome to those that may be unhoused and still in active use. The recovery center here in Augusta closed the doors last year in the middle of the winter because we weren't equipped to do so. We the people are not blind. We will not sit and continue to be forgotten about while countless amount of money is thrown to police departments as well as other organizations that never even set foot in the marginalized communities of Maine. And to be honest, I'm really concerned to where this money is going to be spent. For far too long, we've allowed so-called professionals that prescribe drugs to run the show. And still, the accidental overdoses remain skyrocket. I'd like to think that it's a time for a change. I believe it's time we invest more into peer support initiatives in the harm reduction community and begin to create programs for the people, by the people. That's really all I got. Have any questions?
Marshall.
Shoot.
Marshall, thank you very much. You're a person in recovery. In your recovery, what can you point to one or two things in your recovery that were the most helpful that we could spend this money on?
Absolutely, more peer support. I have been a criminal most of my life. I'm addicted to drugs, the game, and I couldn't find people to accept me or to even help me find purpose in life. It took peers of my own kind to accept me into a community, which was Machias, of all places, to accept me to be who I was and to allow me to be in leadership positions to help my own people. Since then, I've helped probably over 100 people get off the streets, find recovery, connect to resources who came to me who wouldn't normally come to nobody else. Because we come to these places to never black heads in the community, for us, by us. There's never leaders that are in the BIPOC community sitting on these seats and making decisions for us. It's always white people who don't really know what the hell we're going through. We would like to see more people of color in these positions leading for us. That's really what we'd like to see. That's it. Any more questions? Sorry.
No, thank you very much for your time. Thank you.
Thank you.
Tess Parks. She had to leave. Okay. John Reynolds, and on deck is Jeannie Markey.
Good afternoon. Please bear with me. I just had some dental work a week ago, so still pretty sore. Good afternoon, esteemed members of the Recovery Council of Maine. Hello, my name is John. I'm a person in recovery, and I'm also not supposed to be alive. I feel like it's important to say that because I'm one of the lucky ones who managed to escape the death of this insidious disease many times. But that's not the case for many Mainers. I overdosed in a hotel room 2 years ago, almost to the day. The people I was with did not have Narcan and did not call 911. The Good Samaritan law did not exist at the time. I consider myself extremely fortunate to be alive. The reasons for so many unnecessary deaths in the state of Maine range all the way from stigma down to access to naloxone. In my job as a community organizer for Mobilized Recovery, I address both of those things. What I do 40 hours a week is I go door to door and I go door to door in the Kennebec County region, knocking on doors to have a simple conversation, to have a simple talk about what our community members know about naloxone and the Good Samaritan law. More often than not, I am greeted with a warm welcome. Some are even overjoyed about the program because they have personal ties to addiction or have lost some close loved ones. But there are also such circumstances where people answer the door and they are either misinformed or have a predisposed idea of what Narcan is. It takes me knocking on their door, having a face-to-face interaction with them, and making the connection to talk about the importance of Narcan for them to be able to put a face to it. The stigmas around naloxone and its purposes have been ingrained heavily in some of the people. It's usually after a solid 3 to 5 minute conversation with me and my teammates that the members of our community are able to personalize the disease and see the benefits of its life-saving measures. I then ask them if they would like to be trained. If they accept it, I train them right there on the spot, sometimes in their kitchen of their home or on their front steps of their porch. Before I leave, I always give them a bag with 2 boxes of naloxone and a brief description of the Good Samaritan law and how to use it. There have been many times that more times than I can count, where I have encountered someone in the community that has had a stigma against naloxone and tries to shudder me away quickly. I feel if it weren't for me coming to them, knocking on the door and having a personal conversation about how it has saved my life and who I am today, their stigma would have been reinforced. In fact, in most cases where the person started out adamantly against it, after I give them some facts about its usefulness and some info from my personal testimony, almost always do they change their minds and hearts. I feel like there needs to be more funding for programs that spread naloxone and its information. I know if it wasn't for me going to these people's houses and having these difficult but important conversations, that 4,000 less people in the Kennebec County area would not have Narcan readily available and not have been trained how to administer it. It's the face-to-face interaction and connections that's helping break the stigmas around substance use and overdose. Sharing the importance and educating people on naloxone is what helps them change their minds. I'll leave it with a quick story. What is the price on a human being? If there is one, I don't know what that price is. But I do know that because of the efforts of our work, that a person's life was saved. The direct action of me training someone how to administer naloxone and giving it to them made them not only have it, but be ready to use it and save a life. That's exactly what that person did at Mill Park this past summer. After they saved that person's life, they called me practically in tears because they were so happy that I had trained them and given him the necessary tools to be able to save someone's life. This is just one direct result, but I'm sure there are many more situations where, because of the training and the Narcan that we have provided, that a member of our community is alive today. Thank you very much for your time and consideration. If you have any questions, I'm here to answer them.
Thank you.
Also, thank you for bearing with me.
John, I'm going to put you on the spot. You don't know how beautiful that sounded coming from you. I'm hoping that because you've been called out, not by name, but that you are someone who's graduated from treatment court. And I know this is unrelated, but if you can just talk quickly about how important that was to your recovery and where you are today, clearly doing great things in the community.
Thank you so much, Bruce. And hey, I finally got him to talk. So I'm here today in a work capacity. I truly believe in the work I do. But me as a person, I just recently graduated from the co-occurring disorder courts treatment court. Thank you. In May of this year. And geez, I have multiple friends who are still on the court, and I don't even want to call them like, I look up to them, but some of the people that I really care about in this community, that I take their opinions and their advice on life personal, are also graduates from the court. I'm not saying that the court is exactly what changed their life, but I know for me, it was the conduit to which I found what changed my life. It references back to what Marshall said, peer support. I believe that the courts need to have more peer support from alumni that was currently or passed on the court. I really truly believe that the court works. It helped for me to facilitate a better relationship with the law enforcement. It helped me to be able to get some structure in my life. The length of the court was what was the most important to me. I've done recovery programs before, 6 months rehabs, 3-month rehab, 30-day rehabs. Nothing ever worked. It wasn't substantial long enough. The length of the court was what was most impactful to me, because the shortest you can do it is 13 months. And that's if you do it perfectly. In those 13 months, provided with the stability that the courts provide you and the tools that they give you while you're on there, the case management, and it's about the community connections too. They don't necessarily tell you that, but the more community involvement you get while you're on the court, the more successful you'll be. So if you can integrate more community supports while somebody's on the court, more peer support, and get more people on the court, get them out of the jails. They don't need to be in jail. If you have more staff on the court, you'll be able to take more people onto it, pull them out of the jail, give them the opportunity to be able to find recovery and be able to make it somewhere. Thank you, Bruce. Love you, brother.
John, so I'm clear, you go just from door to door, just like political canvassing.
Exactly.
But with something much more important.
Yeah.
How are you funded?
It's actually funded through the ARPA. It's through a grant through Kennebec County.
Okay.
Yep.
But
it's only funded for 2 years. So
are there other people in the state doing that?
I believe we're the first. And it's funny you said that. I just talked to somebody out in the hallway and they were saying we need to do a statewide initiative. This needs to be done more. You know what I mean? I can only speak for Kennebec County, but often people are from other counties asking me to go there. I can't do it because it's not within the guidelines of my grant.
Okay. Thank you.
Thank you. Yeah.
Thank you.
Thank you.
Thank you very much. Jeannie, and then Molly Riddle.
Hi, thank you for listening. To the Maine Recovery Council. First off, I want to thank you for taking testimonies of impacted family members. I am Jean Marquis of the Maine Recovery Advocacy Project. I also canvass with John, door to door. And I'm the mother of an adult son who I'm very proud to say is 2 years sober. I'm so excited. But now we're in the process of dealing with his underlying mental health issues which led to this substance use. You see, my son suffers from medicated resistant depression, ADHD, and a debilitating social anxiety that has him trapped in his own world, literally trapped in his own world. Yet, late in his teens, he discovered that alcohol and opiates unlock this world. He was able to socialize. He was able to go to community college, and he was able to hold down a part-time job. However, it didn't take him long for his substance-fueled world to crash in on him. Opiates nearly killed him a few times. Yet with the help of therapies, and he worked really hard to beat these addictions. But now that he's sober, he is unfortunately back in that very, very small world by his mental illnesses. So we're struggling to find mental health services of the quality that he needs. And we're not alone in this struggle. People in recovery need access to affordable mental health providers who are knowledgeable of the direct connection between mental health and substance use. And these are the barriers that I'm seeing. I see 3 barriers. And these I'd love to see removed by the opiate settlement funds. The first one is lack of affordability. Many psychiatrists refuse to use Maine Care. And these are the level of psychiatrists that my son really, really needs. And you have to pay out of pocket. That pocket's mine. Just pure and simple. And the second barrier is the lack of expedient accessibility. Because we have such shortages in the state of Maine, and also probably nationwide, it takes months to get to a therapist. And in the world of recovery, months are risky. Days are risky because it's during those gaps when overdoses happen. And I've seen that with my son. And the third something, I'll wrap this up. I'm sorry. The third barrier is we need practitioners who understand the connection between substance use and mental health. In our experience of searching for the right therapist, we're finding therapists are either knowledgeable in one area, but not the other. But and with dual diagnosis, if you don't stabilize one, the other will happen. You have to have people who are knowledgeable with lived experience. That's essential. And to close, remember the stories that you're hearing today as you allocate this money. Please make sure these funds go to people who suffered from opiate addiction, not to the people who will incarcerate them, and not to professionals. They're not fully educated to help them in the manner they so desperately need. Thank you for listening.
Questions? Thank you for being a constant advocate for your son. Thank you.
Well, thank you for all the work you do. Thank you.
Thank you. Molly, and then Leslie Clark is on deck.
Hello, everyone. I prepared this on my way here, so I apologize for not having a hard copy for you, but I did submit it. My name is Molly Riddle, and I was raised in Washington County and now reside in Hancock County. I work for Volunteers of America as their Maine Recovery Coach Site Coordinator for Waldo and Knox counties, embedded in the community and in corrections. However, I am not here on behalf of my agency, but rather testifying as a proud member of the recovery community, affected other, and recovery ally. In 2017, I lost my brother-in-law, Hunter Austin, to accidental overdose. Christmas 2018, I lost my mother, Nancy Perry, to drug-related causes. In 2020, I lost my big brother, Ben Perry, to fatal accidental overdose. And in 2021, I lost my cousin, Jason Smith, to accidental overdose. I am a mere drop in a sea of suffering. After these devastating losses and watching how my home community in Down East Maine was impacted by stigma and grief, I started to recognize a pattern. The vicious cycle of overprescribing, overmedicating, spread of misinformation, misdiagnosis, isolation, and greed all played their part in destroying what I used to call home. But with the help of my support system, I was able to find hope again. Hope in knowing that I may be able to make a difference and stand shoulder to shoulder with people who have lost someone to the strategically directed assault on our communities by Big Pharma. The only way I was able to do this was taking advantage of the free education that was offered to the citizens of Maine to participate in the CCAR Recovery Coach Academy. As a person who is in debt with student loans and no hope for furthering my education financially, this was an incredible opportunity. The training flipped my perspective on substance use disorder and aided in my own personal growth and healing. One of the main objectives of these funds is to help Maine citizens recover from addiction. I believe that the knowledge and tools I gained through the 5-day free training made more of a difference in my life than the 4 tireless years I spent obtaining my degree in communications. And providing more free education access to the public, I believe it would be a positive impact for prevention, support, and decrease the rate of fatal overdoses in Maine. The more the public is prepared to handle this epidemic, the better. To break down barriers for Maine citizens who are of the working class to participate in free education and training could save lives and rebuild what we have left from the wreckage of the epidemic. I have now worked as a recovery coach and a site coordinator for over a year now, and in my rather short time involved in the recovery community, I have found faith and humanity again. I have seen profound displays of strength and courage and will and hope that I would not have witnessed otherwise if I did not have the opportunity for the free education. I have found acceptance in my community again among the brothers and sisters and parents who have lost so much to this disease. Furthermore, the access to free education paired with the passion that drives the affected others, the people in long-term recovery and with lived experience, can be the fuel to the fire that is the recovery movement. Shifting society's perception of addiction is in key fighting this epidemic. To offer financial aid for support for education in recovery fields to Maine citizens with lived experience, including incarcerated individuals and affected others, can aid in community healing, prevention, and societal awareness of addiction and its causes. Connection is the opposite of addiction, and people can make connections through the access of education. I know I did. After enduring my losses, I also had to witness my father suffer as well. He has written a letter, not directed towards the council, but really anyone who listens, who I probably ain't got time to read right now, so I submitted it through the website. And I just really appreciate you guys taking the time to hear me and my mad rants of recovery, but it's all true. And it's all very personal. And yeah, I really glad I had the opportunity to present for you guys. Thank you.
Can you come back for 1 second? Molly?
Sorry.
Thank you.
I'm sorry, Molly. Thank you very much for sharing your story and for being a peer support. You suffered a lot of loss in your family. And I'm going to ask, when you were grieving, were there any support systems for grieving family members who have suffered a loss through overdose?
No.
Would it have been helpful for you to have those support services?
Yes.
Thank you.
Thank you, Mom.
Sorry, I don't mean to put you on blast, but I'm curious, what are your next steps?
So for myself personally, I would love to further my career in the recovery field. I'm very passionate. I'm driven by it. I wake up every day because of the people that I've lost, because I feel like, it's because of their loss, my loss of them, that I try to make every day for them. So continuing my education in the recovery field would be what my dream is. However, I owe 30 grand in student loans, and that's not even that bad. However, it prevents me from furthering more education to become a CADC or an LADC. And it's a huge barrier that I'm facing. And I'm sure a lot of people in Maine are also facing. So maybe using the funds to educate the public for free would be an awesome way to utilize it. Help prevent and help spread the word.
Thank you. I'm proud of you. And if you want to see me after, I can maybe help you navigate some of that.
Awesome. Thank you very much. Any other
Thank you.
questions?
Thanks, Mom.
Thank you.
So Leslie is up and then Jason Barber, I think it is, Boubier is on deck. Hey, Leslie, thank you.
Hi, it's good to be here. Good afternoon, Chairperson and council members. My name is Leslie Clark. I am a person in long-term recovery. I'm a resident of Portland in Cumberland County, and I serve as the executive director of the Portland Recovery Community Center, the PRCC. PRCC operates a center in Portland that serves almost 7,000 people who are in recovery or seeking recovery through a large variety of support groups, recovery coaching, and telephone recovery support, as well as pro-social events and opportunities to connect with others and build positive community. Our center also works outside the walls. We work in all 5 facilities of the Department of Corrections, helping bring recovery programs there. And we operate the Pathways of Hope, which helps people connect immediately to residential treatment and other recovery services. We service Maine's Recovery Hub, helping start recovery community centers in now 19 different areas of Maine, with a vision that every local community will have a recovery community center. And I want to say that I just think Amy Clark did such a beautiful job earlier of talking about the importance of the recovery community centers. And I was doing some back of the envelope math as I was sitting and listening today. And my calculation is that our center is open from 7 a.m. till 8 o'clock at night, 7 days a week. Someone can come and participate, receive coaching, go to meetings, do karaoke night, find a whole new community and way of being and purpose among peers for the cost of under $130 a year per person, not per visit, per person. These are really critical and they're a really good bang on the buck. We also had the value of almost $500,000 in volunteer services. Volunteers are the heart of what we do. We know too well the ravages of the opioid epidemic, which has really become an epidemic of fentanyl and impacted thousands of people we love and have lost. The problem is horrific and the need is urgent. The first call I got this morning as I was driving up here was from one of my staff members who I couldn't understand because she was crying, and she was calling to tell me someone loved in our community passed away and was found in her car yesterday of an overdose. As we've sat here this morning and listened to all this important testimony, about 46 people have died in our country of an overdose. So I am grateful for this council, and I also am hopeful that in the urgency of this need, the money will go to where it is most needed. The mission for the council is clear: to prevent the deaths and sufferings of those most impacted, to support people in finding treatment and sustaining recovery, and prevent the next generation from becoming harmed by these poisonous substances. I'm going to go just a little bit off script because the question earlier, and I'm going to talk fast, about the continuum of care. So what we see at the center, and I think it was such a good point about how recovery residences are suddenly or not suddenly, but are often being called upon to serve a need for part of the continuum of care that is missing, which is residential treatment. So often people are coming to our centers after they get out of treatment, after incarceration, but many times we're the first stop and they really need a higher level of care. So the need for this continuum of detox, whether that's medically supervised withdrawal or social programs, residential treatment, and then connections, IOP, behavioral health, those kinds of things are really critical. I'm going to jump ahead, and my testimony talks about some other areas that I think are the most critical need, but nobody has talked about this. And I told staff and others, and it's a personal passion, I would bring it before you, is dental replacement of teeth. To see so many young people, like people who are 30 and their teeth are destroyed and they're in recovery, and not only the impact on overall health, which we all know, but the ability to find a job and to move forward and self-esteem and socially. I hope that maybe there'd be a little carve out somewhere in here to help people have teeth. Every day I'm blessed to see people recover, hundreds, thousands of people in my own recovery journey. I know have seen thousands of people recover, my own family members, myself included. We are living with 3 decades now of a drug epidemic that was created by pharmaceutical companies with insatiable greed. And I hope that this funding will really go to impact and remediate, and restore the lives of people who've been most impacted. And shout out to Marshall Mercer, especially our people who are in the most marginalized communities. Thank you for hearing me, and I'm happy to take questions.
Absolutely. Thank you. Questions, Leslie, thank you for the work that you do and thank you for the Portland Recovery Center and the work that it brings to that community.
Thank you.
I truly are a joy to have around. Thank you. Jason is up, and then on deck, I think it's an Adam Burke.
Chair Kimball and esteemed members of the Maine Recovery Council, thank you for the opportunity to address you today, and thank you for your work on this committee. I'm Dr. Jason Boubier, a genetics researcher and resident of Ellsworth. I'm part of the Center for Addiction Biology at the Jackson Laboratory, and I'm a proud graduate of the University of Maine at Farmington. Go Beavers. I'm here to discuss the clinical importance of distributing the funds for the opioid settlement in the state strategy to support basic research into preventing and reversing opioid overdose. The Center for Addiction Biology investigates the biological basis of addiction. Research has shown that substance use disorders have a heritable or genetic component. At JAX, we have used mouse studies of addiction to show that it is a disease with genetic and environmental causes, not a moral failing. Our work is focused on two fronts: research to help spread the speed and development of new pharmaceutical targets to prevent SUDs, and research into opioid overdose, identifying the identification of the next generation of reversal agents. I believe the latter, the basic research focused on the overdose reversal, represents the greatest and most immediate need for state support under the settlement funds. Narcan, the opioid agonist, has saved thousands of lives in Maine. It's a godsend by reversing opioid overdoses. But we are currently faced with patients or journeyers who are overdosing from more ultra-potent synthetic opioids such as fentanyl, often mixed with drugs such as xylazine, this trank phenomenon that's spreading across the nation, which makes fentanyl even deadlier and not reversible by Narcan. Xylazine works through an alpha-2 receptor, and it's a very different mechanism. There are no reversal agents that are available in humans for xylazine because it's a veterinary anesthetic. Establishing a laboratory-based rapid analysis program may help Maine stay ahead of the trends and begin developing or identifying combination reversal agents or new agents to combat this epidemic in real time, not dependent on the NIH funding cycles, which can stretch from up to 1 year from initial funding application if a grant is awarded. The xylazine thing and trank came out of the blue to NIDA, the National Institute of Drug Abuse. I'm pulling together grants to try to study that. However, it's going to be at least a year before any money ever shows up for me to even begin pilot studies. I'm leading federally funded research programs into discovering alternative interventions for opioid overdose, targeting symptoms that Narcan does not alleviate. Narcan is great for the opioid-induced respiratory depression that people suffer, but it does not target the wooden chest syndrome or the laryngeal spasms, the closing up of the larynx that people have due to fentanyl. Despite the availability of federal funds, there are important and strategic roles for state support of competitive addiction research. For example, the state could designate funds to equip laboratories to support this disease research, facilitate faculty positions at state institutions to bring greater workforce development, education, and research to the state, and support or pilot high-risk studies that the National Institute of Health would not support. The state could incentivize research by funding Maine graduate students working in substance use laboratories. Since federal funding must meet national needs, state research funding can be customized to respond more directly to the local challenges and issues specific to Maine's local populations. In addition to funding critical laboratory studies with the potential for human translation, research has an underappreciated role in growing Maine's innovative workforce and economy. Maine has a growing life science economy of over 10,000 workers, including 1,700 at the Jackson Lab. Investment from opioid settlement would have a major impact on our cutting-edge research programs and our ability to train the next generation of addiction scientists. While I support the use of the funds for all of the amazing programs I've heard about today, I believe that given the resources, we will also be able to strengthen our ability to respond to the epidemic and identify novel therapeutics to combat the new opioids and the cocktail drugs sweeping our state. I'd be happy to answer any questions.
Thank you.
Thank you, Dr. Bouvier. It's nice to see you again, and thank you for everything that you do up there and the other teams. Jackson Lab is truly an international and national treasure that we're fortunate to host in Maine. I guess my question will be kind of general, and you've addressed it some about the role of the NIH, the role of other states, but it does strike me that the quality of the research that you do, supported by NIH largely, whatever we could do, you know, given the other needs we have, would be so minor in comparison that can you convince me in a couple sentences here? What could, I mean, we'd all love to help the lab.
Yes,
But is there something we could do uniquely that would make a difference? That's my question.
A flex event machine, which would cost about $75,000, would allow us to do research on the respiratory mechanics in response to opioid response. I currently have a grant, which I need to do that. We don't have the equipment, so I had to collaborate with somebody out of state at Case Western. So $150,000 a year of grant money is going to another state because I don't have the equipment to do the experiments that I could have done in-house and employed somebody at Jack's.
Great example. Thank you.
Yes.
Thank you, Dr. Bouvier. So you just referenced $75,000. What's the range of investment that you are envisioning for investing in this type of research? From the Recovery Council specifically.
Yeah, it would be monies like that, or a graduate assistantship is like a $50,000 assistantship with the University of Maine to help a student be in the PhD program there. And if it was, funded each year and be known as the addiction fund, the addiction, earmarked grant that would for funding the next generation of addiction researchers. And so that's the kind of money that we have. And I can provide you with a variety of different levels of funding opportunities.
Great. Thank you very much for bringing the importance of research to the committee. Thank you. Thank you. Adam Burke, and then on deck is Molly Lewison from Pine Tree Institute.
Great. Good afternoon, everyone. My name is Adam Burke. Thank you for the opportunity to speak and all the deep listening that you're doing today and holding so much always. I'm the executive director in New England for the Peter Alfond Foundation. The foundation is focused on strengthening communities by promoting meaningful, positive, and direct impact, particularly in wellness. Previously, I've been a homeless youth outreach worker and a case manager on an ACT team for individuals with co-occurring disorders. My home office is in Portland, but I work statewide. And over the past year and a half, we've been learning at the foundation how we might effectively support young people and communities across Maine in the current context that we're living. Our hope is to change concerning trends like those that are highlighted in the Maine Integrated Youth Health Survey data. And in my time, I'd like to make and highlight connections between what we've learned in the Principle 3 for your use of funds investing in youth prevention. We've learned through dozens of conversations with other funders, school leaders, public health leaders, community leaders, and importantly, young people themselves. We've also read countless pages of related research. Based on that learning, we've begun a 3-year effort to help young people thrive through positive childhood experiences that foster mattering and belonging for all middle and high school aged youth. We're focused on building the capacity of innovative community-based youth development organizations, as well as building the youth development field in Maine as a whole. This builds on and complements the work of other foundations like the Rural Futures Fund, Bingham Program, MEHAF, John T. Gorman Foundation, and others. Our view is that innovative community-based youth development organizations are both good prevention and a safety net. Young people are building positive senses of themselves and their community there, as well as a wide array of skills to help them navigate life. And also just consider where else do vulnerable young people go when home or school isn't meeting their needs. They go to places like the Landing Place in Rockland, Midcoast Youth Center in Bath, Tree Street Youth in Lewiston, the Game Loft in Belfast, Rivers and Roads in Oxford County, Hardy Roots in Lincoln, and others that provide relationships, environments, engagement, and emotional support, including non-clinical mental health support and social emotional skills that unto themselves comprise positive childhood experiences. Those are protective factors against substance use. It's in programs like these that youth have told me that the adults listen and help them in ways that they've asked to be helped. These aren't just programs that adults believe are a good idea. Promisingly, research indicates the effect of positive childhood experiences may be greater than adverse ones. One summary is that the absence of positive childhood experiences may be more detrimental than the presence of adverse childhood experiences. And that's optimistic. We can work to ensure positive experiences and thus productive factors are prevalent for Maine's youth. The Peter Alfond Foundation's made 3-year commitments to Tree Street Youth, Out Maine, and Rural Youth Institute as field building partners. They're going to provide mentorship, technical assistance, and training to our other 25 grantees all around the state, including those mentioned above and many others. These are organizations that are sophisticated and going beyond basic after-school and out-of-school programs. And over the next 3 years, the Peter Alfond Foundation will invest approximately $6 million into this work, and more is needed to support these organizations, as well as to support the growth of efforts in communities where there isn't such work happening already. My hope is that you'll see this work is aligned with your strategic plan and funding principles, particularly in youth prevention, and that you'll invest in community-based youth development organizations like those I've mentioned as critical partners in your work. I've heard directly from youth how these organizations save and change lives. So thank you for your time, the opportunity to speak. I'm happy to share more information at any time, and the Peter Alfond Foundation is here to be a partner with you on the council as you explore youth prevention.
Thank you, Adam.
Yeah.
Hi,
Hi.
thanks, Adam, for coming today. I am familiar with many of these organizations that I've seen myself do amazing work. And I'm also just wondering if you have thoughts about how do you see an investment from the Maine Recovery Council? Like, where would you be recommending it be invested in those individual organizations through an umbrella organizations that's supporting them? I guess I just would love to hear a little bit more about your thoughts, if you've thought that through, on how that could be combined with the efforts that you all have at the Alfond Foundation.
Yeah, I appreciate that. I mean, I think the opportunity that I provide is that we have a coordinated effort underway with almost 30 organizations. So if there's a way to leverage what we have set up as a platform to complement the funding we're putting out, I think that could be efficient and effective. I know things like, support to staffing. There's the professional and personal development work that we'll be doing to provide organizations to expand their proficiencies in a lot of different practices that we found to be effective, both in positive childhood experiences and positive youth development. There's evaluation and research work ahead for us. There's a variety of things that it go towards.
Great.
Yeah.
Thank you.
Yeah.
Thank you. Other questions? No,
Okay.
thank you very much for your time. Is it Molly Lewison? And then next I have two people who signed up in the same square, so they maybe wanted to speak together. I don't know. But on deck is Deborah York and Amy Vayu Bellish. So thank you.
Good afternoon, members of the council. My name is Molly Lewison, and I'm the Director of Community Engagement for Pine Tree Institute, a nonprofit in Elliott, Maine, dedicated to building trauma-responsive communities through education and collaboration. I'm also a resident of Biddeford and a child of multi-generational co-occurring substance use and mental health disorders. I've worked with survivors of trauma in York County for the last 8 years, and I really appreciate the opportunity to give comment on the priorities of this council. Maine is fortunate, as you have seen time and again today, to have a community of subject experts with lived experience and providers fighting for resources to help change and save lives. With such a robust community of advocates and providers, I'm here today to encourage the council to consider building recovery-ready communities as a priority area. For the last 4 years, Pine Tree Institute has facilitated the Greater Portsmouth Recovery Coalition, a coordinated response group with over 70 members from across the domains of recovery, from harm reduction to homelessness to recovery housing. With 8 dedicated task forces focusing on everything from employment to service access, the coalition seeks to improve coordination of existing services, to promote collaboration between providers, and increase resources all around. Tangible outcomes have included an increase in treatment beds, access to phones for telehealth treatment, and broad cross-training. The idea of recovery-ready communities and the hope in bringing them to Maine is simple. People don't recover in a vacuum. We know that people struggling with substance use disorder are our friends, our neighbors, our coworkers, our children. We want to build systems of support that make it safe and accessible for people to recover in their home communities. We believe people have the right not just to treatment, but to employment, housing, education, and belonging. And we know that all of these things promote long-term recovery and stability. Research has proved time and again that community resources are a key predictor of success in recovery. The idea is that recovery is bigger than treatment. We want more treatment beds just as much as we want to have employers willing to hire people in recovery, just as much as we want better and reliable transportation to appointments. Research on collective impact in communities also makes it clear that it is important to invest in creating these collaborative structures that provide facilitation and project management. Researchers note that creating and managing collective impact requires a separate organization and staff with a very specific set of skills to serve as the backbone for the entire initiatives. Coordination takes time, and none of the participating organizations has any to spare. The expectation that collaboration can occur without a supporting infrastructure is one of the most frequent reasons why it fails. Alongside the wonderful ideas and initiatives you have heard today and you will hear in the coming months, I ask that the council consider and prioritize funding coalitions to make our communities stronger and give people the best possible chance to recover and thrive. Thank you.
Thank you. Questions? All right, well, thank you very much, Molly. So next I have Deborah York and Amy, it looks like Bellish. Are you speaking together? Are you here? All right. Well, they're not here right now. So next would be Rob Korobkin? Korobkin? He left. We have Sarah Calder. And on deck is Betsy Sweet. My grandson would be very proud of him. He's the baseball player that I'm saying on deck a lot. I'm not a sports grammar. I just watch. Sarah.
Good afternoon. I think it's good afternoon, everyone. I'm Sarah Calder. I'm with Maine Health, and I thank you for the opportunity to speak today. And I would start by saying that it's critical that the Recovery Council make immediate investments that target not opioid use, but other substances, as our communities experience a surge of other illicit drugs like stimulants, and alcohol continues to be the most widely misused substance in Maine. Maine Health has been doing treatment work since 2016, and since that time, it's become clear that Maine needs to work to increase its investment in a full continuum of treatment options, as others have shared with you today, to support the needs of individuals wherever they are in their journey. You have my written testimony. It's very long, so I just want to highlight where we think investments are most needed. I'm proud to say that since fiscal year 23, we've served 2,015 patients with opioid use disorder, but these efforts have been heavily subsidized by our health system to the tune of about $916,000 due to inadequate Maine care reimbursement. So our request to the council is that in order to increase access to these critical foundational services, we would urge you to consider bridging the gap between the current reimbursement and the actual costs of providing care. Due to this chronic underfunding, and as you've heard others mention today, we're particularly challenged to recruit substance use treatment and recovery clinicians and support positions. So we would urge the council to consider investments like loan repayment programs, and for clinicians that serve, and this is the really important piece, a certain percentage of Maine care clients, as well as funding for addiction medicine and psychiatry fellowships. And then as I guess the curse of going later on is that everything's already been said, but you've heard this over and over again today. So Maine Behavioral Health Care, which is part of Maine Health, does not provide residential substance use disorder treatment or medically managed withdrawal, but because of the same chronic underfunding, we have very little, if any, capacity left in the state to meet the needs of patients when they need it. And I think you've heard this over and over again. Time is of the essence. So, if you're waiting even a day, that's one day too long. So we would urge the council to make investments that increase access to these services, and then to consider some innovative solutions like mobile methadone or buprenorphine units, or using existing community paramedicine programs to deliver SUD treatment in the community. And then I have a long list of other suggestions that we have based on the work that we're doing and what our clients, most importantly, are experiencing those gaps. One area that I would really love to highlight, and I would welcome you all to come tour it, is the state's only recuperative care center. This is a partnership between Maine Health, Greater Portland Health, and Preble Street. And I'm out of time, but it's all here. I'm happy to answer any questions. And thank you for the opportunity today. And thank you. I've just, this has been a really great experience to be here. So thank you.
Thank you, Sarah. Did I speak for? Okay, thank you, Sarah. You talked about addiction medicine, psychiatry fellowships. Maine Health currently has some addiction fellows. Do you know how many they have per year?
I don't. I can get that for you.
And I'm wondering, two questions on that is, how much would it cost to fund an additional addiction medicine fellowship? And is there a way to have that funding go to a physician that will guarantee they stay in Maine for so many years?
Yeah, I can get that information for you. We have the Maine Track program, which is a partnership between Maine Medical Center and Tufts University. This is for medical students. That's a scholarship program where we don't have a commitment to stay in Maine, but we find that people do. And we find that if you do your residency or your fellowship in Maine or in the state, that you'll stay in the state. So happy to get that information for you, and just email
Just send it to the general email, and we will make sure it gets to all the council members.
Can definitely do that.
Sarah.
Hi, how are you?
Just to give you some time back, can you talk us? You can hear me. Could you talk more about the recoupment center since you ran it?
Yes, sure. I'd be happy to. This program has cared for 112 individuals since it started last year. And these are individuals that don't have stable housing. They may be unhoused. They've been hospitalized at Maine Medical Center, but they no longer need hospital level of care. So I pulled some data. 60% of the folks that have received care at the center have received medications for substance use disorder. So a lot of times these individuals could have an infection caused from their IV drug use, and it's not safe for them to return to a shelter. And so this is a place where they can go and they can receive those wraparound services that they need. And I'm really proud to share that 33% of those 112 individuals have exited homelessness. And for the hospital, we've been able to save over about 2,700 avoidable bed days, which is so important when all of our hospitals are at capacity, because that means that patients can get the care that they need, that acute level of care that they need, and that you don't have those long waits in the emergency department waiting for that care.
Thank you.
Thanks.
Hi, thanks for speaking today. I was wondering if you can follow up with information if you have it. I was just curious about how private insurance covers a portion of the cost for Maine Health and the comparable ones to Maine Care, and whether or not uninsured individuals are included in those total costs as well.
Yeah, specific to substance use.
Yeah.
Yes.
The comparable percentages of.
And I think it's across the board that all payers need to, and especially our commercial payers, need to recognize the importance of behavioral health and substance use disorder treatment and adequately reimburse for that care. So happy to get that info.
Thank you. Any other questions?
I would say on the substance use piece, also looking at the infections and the cost of all of that too.
Okay, thank you all for your time.
All right. Well, thank you very much for that, Betsy. And then Alicia Melnick from the city of Portland is on deck. Hey, Betsy.
Good afternoon, and thank you so much for this opportunity, but also for all the work you're doing. This has been a morning of heartbreak and heroism and hope. And you on this council have the opportunity to fuel both help and hope. So thank you so much for your work. I am from Hallowell, Maine, and I'm representing the Behavioral Health Community Collaborative. You have I submitted my testimony. I won't go through all the introduction, but I want to talk about a few upstream issues. If you just heard poignantly from someone a few people ago, a mom who has lived experience. 20% of Mainers who live with serious and persistent mental health issues have a co-occurring substance use disorder. For this large population, the underlying issues and the road to recovery must address both of these problems. This is true both for individuals and also for our systems of prevention and recovery. At the same time, which you also heard about today, there are many people with undiagnosed and or untreated mental illness who self-medicate with substances when they're able to get services. When it comes to accessing mental health services for either a co-occurring disorder or an untreated illness, Maine is in a crisis. We have the structure of an effective community mental health system. Our greatest need is not for new programs or new ideas, but for the resources and structural support for the services we have in place. Let me give you a few particularly relevant examples. Med management. Med management is a service that is foundational for people, many people, to stay integrated into their communities and living the lives of many of our friends and neighbors. Right now, there's a 4 to 6 month wait, depending on where you live, to even see a prescriber, let alone regardless of how urgent the need. Crisis services. We have an evolving, robust system of crisis system in Maine. 988, the crisis line, mobile crisis response teams, but in only 8 districts, crisis units or crisis receiving center in Portland, and the Peer Warm line. All of these are 24/7 services. Many of those serve people with co-occurring disorders. The problem is that once you are assessed by a crisis mobile crisis team, we have less than 100 mobile crisis workers across the state. Well, we have over 2,500 law enforcement officers, and law enforcement will tell you that 30 to 40% of their work is to a substance use disorder or mental health call. It is unfair to ask our law enforcement officers to be the mental health and substance use disorder treatment providers. We must do something about this. And prevention. You all know that the opposite of addiction is connection. The ability to establish and maintain meaningful connections and belonging with loved ones in our community is directly related to the status of our mental health. People who are struggling or who identify that they need assistance early on do not receive it because we have an access to service crisis. Regular outpatient therapy, you can count on a 6 to 8 month waiting list to get in to see anyone. You at this council have a significant source of funding over 20 years to make a difference here. We ask you to focus upstream and connect the dots between robust, accessible mental health services and the prevention of SUD. Please direct some of this money to foundational mental health services that have the capacity to prevent people from becoming another casualty in a system whose focus has too long been on treating this crisis as a criminal issue and treating it at the end of the problem, and not enough time or money treating it as a public health crisis rooted in the lack of access to foundational quality mental health services. I thank you for your time and attention.
Questions? Okay.
Thank you very much. Yeah, sure.
Question, and Lydia might be able to. So today we've heard a lot of.
Jim can't hear you, sorry.
So we've heard a lot today about the employment crisis,
Yes.
Lack of professionals. Do you know how many prescribers are Maine psychiatrists or NPs?
Yeah, we have less than 300 psychiatrists in the state of Maine, and we have not hired new I think the statistic that I heard, this is probably a year old now, was that we have hired 4 new psychiatrists in this state in the last 5 years. The same is true for social workers. We are losing social workers. We are losing clinicians to other states because of our rate of reimbursement. And if you talk to the people who work in our universities and who teach in our social work programs and clinical programs, those graduate students are not staying here, not because they don't want to live in Maine, not because they don't love the state of Maine, but because they cannot afford to work here. So we have the option to do, one is student loan forgiveness. You've heard that. Another one is to help with sign-on bonuses. And another is to develop a long-term recruitment plan and workforce development plan specifically for behavioral health. Massachusetts just laid out a blueprint for theirs. It is very, very effective, or very, very inspiring, and I think can provide a blueprint for us. We have some efforts, and the state is trying. I don't want to dismiss the efforts that are being made, but it is not global and not comprehensive. And so I think that, when we talk about residential beds, particularly mental health, but it's true in SUD, we have beds. We don't need more beds. I have my people in the collaborative, we have hundreds of empty beds that we cannot fill because, not because there's not waiting lists, there are huge waiting lists. We do not have the staff to serve them. And I just want to say that a friend of mine worked in a mobile crisis unit for 4 months. And it was so hard and emotionally hard. And she left to go work at Home Depot, where they were paying her $4.50 more per hour than she was making as a mobile crisis worker. I know you know this. I think we have to look at both short-term, immediate things that we can do, and we have to look at the long-term plan to augment this field and make it something that people do not have to live on food stamps and welfare in order to do the work that they are passionate about. Thank you.
Correct. Thank you.
Hi, thank you for your time. I'm wondering if we're thinking about upstream with young people and their behavioral health needs, which are great. I'm wondering if you could provide some ideas of where you think in the sort of missing tiered system of support for young people and their behavioral health services, where would you prioritize some of those efforts to improve what we have for young people?
Awesome. Great question. Thank you. I think that we have got to greatly augment our school-based systems of care. And I think here's the thing that I think is really true for across the continuum. There's I want to say dangerous, that's probably too dramatic, trend of schools, law enforcement, all hiring and creating their own health or their own mental health systems. What we need to do is have partnerships with the existing mental health providers and services, because A, it's more efficient, but B, many of the people and particularly police departments who are now moving heavily to hire their own social workers at 2 and 3 times the pay that any mental health provider can provide. But what happens is those folks, and it's awesome, and we all support that partnership, but when they're hired specifically by an individual department, that person then has no clinical supervision, they have no support, they have no way to be, supported by their colleagues who understand and, know about these, know about how to treat people with mental health and substance use disorder. So I would say school-based programs, with the caveat that it be through and with our agencies and our incredible network of community-based agencies that help. I think that's a prioritization. Priority. I'm sorry.
Representative Kraft, and then Miles.
Well,
Do you need this one?
I just wanted to comment to Joe's question about psychiatry, because not only is it wait list, it's not even accepting referrals. So I ran into a pediatrician in Newcastle just yesterday, and she said, who are you referring people to? Because when I call psychiatrists, they won't even accept a referral. So I think that investment in that upstream, those basic foundations are crucial for, across age demographics.
And I also am a counselor on my own. I have another I have 2 jobs. And I had a client who had gone successfully through opioid addiction recovery and then broke his leg, went to the hospital, begged them to not give him opioids. They did not. I mean, they did. Anyway, told him there were no other choices. And then when he left the hospital, he had no backup plan, no support, no transition, tried to get into medication-assisted treatment, was told there was a 4-month wait, and ended up back in addiction, and is now struggling mightily with his family to try and get back into recovery. But this is, and again, that was a lack of access preventable problem. Sorry.
Thank you. When you say 100 beds, what kind of beds and where?
Thank you. All over. Yeah, thank you. Not SUD beds. But I mean, we have, I know the kids piece up in Ellsworth that serves the northern part of the state has over 100 beds, I believe, that are empty. I know that in Augusta County, they have empty beds. And then I think all over, I mean, I don't know the exact numbers. We can get you those, but I mean, the issue is not enough beds. And my friends at Maine Behavioral Health, we talk about this all the time. It's not that we need more beds. It's we need beds that are staffed, so, but we can get you a list of all the beds for both children and adults.
But that's not SUD or OUD beds,
No, these are, I'm talking about mental health
mental health
beds. Yeah.
beds. Got it.
Any other questions? Thank you very much. Oh, well, Courtney?
I was just gonna say, never mind. Never mind. I'm tired.
Okay, thank you very, very much.
All right, thank you. Alicia, and then a Catherine, I think it's Ramson from the Recovery Friendly Workplace. Hi, Alicia.
Good afternoon. Thank you all for being here and for your incredible patience and attention. It's been wonderful to hear so many incredible people come forward and share their stories and their professional experience. My name is Alicia Melnick. I'm an attorney. I work at Bernstein Scher. And I know many of you from over the years working on this issue in various capacities, but I'm here today on behalf of the city of Portland to just present their testimony that was submitted by Mayor Snyder. On behalf of Portland's Legislative Committee, this is the testimony today. As you're aware, both overdose and mortality rates are on the rise in the US and in Maine. In addition, Maine has the 5th highest rate of opioid overdose deaths per capita. And I'm going to skip this part. To mitigate the effects of overdose and mortality, the city of Portland currently provides the following services: syringe service program where individuals can access harm reduction supplies and education, HIV, HCV testing, vaccinations, and wound care, mobile outreach to individuals experiencing homelessness, patient navigation to connect individuals to shelter and housing, treatment, and other basic needs, naloxone distribution and overdose prevention, recognition, and response training. City of Portland programs addressing substance use disorders currently receive $2.3 million in state and federal grant funding. One of the biggest unmet needs is treatment for people who use drugs. Individuals with opioid addiction in particular face tremendous barriers, as you've heard throughout this morning, to accessing and remaining in treatment. When patients are unsheltered, overcoming these barriers is even more difficult. For these reasons, the Portland Public Health Administrator, Dr. Alfredo Vergara, and the City of Portland Public Health Division identified shelter, outreach, case management, and access to a variety of treatment services as areas where immediate large-scale support and investment are needed. Specific recommendations include improve access to treatment in the places where people who use drugs are and in the form they need. This includes increasing the number of medically supervised detoxification programs and clinics that provide medication for opioid use disorder that accept Maine care. Invest in treatment retention dollars for those engaged in treatment programs, supporting social services and basic needs, peer support, and housing navigation services. Increase funding for syringe service programs across the state, especially in rural areas that currently lack such services. Create continuing education requirements for the healthcare workforce related to harm reduction, stigma reduction, and culturally sensitive supports when working with people who use drugs. Engage those with lived experience when creating programs and interventions meant to serve them. Understand barriers they face when trying to access healthcare and other support services, and invest funds towards addressing these barriers. 6, increase the outreach and case management workforce across the state, as you've just heard, including peer support and those with lived experience, in order to create wraparound services or opportunities for warm handoffs to different services, including harm reduction, behavioral health, and substance use treatment, and basic needs and shelter. These should be seamlessly integrated to minimize barriers to access. And lastly, build primary prevention programs targeting youth. These include investment in school-based programs, last sentence, that focus on working with youth with adverse childhood experiences, known as ACEs, and an increase in the amount of trauma-informed school staff. This may also include investment in substance use prevention staff within local county and state health departments. Thank you for your consideration, Mayor Kate Snyder. And I'll just say personally, I can't imagine anyone in the state isn't an affected person at this point. And I know we all have stories, myself included, and I'm just so grateful to be a part of the discussion. Thank you.
Thank you. I do have a question you can take back to the city.
Okay.
And if anybody is from a municipality here, it's the messages for them. So a portion of the settlement dollars went to the counties and to cities. And one of the challenges we have is how are you spending your money so that we coordinate services, we don't duplicate services, but we spend the money wisely. So if the city can figure out a way to report back to us exactly how and what they're doing with their settlement dollars, that would be very helpful to us here at the council. We're trying to figure out a way. Again, we don't want to duplicate dollars. We want to be able to invest it wisely. And so if you could bring that back to the city, we'd really appreciate knowing how the city is spending that portion of the settlement dollars they're getting.
Yeah, absolutely. I think I would hope that perhaps you all, as this body, could play one of those roles in understanding again how the other portions of these settlement funds are being used, and in addition, the money that's being spent at the state level, just through the general fund and other funding sources, to ensure that again that there are efficiencies and not duplication of services. That seems to be potentially a really key role that you all could play, and I'll be happy to try to make that link.
Thank you very much.
Thanks.
Questions from the council?
We're down to one.
Yeah. I just.
You're down to zero.
I
Is
didn't
that-
do anything.
yeah, it's working. I want to piggyback on what Pat said. I mean, we don't want to duplicate things, and this is just as coming from me, but we also want to leave open the possibility of collaborating and combining those funds, the funds that we have control of and the funds that the municipalities have also.
Yeah, again, I think that makes tremendous sense. This is an opportunity for there to be as much collaboration as possible, so that again, this sort of seamless provision of services happens without there being a waste or duplication. So I really appreciate that, and I think this group has so much skill and so much knowledge. Perhaps one of your future meetings could be focused on understanding how other pots of money are being spent and where those opportunities are.
Thank you.
Thank you so much.
Other questions? Yeah, thank you very much. Catherine, is it Rawson? That's okay. Thank you. And Ryan Page is up next on deck.
Hi, I apologize. I have a toddler, so I chronically sound like this. Good afternoon, members of the Maine Recovery Council. Thank you for your time today. My name is Catherine Rawson. I'm a person in long-term recovery and currently reside in Wyndham. I'm employed through Pine Tree Institute as the statewide business advisor for Maine's Recovery Friendly Workplace program. I'm speaking on behalf of my supervisor, Mark Lefay, who unfortunately could not be here today. Our current statewide operation, administered in partnership with the Portland Recovery Community Center, is supported through grant funding. We provide overall program leadership and common practice framework. However, the center of focus under our model is at the community level, local hubs. The program we've designed and developed features a coalition of hubs across the state that will be crucial as we build capacity to serve employers throughout Maine. Each of these hubs, for example, Lewiston, Auburn, Washington County, Greater Portland, etc., will consist of 2 local resources for employers, a business advisor and a recovery advisor. The local business advisor conducts outreach, onboarding, and provides guidance to workplaces interested in the program. The local recovery advisor, led by PRCC, supports recovery-friendly workplaces with peer services, resource navigation, training, etc. The current Recovery Friendly Workplace grant is modest and only has the capacity to fund the operation at the overall statewide level previously mentioned. The grant is insufficient to support the roles within the local hubs across our vast state. We believe that the mission of local Recovery Friendly Workplace advisors is entirely consistent with and supportive of the stated priorities of the council. The most recent national data shows that 70% of adults with substance use disorder are employed. Without a doubt, the workplace is an important and unique setting to address this issue in Maine. With help from the Recovery Friendly Workplace program, employers can play a crucial role in prevention, support, and connections to care for members of our community. Thank you for your time and service.
Thank you. Questions?
Thank you.
Thank you very much. Just so the council and everyone's aware, we are no longer taking names. So, but we are going to stay here for the full to listen. So there's 12 people left here and we will stay and certainly listen to them, but we're not taking any additional. So we are at the final 12, just so that you know that. So Ryan, is it Paige? Paige. And then Mary, is that like Angela? Oh, no idea.
Yeah. Mary A.
Mary A. That's all we know. She's on deck. Thank you, Ryan.
Hi, esteemed members of the Recovery Council. My name is Ryan Page. I am a person in long-term recovery and the co-founder and chief operating officer for Access Direct Recovery Network. We are a 501c3 nonprofit that helps direct and connect people suffering with substance use disorder to a variety of treatment options and recovery resources, both in Maine and also abroad in other states across the country. It is my opinion, both as a person in recovery from substance use disorder and a person who heads an organization that works to help others that suffer, that the settlement funds need to be used to fund organizations who are already doing the work. With little to no funding, the people that do it because they care. Funding that would provide quicker access to detox, residential treatment for all pathways, rented recovery residences, harm reduction, and the transportation to get to and between these resources. At Access Direct, this is what we do. We take the call whenever it may come. We have a 24/7 phone line. We find the available resources being sought out: detox, residential treatment, sober living. And I lost my spot. And we connect people to those resources and we orchestrate transportation and funding when necessary. We have been able to help hundreds over the past year and a half, utilizing limited funds that we raise, help from community partners, and at times out of our own pocket, investing countless hours in the pursuit of helping others. It's possible that we've helped someone that you know. We have found detox beds for individuals when there were no detox beds available. We have helped people connect to treatment facilities and scholarship options, helped cover transportation costs and secured transportation to and between facilities, and spent countless hours on the phone supporting people who are suffering and their family members. We take calls from not only the individuals that are looking for help and their family members. We also take calls from jails, hospitals, case managers, social workers, options liaisons, detoxes, treatment facilities, police department liaisons, recovery community centers, shelters, you name it. We talk to people to help, and we get calls from everywhere statewide, York to Augusta County. Our call volume continues to grow, as does our network of resources and the need for funding. Funding that will ensure that we can answer calls, find and connect to resources, and establish transportation faster and more efficiently. The people that call us are asking for help to save their lives. We ask that you help us help them. That'd be all.
Ryan, thank you. Questions?
Thank you very much, Ryan. You connect people to different resources. We've heard today that a lot of those resources are lacking.
Yes.
Do you sometimes have to go out of state to find those resources?
Yes. Yes, we do. And that's happened more often than I care to admit, right? It sucks that we can't keep people here, but we are sending people to Virginia, Georgia, South Carolina, New Hampshire, Massachusetts.
And do you transport the patients there?
We have the funds to transport, whether that's via Amtrak, bus, plane when necessary. Locally, we have volunteers that transport in between from wherever they are actively using to detox or to in between detox treatment, residential, sober living. So yes, we do provide transportation already.
Are you based in one place and then do a lot of your work by phone or?
Yeah, so I'm based in my car. I drive. That's where I always am. That's my office. And we take calls, like I said, from across the state, and that's so it's a 24/7 phone line. The phone is always on, so there's always somebody to answer it, and that's really a critical component of what we do, is being able to be there to take that phone call in that very small window of time when somebody is at that breaking point where they're ready to get help. Having somebody to connect that is a peer, that understands, that is supportive, and knows all of the resources that are available. I think we've heard that multiple times today, is the need to have an organization that has all things encompassed, that knows what's available at the time. And that's what we do.
Brian, thank you for what you do. I know you do good work. Does your nonprofit organization have the capacity to follow these individuals that you help access treatment to for a year, 2 years, so that you know out of the last 100 people that you helped, how many are in sustaining their sobriety, so to speak?
So yes, I can have my wife can email all the information about the practices that we use and how we're keeping the data referring to. That's kind of part of what we do as well, is to follow somebody that starts with us, to find out and follow up to make sure that people do not fall through the cracks. So when they go to detox, sometimes I know for me, I go to detox, I get there for a few days and I forget that I had to call somebody to do something else. So to follow up and to make sure that nobody gets left behind.
It'd be great information.
Thank you.
Hi, Ryan.
Hi.
Are you staff or volunteer? And as a follow-up, tell me about how the network of transportation actually happens.
Okay, so staffing for volunteers is what we're working on. This is what we hope to attain funding for. So currently we have a network of people that volunteer with us. And we put out the call to people that have agreed to volunteer with us, right? And that is community partners, people that we know, people that we work with, and typically peers that have experience with substance use disorder. And that is our current model of transportation. And then we fund by reimbursement, gas and tolls, or whatever that might look like, to get a person from said point to said point.
So completely volunteer run.
Completely
Kinda,
volunteer.
excuse my language, but it's 2:00 in the afternoon. So that just kind of like get shit done model.
Get done model.
Oh.
Yeah.
Okay, thanks.
Yeah, I just want to say thank you. I've been on the receiving and the calling end of Access Direct, and you guys do amazing grassroots creative work. It's huge, huge.
Thank you, Miles. I appreciate that.
Yeah, Miles kind of stole my thunder. I just want to thank you. You've helped us dozens of times, and it didn't matter what part of the state you were going to. A lot of people say, "Oh, we're helping folks." Thank you, Randy. Randy's done a bunch of those transports, but
yes.
you know, a lot of folks say they do what they do, and then you find out they really don't do what they say they do.
Yeah.
You guys always deliver, and we're really appreciative. And I know, you know, you've been doing this not for the money, man. You've been doing it because you care, and we really appreciate it. The whole state, the whole recovery community is very thankful for you and your organization.
Thank you, Bruce. I appreciate that. It's a privilege to be able to help. Thank you all for all the work you do. You have your work cut out for you.
Thank you for being and sharing. Thank you. So there's a Mary A from Washington County, I think. If she's not here, then unless it's John Mandarelli. Thank you. And on deck is Rachel Solomon.
Hello, thank you for having me.
You're welcome.
I came in today. I don't even know how I got notice, who sent it to me, and I wasn't expecting this. I seen recovery and I thought it'd come in, and I see now after listening to everybody speak and the momentum that's the state is getting, I feel strongly that God led me here today. Little introduction about myself. I'm a person in long-term recovery. My name is Johnny Mandarelli. I'm also a returning citizen of 7 months now, after serving 20 years, 3 months, and 21 days on a 35, all but 25-year sentence. That sentence was nothing. It was a lot, actually. I remember being before the judge, not breaking any emotion of when he passed down that sentence. The emotion was when the mother got up and said, "You took my boy." It wasn't my first time in prison in the custody of DHS. As a child, 12 years old, I was a ward of the state, in and out of the youth center, skipping school, two loving biological parents, but something rebelled. Addiction. It grabbed onto my life and it would not let go. Excuse the emotion, but it's deep, right? We're talking about people's lives. I am blessed that I didn't OD. I am so blessed. I'm also blessed that my 88-year-old mother is still with us after my release. I found a beautiful woman that is my fiance now. I have a second chance. During the 20 years of incarceration, I was in a supermax cell for a dirty urine test, and I got high risk. I sat in that cell for 14 months, and a little glimmer of self-worth and self-respect came into my life. I asked myself, is this the way? Do I want to live in a prison within a prison? And if I didn't know substances and addiction, I would have never been the person that society said I was. And I believe that. I will try to make this short as possible. I received, while incarcerated, a peer support certification, a degree, associate's degree through UMA. Thank you, UMA. In community corrections, substance abuse, and mental health rehabilitation, as well as mediation and interdisciplinary study. I also became a certified, moved on to be a registered recovery coach with harm restorative justice certificates in harm reduction and mediation. Today, I work for MERN in the Kennebec Project. I also just got hired the other day for Blue Skies Counseling in Waterville. I am blessed. I also own a home, bought and paid for, no mortgage, that I would like to offer to an agency. And as I said, I didn't know any of this, but God put this in my heart. And then today I'm in here. So God does good things in my life. However, the home that I'm proposing needs renovation. I don't believe much, 20, but a 9-to-5 job isn't doing that. I just saved up $8,000. I got re-entered back into society with no credit. I built everything I have, a vehicle and everything, So I would like to fix up that home and offer it to preferably my company, our company, MERN, to run a re-entry sober living house. I know the struggles it is about getting out. And honestly, I miss home. I miss the institution I left. I had a purpose and a passion And it took me a few 5-7 months to bridge the gap from the work I was doing in there, facilitating programs and hepatitis and psychology of incarceration. In Dexter, Maine, where I own the home, is dead center Maine. It's they have a saying, the heart of Maine, and there's no recovery community there. There's no community center where people can go. There's no housing. It's next to Mountain View Correctional Facility. And I know one of the struggles that I see a revolving door in the 20 years I spent. People go to work release, they go to AA meetings, go to church services at Charleston Church. And then they told, you're getting out, you're going back to Massachusetts, you're going back to Portland. I recommend that if we can create funding for recovery centers in housing, and I will offer the house, just need something to, an agency to staff it, but the renovation of that home so it's livable. People from Charleston that get out could live there. It's ideal. It's the heart of Maine. Thank you for your time.
Thank you. So I would thank you very much. And I like whoever sent you here. So that's a good thing. And I would recommend, it's just my recommendation, that there was a gentleman here earlier who runs Fresh Start, Scott Purdy. If you Google him, he can get his number. And I'm sure he would love to have a conversation with you, because one of the areas in his presentation was that there is not a recovery residence or a home in that Piscataquis area. In that whole county. So, but I recommend you just Google Fresh Start, because I don't have his number on hand, but contact him, and I'm sure he would love to have a conversation with you.
Thank you very much.
Any other questions? Thank you very much for coming forward. Thank you.
Yes. Good to see you, Dr. Bruce. Have a good day.
Rachel Solomon, and then an Eric Gerard. Hi, Rachel.
Hi, thank you for giving us all opportunities to speak today. My name is Rachel Solomon. I reside in Wyndham. I work for the Family Restored, a nonprofit organization, but I'm here today representing fellow affected family members of this disease. I know it's been a long day, but I'm here today to testify on behalf of all of those whose voices aren't always heard, who struggle with their own stigmas, isolation, self-doubt, and heartache due to this disease. The national average family size is 3 people, meaning every person with substance use disorder, there's double that in family members suffering from this disease. 11 years ago, I gave my sister a hug goodbye unknowingly for the last time. My sister Cindy died from an overdose in 2012 at the age of 18. She died after years of treatment, detox, sober houses, MAT, absent-based, wilderness programs. My mom was a single mother, and I became the unqualified co-pilot in making decisions about treatment plans for Cindy. We weren't aware of any support services, and we were left to our own devices, which were limited at best. Disagreements between the two of us have left irreversible damage. I knew nothing at the time about SUD and how to best support her or when to draw boundaries. I truly felt like we're the only ones navigating these constant challenges, setbacks, and disappointments. My family's worst nightmare eventually came true. My youngest brother found my sister fatally overdosed in our childhood home. It felt like we had lost a battle. I replayed over and over every mistake I made along the way. I felt completely alone and ashamed from what felt like my own failure, and no one in my family has been the same since. Flash forward 11 years, I've been sober myself now for 9 years, and in that time, I've gained a deep understanding of SUD and the family dynamics that come with it. At the Family Restored, I work with families through services such as support groups, educational workshops, one-on-one support, retreat, and facilitate grief support. I have seen family members gain the knowledge and confidence to better support their loved one's recovery. I've seen family members lean on each other, learn from each other, and share resources. Countless family members have expressed that these services saved and changed their lives. Resources then help them become better recovery allies. And for those who have lost someone, through grief support and holding memorials, families find a place to grieve and connect. If only I knew back then what I know now, I can't help but wonder what would have been different. If only there was more access to family support services, so my mom and I weren't left making guesses on how to help Cindy and feeling helpless through each setback. Family members suffer due to this disease. The overdose rates are all human lives who have left behind countless loved ones in disbelief and heartbreaking grief. I'm here to respectfully urge the council to provide funding for family support services. SUD can impose a substantial financial burden on families. Bereaved families or those who are still trying to support their loved ones deserve easily accessible services at little to no cost. There should be a wider awareness of these types of services, and every person, regardless of their socioeconomic status, should feel supported through this devastating epidemic. And while there are so many important organizations here today with their services, my hope in testifying is that family support is not forgotten while distributing funds. Thank you for your time.
Jill, thank you. And thank you for being that voice for families, because we know there's lack of services and you need support. Families should, and there's many of them out there. There's many people that I worked in this field for a long time, and the most common call that I received was from family members. It wasn't from people who were seeking the help. It was from family members who just felt lost. You should be, families should be supported. Questions from the council, Doctor?
Rachel, thank you. And you've already answered the question, but the last person that came up that had a family member who had died of an overdose, I asked if there was any grief support for the family, and there was not. Yesterday, I had the opportunity to listen to a podcast called The Addiction Files, and where they interviewed a grief support specialist in the state of Utah who specializes in opioid overdose grief support. And it turns out that's the only state in the country that has a program like that. I refer you to that podcast. It's called The Addiction Files. I found it fascinating, and I'm so glad I listened to it before I came here, because I agree with you. That's family support is super important.
And I will say there are organizations working towards providing support services. We've partnered with an organization called the Sun Will Rise out of Massachusetts. SADOD provides national trainings and support. And I think that more access to these things and more awareness, because I feel like when I lost my sister, you're in such disbelief that it should just, these types of services, though there are some, everybody should know about them. Sometimes they feel like a secret that you kind of have to find out about. And when you're in crisis, it's hard to be digging around for resources.
Thank you. Thank you very much.
Thank you for your
Thank
time.
you. Eric, and then on deck is Kelly Cookson.
Hi, thank you so much for your service to the community and for allowing me to speak today. So my name is Eric Gerard. I'm the co-founder and executive director of the Family Restored. And as Rachel said, we're a nonprofit organization based out of Portland, and our mission is to strengthen and support families affected by addiction. Today, I stand before you as a representative of the organization, also as a resident of Cumberland County, and as a person in long-term recovery myself. During my years of active addiction, those closest to me bore the heaviest burden of my actions, and particularly my family. Having grown up in a pretty stable home, actually, my parents were blindsided when they discovered that my experimentation with drugs and alcohol in high school had spiraled into a full-blown substance use disorder. The lying, the stealing, the manipulation, and the consequences of my actions began to stack up, and prompting them to do everything in their power to help regain control over my addiction. Unfortunately, their efforts seemed to only exacerbate the problem. The frustration, the anger, the fear just overwhelmed them, and they desperately tried to intervene, dreading the day that they might receive the phone call that I had been found overdosed. Their sleepless nights and countless hours spent worrying, following me, and attempting to understand my behavior consumed them, causing neglect of their own jobs, friends, and even my siblings. Their unconditional love for me evolved into this unhealthy, enabling, and codependent relationship. My chronic relapse and the cycle of hope and despair left them exhausted and hopeless, and with limited resources at their disposal and a maze of conflicting advice that they found on the internet, my parents really felt alone and lost. Eventually, they stumbled upon a local family support group in another state, actually, where they met families facing situations much like ours. And they gained a better understanding of substance use disorder and learned how to approach me and my addiction in a healthier way. They altered their language, they adjusted their approach, they set boundaries, and refined their support. I truly believe it is because of the changes that they made that I'm able to stand here today, 15 years into my recovery journey. Addiction is a family disease impacting everyone whose lives touches the person who's suffering from SUD. Families should be integrated into the recovery process, and there's mounting evidence that suggests that well-informed and supportive families can significantly enhance a person's journey of recovery. This support leads to improved treatment adherence, reduced feelings of isolation, better treatment outcomes, and reduced risk of relapse. So therefore, I urge the Maine Recovery Council to consider funding organizations like the Family Restored, who dedicate themselves to providing extensive support for affected family members. Services such as family support groups, one-on-one family coaching, educational workshops, and grief support are often overlooked within the community. And families really need a place to turn for fellowship, support, and education to help them cope and navigate their way through a loved one's recovery process. While I did want to emphasize the work that we do with families, because I think there's a great need for that, the Family Restored does do a great amount of work helping those seek recovery as well. We operate a men's recovery home in Portland, and we also operate a scholarship fund that has provided over $1 million in treatment scholarships to over 800 people. The state over the last few years has flooded a bunch of money to support harm reduction and an MOUD, which I totally agree with, and there should be, because overdoses continue to rise, and that's a huge need. We can't help people who aren't alive. But for me personally, after trying many different recovery pathways, I found that a 12-step abstinence-based recovery path was what worked for me. And so I also ask that the council all support all recovery pathways, including that which saved my life. Thank you.
Thank you very much. Questions? No, well, thank you very much for the work you do, and thank you for the suggestions for today.
Yeah, thank you.
Thank you. Kelly Cookson, and then Leanne Lavoie. Is it?
Good afternoon. My name is Kelly Cookson. I'm a resident of Enfield, Maine. I'm also the director at Safe Life Recovery Community Center in Lincoln. We serve a large rural area of Penobscot County. First and foremost, I'm a mother to 3 children, one of whom suffered from substance use disorder that began in the medicine cabinets of her friends' families misusing prescriptions from some of the companies listed in these lawsuits. The public was not well educated or were flat out misled about the dangers at that time. I can't begin to describe to those who haven't experienced something similar what it is like to watch your child slowly dying for years on end and how helpless we feel as loved ones. The pain experienced by my family and countless others make these litigation wins extremely personal. I don't pretend to have all the answers. If any of us did, we wouldn't be here. The needs are so great in my area, I don't know where to start. I almost didn't come today because I had so much difficulty narrowing this testimony down to just a couple of areas. The only reason I chose to come is because despite not having all the answers, I didn't want to see any of this blood money misallocated. I want to see it go to the people and programs that need it the most. What I do know is that Maine has critically low recovery resources and a substantial need. The few services we have are difficult to find. I haven't successfully located many accessible local resources by searching 211, SAMHSA, or the OBH website, and it wasn't for a lack of trying. A lot of the information is missing or inaccurate. The way I receive the scattered information I do about any service near me is from Facebook, calling individual places and asking, which isn't possible if you don't know they exist, and word of mouth. I invite you please to take a moment and do a search of the above listed websites with the link and zip code 04457 at your convenience. What you will see is that almost everything is in Bangor and to the south. The hour ride to Bangor may not seem far for those of us lucky enough to have reliable vehicle and gas money, but without those things, it may as well be in California. If you take the time to call, you'll find as I have there, a lot of the resources listed have inaccuracies. So my first ask is a centralized information center with material that is up to date, user-friendly, and includes data from emergency rooms, police department, laboratories, and autopsies. It needs oversight to ensure it's being done. This would help give us all a better understanding of where to direct resources. Organizations that provide any services should be required to sign up at this one-stop shop and have clear instruction how to do so. My second ask is that an assessment be done by rural addiction and prevention specialists, not by phone or Zoom, people to physically come, look at the landscape, speak with the members of the community, and determine how we can best serve the people who need us. Maybe this has been done recently. If so, please direct me where to find this information. Small recovery centers like Save a Life want to help fill the gaps and do this in a cost-effective way, but we cannot make lasting, impactful change within our community without tools, and knowledge is number one. Save a Life could be more effective in this role if we've taken on, if we had financial resources to support a few full-time staff members, a van to provide mobile services, rides to meetings and groups, and technology support at bare minimum. The families, youth, and individuals affected by substance use disorder have so many needs that are just overwhelming. I've paid for hotel rooms, bought shoes, bought household supplies, coats, given transportation. The list goes on out of my own pocket. And I am not saying this for any praise. Many of the people working on the front lines here to do the same when we ourselves are underpaid, because this is what's needed and it hurts us to see people suffering. My last ask is to not forget the people who have been directly impacted by the irresponsible, shameful greed of these pharmaceutical companies. People who meet the criteria for this lawsuit, which does not include my family, by the way, they deserve to be included. They may not have had the capacity to be included in these lawsuits themselves or the knowledge. They will never be the same if they are still on this earth. Please don't forget about them. Thank you. Does anyone have any questions? They're temperamental things, aren't they?
Hi, I was wondering if I just know this because I know you, but I was wondering if you could talk about how your recovery center is also providing harm reduction in the center. Could you talk about that a little bit?
Yeah, because we saw a lack of services in our area, we decided to, we now have a full syringe service exchange program that we are using within the center during designated times to try to be able to bridge as many gaps as possible. We're also doing prevention work in the high school.
You and your group up in Lincoln should be congratulated. You never gave up hope. You keep like
We're like, but we'll train that.
you are that little phrase, keep moving forward and be admired.
Thank you, Pat. I appreciate that.
Any other questions?
Thank you all for your time. It's really appreciated.
Leanna, and then Charlotte Warren.
Good afternoon, and thank you all for being here. I did submit my letter last night, but I'm going to go a little off. My name is Leanna Lavoie, and I live in Jay, which is in Franklin County, and it borderlines Androscoggin and Oxford counties. This letter does outline my recommendations, which I'm going to jump to in just a minute. But this is based on 25 years in public health, as well as personal experiences with the opioid crisis. So I'm going to skip a few pieces of this and just get to the recommendations, and then also talk a little bit about Franklin County. My recommendations are higher level and more process orientated. My, again, recommendations are capitalize and provide direct funding to existing programs and services that are working. For example, take a portion of the funds for the expansion of recovery centers, which you just heard a little bit about, harm reduction education, syringe service programs, and substance use prevention. Again, a lot of what you've already heard about. A lot of programs are already in existence in the state of Maine that are working real well that could use additional funding through existing channels. Utilize the governor's opioid strategic plan as a driving strategy for funding programs and services. This plan outlines many evidence-based strategies and interventions proven to positively impact the crisis. Funding programs should support this plan and demonstrate how it supports the plan. My third recommendation is to develop equitable funding distribution across the state that not only includes population, but places that have higher drug overdose death rates, as well as other risk factors that include access to services, which you've heard a lot about today, or lack of access to services, and also the rural nature of our state. This is another recommendation, but to review the tobacco settlement process. We've had a settlement. We still have the funding for this, but look at what has worked and what hasn't worked in distributing funds with a tobacco settlement. Last but not least, because this is the core of what I do and what I've done my whole public career, is please commit a certain amount of funding each year focused on prevention. Building on the great work of Maine CDC and a lot of the community coalitions that are doing this work. We've heard a lot today about the destruction of this epidemic. We have to stop the bleeding, but at the same time, we have to get upstream. From Franklin County, these are just what we see. I hear about this every day in the work that I do. Transportation is a huge issue. Mental health, we've heard a lot about that as well. The right care at the right time. I'm not saying anything you haven't heard. And housing. Those are the main things we talk about as a community often. The other thing I wanted to touch on, because I haven't heard the dinger go off, so I'll just keep talking. So Franklin County's opioid settlement funding, we created a subcommittee. The commissioners created a subcommittee. We developed a mini RFP process that aligns with what the funding can be used for, as well as the opioid strategic funding. We have accepted applications through the end of the month, end of October, excuse me. And this committee will be reviewing those applications next week, I believe. So it's I feel like a good process. And we're building on a lot of the work that's being done. And the council has representation from people in recovery and the different sectors, which I think is a great process. So you had asked about that earlier. So I'm on that committee. So if you want more information, I can definitely share that. So, wow, I'm a really fast talker. Any questions?
Leona, what's your last name again?
Lavoy.
Lavoy.
Yeah.
The voice,
Huh?
the voice. Right?
No, Lavoy. Lavoy.
No, in French, it means I believe it's the
Oh.
voice. Sorry.
It is French, but I'm not really French.
Just had a question. Did that committee, did it prioritize anything? Like, did it say, we want to fund detox centers, we want to fund this, we want to fund that? Or was it like
open.
very broad?
It's very broad. It's very open, and it's really based on what the recommendations are on how we can use the funding, and also the opioid strategic plan. And we wanted to keep it simple so that folks in the county could, or it doesn't have to be in the county, but they have to provide services in the county. So there's no, and I haven't seen the applications yet, so it's hard to tell, but we
So it's
wanted to
kinda
keep it open.
I mean, like an open call based on the MOU document of things that you're allowed to spend money on.
Yeah.
Tell us what you want to use this money for.
Exactly. And it has to be based off evidence too.
Right.
Yeah.
Right. Based on the MOU and the settlement document.
Yes. Yep. We do have a dollar amount. So this first round, because it's kind of a pilot project, it was either 72 or 78,000 for this first round of funding that we're going to be giving out.
Each application has to be under that, or you have a total of 78,000?
A total. Yeah.
Right.
A total for this first round.
Because you guys didn't get that much.
Gosh, we have, but this is, again, we're starting off small, see how this process works. It could be, someone might apply for $5,000 for transportation efforts. It could be, I believe one of our, an organization that I wrote a letter of support is applying for recovery coaches, to have more recovery coaches.
I mean, it sounds a lot like the ARPA funding at the county level, that a lot of counties kind of did this open call, ask them people to come back. I just want to thank you guys. I think you might be the only county in Maine that's created a committee with representation of people in recovery to oversee this money. And I just really want to hold
Yeah.
that and congratulate you guys
you.
for taking the initiative to protect this money the way that I believe it should be. So
Yeah.
thank
And
you.
our hope is that this funding will get out in the next couple of months, the first round of the $78,000, and then we'll do another round for the funding. But yeah.
Other questions? Thank you very much.
Thanks for your time. The countdown is beginning, right? Not too many more.
You could, when they say in Washington, you had time to spare, you could pass your time on. Okay, I don't think that one is either. This one's working. All right. Thank you. And next on deck is Holly Stover.
Thank you. Good afternoon, members of the Maine Recovery Council. My name is Charlotte Warren. I live in Hollowell. I'm a social worker, an educator, a policy consultant, a person in recovery, a person who loves many people in active use, and a person who has lost many persons to substance use disorder. First, I want to give you my gratitude. Thank you all for doing this work. I know it's not easy. And thank you for hosting this public hearing today. Secondly, I want to make some requests. Please, as you are making these decisions around funding, please remember why we have these dollars. Remember that Mainers were targeted by pharmaceutical companies. Please remember that our communities have suffered, that our communities are suffering irreparable harm. In addition to the harms created by this deceitful marketing is the harm that has been created by the drug war. Please remember this, and please do not spend a single dollar of these funds on programs that continue the war on drugs. Please hear me. This is blood money. Please hear that. Please also yet let the principles for the use of funds from opioid litigation from Johns Hopkins, which I see on your website, please let that guide you. Those principles are really important. And I know that you are because you have it on your website. So I ask that you pay special attention to Principle 4, which is the focus on racial equity. I won't quote what I've put in my testimony. You'll have time to read that. But when I think about that principle of focusing on racial equity, it brings me back to the place of giving resources to the communities that have been most harmed, right? And we have to think about racial equity there. The criminal justice system has mostly harmed marginalized communities. So please keep that in your mind. But also, when you've heard from so many people that are doing work on a shoestring budget because they are also persons in recovery. They are also family members of persons in recovery, or they have lost family members. Think of those people of having paid a very large price when you think about handing out this money. And my final request, and I do make this request from a place of love for the state of Maine and from a place of love for a lot of Mainers that are in a lot of pain right now. A lot of Mainers, family members, folks who are suffering from substance use disorder, etc. I make this request with the most love. Please pick up the pace. Please get this money out, right? I was still in the legislature when we were doing LD 1722. It was my bill that was talking about this and was still doing it. Can we please pick up the pace? I know it's important to follow a process, but somebody earlier when I was home working and listening, somebody earlier said, you know, when COVID first started, we threw everything out the window because we knew we needed to respond quickly. I ask you to start throwing stuff out the window and get this money into communities. Thank you. Oh, any questions for me?
Thank you. And thank you for all the time you served, for always being an advocate in the legislature. You will be missed. Questions?
Oh,
for
I'll
the
still be
committee?
an advocate.
You'll still be right there.
I'm not going anywhere. But thank you, Pat. I appreciate it.
Any questions? No.
Thank
Thank you
you.
very much. And thank you for the reminders.
Thank you.
Thank you. Representative Stover is next. And then Randy, is it Randy Beard? Thank you. Is on deck.
I first want to start by thanking you all for sitting patiently all day. And if nothing else, to call you first responders. And you have listened attentively. You've gone without lunch. I should have gotten you water and coffee. I didn't, but I mentioned it. For a bag of apples.
The intent was there, Holly.
A
The
bag of
intent was
apples. You've done yeoman's work today and every time you meet. So thank you so much. My name is Holly Stover. And I'm here today as the director of a small nonprofit down in Booth Bay Harbor called the Community Resource Council. And in that council, I serve as the director, but I also, part of my time is split. And I serve as the director of the Addiction Outreach Program, which started 7 years ago under the vision and heart and soul of former Chief Bob Hash. It's been a very successful program for our 4 towns. When you live at the end of a peninsula, people do not come down to you. Oh, and I also, I want to mention that a special thanks to my colleague, Representative Crafts, for being here today. So I serve the 4 towns. Booth Bay is my hometown, so it means a lot to me that I'm working in my community every day. I'm also serve as the state representative for District 48, which also covers Booth Bay Harbor, South Port Edgecombe, West Port Island, South Bristol. I'm a family member of a man who has a 25-year history of substance use disorder that began when he was playing football. And we had a gentleman in town who was a prescriber who was handing out oxys in 90s. That's just for starters when you're 15 years old. His story is long. He and I could probably write a book. We've been to every possible resource. He died several times. He was revived. Every jail. He didn't go to prison, thankfully, and to the bottom. And then it was because of Tim Chaney and Enso Recovery who saved his life. And he is 1.5 years sober. He's taking college classes. And Sheriff Brackett is probably equally as surprised as me, because they were fully expecting that wasn't ever going to happen. So I'm incredibly proud of him. He's also serving as a house manager in the recovery house where he lives. So it does happen. It's miracles happen every day. The addiction program that we have in Booth Bay Harbor provides information, support, and referrals to people seeking recovery and mental health services. It's impossible to tease those 2 things out. It's a collaborative partnership, as I mentioned, with the Booth Bay Harbor Police Department and the Lincoln County Sheriff's Department. And we support our local law enforcement's efforts as first responders. The integration of services and supports to help people with lived experience helps them to feel more connected to our community, not isolated in our community. And when Bob Hash first started this program, he was one of the first to say, we've got to stop arresting our way out of this. Since 2016, we have served over 300 individuals and families in our community. We're not a big town, but we have certainly made a tremendous impact. You know the numbers around deaths. You've been here a long time, but I want to tell you that in 2022, we lost 4 individuals to opiate-related deaths. Additionally, because I don't want us to forget, we also lost 3 people to alcoholism. The people ranged in age from alcoholism, 37 years old, 47 and 52, all local people, all amazing, all the people that we lost. There was one woman who went through just about every service that you've heard from today, touched in some way, including jail and prison and long-term treatment programs and short-term, did everything ever humanly asked and worked really, really hard and was a great mother, tremendous athlete. And when she passed, her parents asked me to be a pallbearer, which sort of put it all in perspective. Never had I done that before to honor her. We continue to work with our partners, Healthy Lincoln County, about Narcan and how to use it effectively. And with alcoholism, we work with the medical community to provide Vivitrol. We've had some limited success, but it still is success. And I wanted to mention, because you talked a lot about harm reduction, the testing strips, fentanyl testing strips, that's a great tool. One of the things I did, and I would give you food for thought, is I took them and I made little kits out of them, and with very simple instructions. If you've ever read the little paper, it's a lot of gobbledygook. I made simple instructions in a baggie and I put it all together, and I went out and I talked to my most popular bartenders on my peninsula, because they actually see people, and I showed them how to use it. I had my little fake kit and they handed them out. And it's just, we did cut out domestic violence training hairdressers for the same reason. They touch heads, they feel bumps and bruises. And training bartenders might be something for you to invest in. It's a very cool thing to do. One of the other things we do, and I'm going to skip through I talk too much, is that we raise our own money. We don't take state or federal money. We do it for a reason, because we can provide services on the ground the way we need to. And one of the most successful components of the program that we've created in Boothby Harbor is we pay for MAT for underinsured and uninsured persons. And I have several people right now who are on Medicare. Everybody thinks this is all young people. Well, these people started back 25 years ago, and now they've aged out and they're on Medicare, and their Medicare plans don't include their Suboxone. And so we're carrying, and not all the people are carrying on Suboxone, but we have other people who don't qualify for Maine Care, and their commercial plan doesn't cover it either. So we're helping people pay for Suboxone. And when I say help, in 2021, we spent $44,000. In 2022, we spent $48,500 on medication for people. And I would encourage you to think about, you'd think that the pharmaceutical industry would kick up a little bit, or there'd be some generic equivalent. There's not, but it's life-saving medication, and they won't take it if they can't buy it. So that's what we do. It's one of our, I'd say not just popular, one of the most effective things we can do. We raise the money and we spend the money. We use wraparound funds. Again, people have mentioned that today. And it's flexible funding. I think many of you may know what it is, but it's flexible funding to pay for things where no other funding exists. But the barrier is there, and it's the glue that holds the recovery plan together. So we can pay for housing, we can pay for your car repair, so you can get to your IOP, so you can get to AA meetings, you can get to work. We work collaboratively with our local YMCA. I know they testified earlier. They provide free memberships to folks who are in early recovery. And it's been a real helpful thing. We work closely with the director as a community collaborative. We work very closely with Maine Health Family Care Center, which is our local provider, with our physicians there, and have since the beginning. We work with Midcoast Hospital Addiction Resource Center, and we have the two folks who work out of the Lincoln County Sheriff's Department who come down on Tuesdays and co-facilitate recovery groups. The most significant barrier I face, I've traveled all over the state with people, and I've traveled out of state. I've gone as far as Tennessee and back in a day, by the way. But the lack of insurance parity is a real barrier. People with commercial insurance can get in more quickly. I could get you in a detox bed tonight with your commercial insurance, not with your Maine Care. And also residential treatment. We're underbedded. Not that anybody wants residential and all residential, but it's true. And we need places for people to go, and they need to be the ability to use Medicaid is a real barrier. But for all insurance, and the lack of parity, I think for 25 years in my career, the lack of parity in commercial insurance and behavioral health is just unmatched, and it hasn't improved very much. In fact, it's gotten worse. So the addiction outreach program we provide is a community-based collaborative model. It really works for us because we're small, it's intimate. We believe that integrated community-based services work the best. we don't need to provide all the services. We need to be able to bring in all the people who are able to do the best work. And we have tremendous support, obviously, from our local community to continue to do this because they give us money. We have very generous donors, and I write grants. And I'm not asking you for any money. I'm just saying the things we have learned along the way can really help to point you. But building things on local levels that serve local people work best. I don't want to say my people, but the people in my community don't want to leave. They don't really want to leave a lot of times, but they want to get the services. And they don't mind leaving for a short amount of time, but home is home. And we live in a pretty beautiful place. I don't know if you have any questions, but I stayed all day because I just wanted to especially tell you about people without insurance to pay for medication and general assistance isn't giving you $425 a month ever. But we do.
Thank you, Holly. Questions? Thank you for all that you do and for the years of service that you have and being in the legislature and always making sure our voices are heard. Thank you very much.
Thank you all for what you do.
Thank
This is
you.
dying too.
Thank you, Randy. And we have one final after Randy. And I cannot pronounce this name. And if the person. Yeshia is on deck and he is our last person done. But Randy, you're up.
Hi, everyone. First of all, thank you, Madam Chair and the council for being here. This really means a lot to me. When you look at a person who has substance use disorder, a person who's been incarcerated, a person who's been unhoused, person in recovery, I'm the poster child. My name is Randy Beard. I'm the founder of a Facebook group called Recover Together. I formed it 3 years ago. We now have 3,500 Mainers in it. We have over 200 different groups, professionals, mental health physicians, doctors, lawyers, all with the common goal of helping each other. Our pronouns are we are and us. We have no hate, and it's all about recovery, point blank. I'm a peer navigator for the Church of Safe Injection. If it wasn't for harm reduction, I wouldn't be standing here today. I'm 100% sober now, just past 4.5 years, thanks to harm reduction. I'm a residential administrator at the Travis House, a 6-month residential treatment program for men. I absolutely think you all should look into it, and it's under Recovery Housing of Maine. Jeremy Isaac Hiltz runs it. It's a great blueprint for what the state needs, and their Maine Care accepted. I opened a sober house called the Phoenix House. I turned my apartment into a sober house. I don't really charge the guys rent. I just don't want to see them on the streets. If they work, then they do help. I reserve a bed for somebody who needs to get into detox, and there's no detoxes available. I don't care what anybody says. I will keep them at my house until there's a detox available. I'm a person with 20 years of being unhoused, a person with 36 years of substance use disorder. I'm a person who was molested as a young child. I was verbally, mentally, physically abused. I was thrown out at 12 years old. I've been in and out of incarceration my entire life. But now I'm a person who's going to be going for my CADC. I'm going to be doing everything I can to help out. I commit probably 75% of my personal salary to helping out. I am not a nonprofit. I'm umbrellaed under the Church of Safe Injection because I also do peer outreach for them. I go to the front lines. I go to 10 cities. I go to the sweeps. I do everything I can for this community. I work about 20 hours a day. I was at work today and I was watching this, and I drove up here from Auburn. I moved to Auburn because I was living in Windham, and I was asked to move to Auburn to help make a difference there. I now, like I said, I work at the Travis House. I work at the Church of Safe Injection. I run my group. I work with Access Direct Recovery Network. Ryan is he's actually the president of my group because I'm not good to get in front of people, you know. But I put almost 100,000 miles in my car in 2 years. My car's obviously taken a beating. Most of the people on this board know me. Almost everybody who spoke today know me. I'm here for the right reasons, but I can use some help. I'm not gonna lie. And people like me, I grew up on the streets. I don't know how to get that help. I tried to file for nonprofit status. I don't know how to do any of that stuff, but I know I can make a difference. My group can make a difference. I just need help doing it. And I hope you guys can look at groups like mine and help me help people, because I do. You know, you guys can only take my word for it, but some of you guys actually know what I do. And if it wasn't for people like Carrie Morissette and Jesse Harvey, I wouldn't be here. So I'm not going to forget where they pulled me off the streets. And I would appreciate any help you guys could give me.
Thank you.
Thank you. And I'm actually an expert at this. So if you guys have any questions, I'm probably the right person to ask.
Thank you for your heart.
Randy, I have a question. You just mentioned. Am I alive? Okay. You just mentioned, you don't know how to file for a nonprofit status and you're not a nonprofit. I think there's a lot of phenomenal human beings like yourself who also are in that spot. So I guess my question is, would it be helpful if this council got somebody to help groups like yours become nonprofits? I don't know if I'm making sense.
No, you are.
Like technical assistance. There we go. That's the word I was looking for.
And Bruce can probably confer to this, that a lot of people with incarceration, one of the big things of reentry, they technology wise, they're not up to date. You know, the resources, every time I was let out, I had no outgoing package. I was right back to being homeless and on the streets and selling drugs to support my habit. So there was no reentry process. What I've seen since I've gotten sober has been a lot better, you know, but there's a lot of stuff out there that can be done. I help with a meeting called the Pros and Cons. It's people in society who helps convicts who are back out on the street, teach them how to use a cell phone, teach them how to use computers. But I honestly don't know how to do. I mean, Courtney told me to do a spreadsheet one day, and I said, I know how to spread a sheet on my bed, you know. So
for the record, I created the spreadsheet.
Yeah. But the stuff we do in the recovery community is beautiful, you know, and I want you guys all to be part of that, because the way we are going to beat this is if we work together. Plain and simple. There's no other ways about it, you know. And right now the big rivalry is between recovery and harm reduction. And harm reduction saves lives. If I can employ you guys to do anything, do some research on safe consumption sites up in British Columbia. Do some research on harm reduction. I tried to warn the state of Maine about xylazine almost 2.5 years ago. And I mean, our amputations are up 40% because of that. Mm-hmm. You know, I seriously know drugs. I hate to say it, but I know what the people on the streets are going through. I'm there constantly. I'll stop. I'm sorry. I'm just very passionate about this, though.
I hear that, but thank you very much. Any other questions? Thank you, and we'll take your advice on the research. Thank you. Thank you. Thank you for coming and sharing your day.
My proposal is a little different. Distinguished members of the council, my name is Yeshua Adonai, and I'd like to thank you for the opportunity to testify today. I'm a proud resident of Mid-Coast, Maine, I'm a U.S. Marine Staff Sergeant, combat veteran, and a former U.S. diplomat standing before you, as a living testimony to the healing power of breakthrough therapies like MDMA and psilocybin and overcoming the trauma associated with military service. Amid an unprecedented mental health and addiction crisis, I urge the council to consider investing in research and infrastructure development of transformative and powerful alternative treatments. Following my 8 years serving our nation, I struggled with treatment-resistant depression, severe anxiety, and complex PTSD. It has been a challenging journey reintegrating into society. I've been divorced, homeless, bankrupt, just to name a few. For many years, I hated myself, feeling hopeless and disoriented. Breakthrough therapies saved my life. Unfortunately, my story is far from the outlier. As some of you may be aware, our country is experiencing a veteran suicide crisis, where recent studies suggest that up to 40 veterans take their own lives each day. Our response to this crisis is clearly not working, as far too many find themselves unresponsive to antidepressants, SSRIs, and the handful of pills we are given by the VA upon diagnosis. In the midst of this crisis, alternative therapies have shown tremendous promise to treat PTSD and its related comorbidities. Indeed, the clinical data produced by world-renowned research institutions has thus far been so promising that the FDA granted MDMA and psilocybin its coveted breakthrough therapy designation, indicated as equally, if not more effective as currently available treatments. However, outdated laws and regulations have made access here at home tremendously difficult for our vets. As a result, countless veterans are traveling to Central and South America, or worse, risking criminal punishment here at home to receive the mental health care treatment they need. I'll say that again. American veterans that have risked their lives for our country are seeking effective mental health cases in other countries. Members of the council, I believe, and I hope you do too, that our servicemen and women deserve better. Our state finds itself at a unique crossroads. Our communities, like so many others in America, have been devastated by the opioid epidemic. Breakthrough therapies like psilocybin and future breakthrough therapies like ibogaine treatment are showing promising early efficacy as addressing not just PTSD and traumatic brain injury, but pending opioid use disorder and withdrawal symptoms. We owe it to our veterans and every member of the community who has been affected by the surge of the opioid epidemic to turn every stone in the search for effective solutions. Members of the commission, I urge you to take bold, brave action by leveraging our historic opioid settlement funds to invest in the research and development of promising new therapies like psilocybin-assisted therapy and ibogaine treatment. Current available treatments have their place, but our communities are in desperate need of a breakthrough. Thank you for your time and consideration. I'm happy to take any questions.
Thank you. Questions?
Thank you very much. I was just at a dinner last night and was talking to someone else. I have a background in emergency medicine. I've really been interested in the literature on mostly in psilocybin and ketamine that I've been looking at. But I'm not aware of any good research using ketamine in the emergency departments for treatment-resistant depression. And I think would be an opening because of the huge backlogs of patients with mental health that are being held in the emergency department. Are you aware of any research that's being done on that?
Not emergency departments, but working with ketamine clinics. The coalition I'm part of, we have 4 different states have secured $12.2 million, and the ketamine clinics are our partners for working with those with addiction. And then the state of Kentucky, similar council of yourself, they are considering allocating 5% of their budget for ibogaine research, and then ketamine clinics are kind of on the side of that initiative as well. Yeah.
I want to thank you particularly for speaking on behalf of veterans. I don't think anyone here spoke today in regards to the veterans, and we do know that they are in need of services, and certainly have earned that by protecting us in so many ways. We should be returning that when they come and return here. We should be giving them the help they deserve. Thank you very much. Thank you.
Thank you.
So I have to share for those who are listening in, who sat in and listened in, and for those the few that have remained here, absolutely thank you very much for that. I think if I count it right, we went through 58 testimonies today, as well as those that are that we have collected off our website. And it certainly has given us a lot of that missing research piece, so we can move move this engine forward. And again, I know that we have hired some people to help us get that process moving all the faster. So we are very much moving that train in a more rapid pace. But again, 58 testimonies today, 58 wonderful things. Again, we are still remaining to take testimony. So if you have testimony that you want to share with us, our websites are listed out front, as well as our email address, and we listen to those on a regular basis. Remember that all of our meetings are public, and we welcome you to listen in or come to the actual site. Our survey is still out there. Our survey, you can still complete the survey, which is in 4 or 5 different languages until 5 today.
It got lost within the realm of this.
Oh, okay.
We sent it out again and it's in 7 languages.
Oh, in 7. Okay. So I don't know who has the power to do that, but we'll just leave it open. There we go. Anyone listening in, it's going to be left open over the weekend. I absolutely thank the members of this council for sitting here so diligently and spending their day. They all have, I thank you very much for your patience, your absolute questions, and have a good end of the day. Drive home safe, and thank you very much.